Okay, thanks. Good morning, everybody. I'm Adam Top. I'm the Chief Executive Officer of Shared Health. Going to begin today by acknowledging that health services across Manitoba are provided in facilities located on the original lands of First Nations, Inuit, and the homeland of the Métis Nation. Manitoba health authorities respect the First Nations treaties were made on these territories, acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit, and the Métis people in the spirit of reconciliation. I'm happy to be here with you today for the kickoff of BugDay 2022. It's the largest interdisciplinary accredited education day in the province, and today we welcome more than 2,300 participants from across Manitoba and many other Canadian provinces. I want to acknowledge and thank each of you and your various teams for your ongoing expertise and professionalism, particularly through the challenging times that we've just been through the pandemic. Our understanding and appreciation is for those who work in the field of infection and prevention control has certainly grown over the last few years. And I'll be pleased to turn things over shortly to someone whose expert guidance and leadership has been vital to our efforts in Manitoba. Dr. Embo is a specialist in internal medicine and infectious diseases. He's currently the medical lead for infection prevention control for the Winnipeg Regional Health Authority and a professor of medicine at the University of Manitoba, and has served as the infection control medical lead for our province during COVID-19. John's the driving force behind BugDay and bringing together experts in this field each year. And thanks, John, to you and your committee for your commitment to this and for organizing another great lineup for today. And over to you.
Thank you very much, Adam. So I'm John Embo, and I'll be your moderator for today. I'd like to welcome everyone to the 26th annual BugDay. 2,300 people registered, as you heard, from Manitoba and other Canadian provinces, and we've got urban, rural, and remote participants. So thank you very much for believing in the program. Before we start, a few housekeeping items. For those who registered online with CPD, please ensure you have checked in and recorded your attendance or in Slido, and it's hashtag bug, all in capital, 2022. This will allow you to download your certificate and claim your continuing professional development credits for attending today's events. Allow about 14 days for your attendance to be appropriately recorded. If you require a certificate or credits and you have not registered with the Department of Continuing Professional Development, please visit the CPD website and register at www.cpd-umanitoba.com. And registration closes at 4 o'clock today, so it's never too late. There's no need to register with CPD if a certificate or credits aren't required. And questions and feedback are submitted through slido.com. Go to slido.com, use the event code hashtag bug2022. Take a moment to complete the welcome poll and demographic information about yourself, as that is valuable for research purposes in terms of who attended and who's actually interested in BugDay. The other thing that I would definitely ask you is, please complete the questionnaire about the program and each speaker and each presentation, because that helps us plan for future BugDays. And we take the comments seriously. And the comments often lead to different topics and unique speakers for future years. You can ask the speaker questions using Slido, and if there are any questions that you observe on Slido, you can vote them up in terms of interest or vote them down if you're not interested. So I'll leave that to you to either vote up or vote down. Again, we need your feedback, and the feedback is very important. One very important thing, one of our speakers had to change their time. So Dr. Jared Bullard, who will be speaking about pediatric COVID vaccination 1 year later, will be speaking at 12:45 to 1 o'clock. And Lane Torgrad will be speaking about germphobia, but he'll be presenting at 2:15 to 2:30. So with that, I'd like to switch gears and introduce Dr. Zulma Rueda, who will be speaking about tuberculosis surveillance and management, looking in the future. Now, Zulma is an expert in the epidemiology of Mycobacterium tuberculosis, as Zulma is a physician and has a PhD in epidemiology. Zulma is originally from Colombia, and her research is focused on latent and active tuberculosis. Her research was focused on latent and active tuberculosis in persons in penal institutions. Currently, she is an associate professor and research chair in sexually transmitted infections at the University of Manitoba. Zulma, over to you.
Thanks, Dr. Embol. Perfect. Can you see my slides?
Perfectly.
Okay, perfect. To start, I would like to thank Dr. Embol for this kind invitation. I feel privileged and honored to be here with you today with such a great speakers and such a great audience. If you have any question, please do not hesitate to send me an email. I'll be happy to answer. And you can follow us in several social media that we have. I would like to start to mention that Dr. Rachel Dwillows has a talk today at 2 p.m. Entitled Update on Tuberculosis Infection and Prevention Therapy. So my presentation won't focus on this particular topic to avoid duplication. I do not have any conflict of interest to declare. And these are the three objectives of my presentation. Review the current tuberculosis guidelines, review the new definitions of tuberculosis states, review the impact of these definitions for program indicators, clinical management, and performance of screening strategies. So this is the outline of my presentation. I will cover these 7 topics. So I will start. So who am I? I'm from Colombia. I'm a clinician. I did my PhD in epidemiology. I work in tuberculosis in prisons since 2009, HIV tuberculosis co-infection, and HIV sexually transmitted co-infections in vulnerable populations. Currently, I'm a Canada researcher, as Dr. Embol mentioned, and I arrived to Winnipeg on December 27, 2020. So let's say that I'm a newcomer. And I started my new position at the University of Manitoba last year. So I arrived in the middle of the lockdown, as we all experienced during this pandemic. So this is me a week before I traveled to Canada, in the middle of the jungle. And this is me after I completed my lockdown. But who is the person behind these titles and these positions? So I'm a cis woman from Colombia, which is located in South America. It's not the US. This country has the 3rd highest biodiversity in the world, which means has a lot of beauty, but we have more than 200 years of violence and internal conflict, which means, in other words, war. The second thing is I experienced poverty and hunger when I was a teenager and when I was studying medicine. I mentioned this and I shared this experience because sometimes when we are healthcare workers providing services to people who are experiencing poverty, sometimes we believe that people have lack of awareness or lack of interest. And what we have is a competing interest. So we need to prioritize. The third thing is I experienced sexual harassment for 24 years, since I was 8 years old until I was 32 years old. And I mention this because in addition to these structural determinants, there are other components that make our lives a bit tougher. The fourth thing is I'm a 1st generation immigrant to Canada. So part of the screening for tuberculosis, I experienced not only reading, also by myself. So as an immigrant, you have to undergo for pre-entry screening for TB. HIV, syphilis, a urine test that today I don't know what was for. Many people says that is for STI, others says that is for drug testing. However, I have no idea what it was. And also I have no idea of what were the results. What we know is if we receive a call, it means from the doctor, it means that any of these tests had a positive result or an altered result. Then when I arrived here, I applied for permanent residency, and as a permanent resident applicant, you need to also undergo, this is for every person that applied for permanent residency, have to undergo for screening for tuberculosis, HIV, syphilis while in Canada. Again, I don't know the results, but on the website you receive this update. This is a real screenshot where it says that you passed the medical exam. But this has another connotation, and is that the baseline cost for applying as a permanent residency is $1,685. That includes the application and the medical testing. But it can go even higher if you need translations of your documents and many other things. So it means it's a very expensive process in already very tight budget for many immigrants that arrive to Canada. So the second component that I want to mention is that traditionally tuberculosis was known as a disease of poverty. And in this case, I want to emphasize that there are structural and social determinants of tuberculosis. So this is a brief definition of what is structural determinants. Those factors that generate or reinforce socioeconomic stratification in the society and which define the differential distribution of risk factors in a given population. So some examples of structural determinants are global socioeconomic inequalities, macroeconomic policies, etc. So I will give you a concrete example. In the y-axis, you have the tuberculosis incidence. It means cases per 100,000 population in 2020. And on the x-axis, you have the GDP per capita. What you can see here is a negative correlation. It means higher incidence of tuberculosis among people who have a very low income, and the TB incidence decrease when people increase their income. So this is this has been demonstrated how poverty increase tuberculosis incidence. And there is something called social determinants, which are all those materials, psychological and behavioral circumstances linked to health and generically indicated as a risk factor in the conventional language of epidemiology. Some examples of this is crowding conditions, food insecurity, malnutrition, co-infections or other comorbidities that the person might have. Again, this is an example. This is the tuberculosis incidence per 100,000 population in 2020. And on the x-axis, we have the prevalence of undernutrition. So 3% of the population, in this case, up to or higher 30% of the population. What we can see here is how when the prevalence of undernutrition increase the incidence of tuberculosis. And there is also, in this study, for example, this is a combination of people who are experiencing homelessness and people who are also diagnosed with HIV. Here we have the percentage of successful TB treatment. This was done in Antioquia, in Colombia. Here we reported more than close to 7,000 people affected by tuberculosis. And the goal is to reach 90% of successful TB treatment. When we stratify or disaggregate it, you can see that people who are experiencing homelessness and are diagnosed with HIV, the dark bars means diagnosis of TB during hospitalization, and the gray bars means outpatient diagnosis. It doesn't matter where the patient is diagnosed. If the person has both HIV and are experiencing homelessness, the percentage of successful TB treatment is 30%, compared to patients with who are HIV negative and are not experiencing homelessness. So these are two concrete examples of how social determinants impact tuberculosis. This is a very recent paper that shows in the center is tuberculosis. So here is to illustrate the contribution of multiple disparities and how those disparities increase the TB risk in individuals. So in this example, disparity A means crowding conditions, which is directly related to poverty. And those crowded conditions translate that if a person if a household contact, one of their family members is diagnosed with tuberculosis, so, and we have crowded conditions, so this person will have higher risk of exposure to TB. So it means it is a vulnerability to infection. In disparity B is access to food, for example, undernutrition. So increase, alter our immune system, and the person is at risk to progress to active TB. And the disparity C means healthcare access. So if we have inadequate or barriers to access to care, the person might have inadequate treatment. So this is just to show how social and structural determinants increase the risk of tuberculosis among people. So you might think, okay, but this is in low and middle income countries. However, poverty is present in Winnipeg, in Manitoba. Yesterday was the International Day of Eradication of Poverty in the world. And I didn't know these numbers, I just saw it yesterday. Poverty is all over Winnipeg. And for me, it was surprising that affects 1 in 8 people, which means 92,000 people in Winnipeg are experiencing poverty. And certain population groups have higher rates of poverty than the population. So includes children, indigenous people, and recent immigrants. And also people of color, people with a disability, a non-binary population, and lone parents, in particular female lone parents, are also more likely to experience poverty. So I want to share this video that is only 2 minutes, that was produced by the National Collaborating Center for Infectious Diseases, which is based at the University of Manitoba. I invite you to follow this website. They produce amazing and very easy for public health and clinicians and healthcare workers about infectious disease.
In 2016, First Nations peoples accounted for over 12% of the Canadian-born cases of tuberculosis, even though they comprise only 2.4% of the population. The TB Journey Determinants Map for Northern First Nations communities is an educational resource for service providers to TB-affected First Nations communities. The map visually depicts key stages in a typical TB patient journey as they move from exposure to treatment completion and the different healthcare-related, social, and First Nations determinants of health. Social determinants of health are the non-medical factors that influence health outcomes. They affect individuals at all stages of the life course and include factors such as income, education, food insecurity, and housing. How do the social determinants of health affect First Nations communities? The history of relocation, the establishment of reserves, and the residential schools era has put the First Nations population at risk of poor health outcomes and contributed to the First Nations TB experience. However, these are not exclusive to the past. The ongoing processes and intergenerational effects of colonization continue to have a systemic influence on First Nations people in Canada today. The following are some of the determinants of health that contribute to the spread of TB in First Nations communities. Employment and income. The WHO has classified tuberculosis as a disease of poverty, and First Nations peoples in Canada experience the highest levels of poverty, with about 25% living under the poverty line. Housing. Inadequate housing on government-sanctioned reserves facilitates the spread of tuberculosis due to poor ventilation and air quality in the home. And approximately 25% of First Nations adults live in overcrowded homes, which is a risk factor for infection and disease. Access to health providers and services. First Nations populations face barriers in access to quality, culturally informed healthcare, service providers, screening, and continued treatment. These may increase the likelihood of developing active tuberculosis. Due to the ongoing ideologies and policies of colonialism, First Nations populations are disproportionately affected by tuberculosis. The TB Journey Determinants Map for Northern First Nations communities represents the importance of social determinants to support the health and well-being of First Nations peoples. In 2000.
So I wanted to mention and give this initial background because, as you saw in the video and in the previous slides, there are social and structural determinants that definitely impact tuberculosis trends. So now I'm going to show a few updates about current tuberculosis trends. So this is the Global Tuberculosis Report from 2021. The 2022 will be released on November. Here, always the 2021 report, the trends or the indicators from the previous year. So in this case, 2020. But I want to start mentioning that this is, these are the two main messages about the impact that COVID-19 pandemic has had on tuberculosis. So WHO mentioned that the COVID-19 pandemic has reversed years of progress in providing essential TB service and reducing tuberculosis disease burden. And the global tuberculosis targets are mostly off track, although there are some countries and some successful stories. So here I want to mention in the y-axis, you have millions of tuberculosis per year. And on the x-axis, you have the years, 2000 until 2020. The green line represents the expected number of tuberculosis cases. So it was expected that there was 9.9 million people falling ill with tuberculosis. However, in 2020, it dropped from 7.1 million in 2019 to 5.8 million in 2020. So definitely is a gap that we have. So this is what we call missing cases. And this is due to diverted resources to address COVID-19 pandemic. There are 8 countries that contribute to high burden of tuberculosis worldwide. And in general, it is known that there are 30 high TB burden countries, mainly located in Africa and in Asia, that contribute to 86% of the global population. This is important to take into account because of what I'm gonna show you later. When we talk about the deaths, tuberculosis deaths, this is the first time that increase the mortality among people affected by tuberculosis since 2005. So there were 1.5 million people that die because of tuberculosis, being the most affected population, people who are co-infected with HIV. 1 out of 3 persons co-infected with HIV died because of TB. And the other thing is that tuberculosis not only impacted, when we compare here, the number of deaths because of HIV/AIDS alone, you can see that in 2020, there were 0.68 million people that died because of HIV/AIDS. And in tuberculosis, there were 1.3 million in people who died who were not HIV positive. So tuberculosis is known to be the killer number, the infectious diseases that kills more people worldwide. However, this was passed by COVID-19 during this pandemic. When we go to Canada, in 2020, there were 1,772 cases. And when we look at the numbers, 73% were in foreign-born individuals, and 18% were Canadian-born, being the majority indigenous peoples. So this is important to take into account because these two groups are at high risk of progressing and being impacted by tuberculosis. I want to share this table that reports tuberculosis incidence rates and case counts by origin and year between 2007 and 2017. And here you can see the blue rectangles are the total number of cases of tuberculosis among Canadian-born non-Indigenous people, foreign-born people, and Canadian-born Indigenous. You can see that the majority of cases are among foreign-born people. However, when we look at the rates, you can see that the rates among Canadian-born non-Indigenous people achieve the NTB goal strategy. So, which is less than 1 case per 100,000 population. So in this case, we achieved that. However, in foreign-born people, you can see that is 14 cases per 100,000. And in Canadian-born Indigenous people is higher than 20 cases per 100,000 population. Being Inuit population up to 200 cases per 100,000. So you can see that within Canada, we cannot say that we achieve the NTB goal strategy, which is Canada said that it is committed to meeting the World Health Organization goal of reaching less than 1 TB cases per 100,000 by 2035. And we achieve this rate among Canadian-born non-Indigenous people. However, in foreign-born and Canadian-born Indigenous people, we are far from reaching this goal. This is from the latest publication about epidemiology of tuberculosis in Canada. I won't go into detail because Dr. Rachel Duillo will share with you this afternoon, but I wanted to show you here since 2001 until 2020 that Inuit population is the most impacted and affected by tuberculosis. And in this blue square, you can see that First Nation on reserve are the second most affected communities, followed by First Nations of reserve and followed by foreign-born people. So moving to the current recommended surveillance and treatment, I want to share 2 things. Number one, this year, the World Health Organization updated and relocated all consolidated guidelines, operational handbook, and training catalog in this website. I personally like it very much. It's very easy to navigate. It's tbksp.org. And the second thing is that this year was also released the Canadian Tuberculosis Standards, the 8th edition. It contains 15 chapters that review everything related to tuberculosis in Canada. You can find it in Google, type in Canadian Journal of Respiratory Critical Care and Sleep Medicine, is the volume 6 issue, supplementary material 1 this year. So I want to mention that when we talk, so now you understand why immigrants is definitely very important to understand. So we have pre-arrival screening, and this pre-arrival screening to start with immigration medical exam, which include a chest radiograph. If in this exam, or if the client has a history of prior tuberculosis disease, or if the chest radiograph finds a cavitation or history of active TB consistent with active or remote tuberculosis, so the client must go under examination to rule out TB with 3 sputum for mycobacterial smear and culture. And if positive, the person should receive treatment for active TB to be completed prior to immigration. If the person has a history of active TB, or if the person has any radiographic features consistent with active or remote tuberculosis after completed treatment, these groups will undergo for post-arrival follow-up with provincial and territorial public health authorities within 30 days of arrival to Canada. These change between provinces, but in general consist of a symptom inquiry, a repeat chest radiograph, and sputum for mycobacterial smear culture. And of course, depends on the results, the person will undergo for tuberculosis treatment, latent tuberculosis infection treatment, annual surveillance, or no further follow-up, depends on the results. If the person has an immigration medical exam with chest radiograph and has no history of active TB and no any radiographic features consistent with tuberculosis, the person do not need any follow-up with any public health or medical authorities after arriving to Canada. So this is the most updated recommendations. They require pre-arrival screening for active TB and TB infection. So all people that apply for permanent resident status and selected non-permanent residents, for example, people with study on or work permit, undergo for the following screening. So all applicants 11 years or older requires a chest radiograph. Applicants younger than 11 years old who are defined in a TB risk group needs a chest radiograph, and all individuals in a tuberculosis high risk group, if older than 2 years, undergo for IGRA testing or tuberculosis skin test if IGRA is unavailable, or if the person is younger than 2 years old, the person undergo for tuberculosis skin test. The tuberculosis high risk group refers to people who are close contact with an active TB cases in the previous 5 years, any person with an HIV positive result, history of certain head and neck cancers within the previous 5 years, any person with a chronic kidney disease, and a solid organ or bone marrow transplant or immunosuppressant therapy. These are the criteria for people who undergo for medical examination post-landing into Canada. As I mentioned already, previously treated tuberculosis, inactive pulmonary TB on chest X-ray, extrapulmonary tuberculosis, household or close contact of persons with active tuberculosis within the previous 5 years, individuals with a reactive pre-landing IGRA test or tuberculin skin test who has any of the high-risk conditions that I mentioned previously. But there is something to take into account, and there are barriers to access this post-arrival surveillance. So those barriers can be disaggregated by a structural level. For example, lack of interpreters. I would say that as an immigrant, language is one of the main barriers that immigrants face. On the provider level, there are several, but I would say, for example, lack of knowledge, experience in TB infection screening and treatment, resource limitations. And on the patient level, there are several. One of them is fear of stigma and discrimination. Language barriers, I would say, is number one, in addition to economic factors, travel and other costs, missed work opportunities, precarious employment, etc. I wanted to share this because it links with the economic factors that immigrants face here in Canada. So this is the median entry wage of immigrants admitting in 2017 and 2018 by pre-admission experience. It means with those clients that apply for a study permit, asylum, without pre-admission experience, with work permit, and with work and study permits. And what you can see is it ranged between $0 to 50,000 Canadian dollars. And you can see that people or students, international students, their median entry wage is around $14,000 to $15,000. People with asylum claim is around $23,000, and people with work permit or with both, it ranged between $35,000 to $45,000. And many of these immigrants have families and so on. So definitely income is a barrier that immigrants face to be adherent to all those surveillance. But there are also facilitators and strategies to improve TB infection testing and treatment uptake. So some of the facilitators are, for example, addressing language barriers. So when there are multiple interpreters, engaging with local communities, this is very important, ensuring consistent care and sensitive, supportive patient-provider relationships, as well as providing patient education and awareness raising and providing culturally sensitive materials and care. So all of these are facilitators to improve treatment uptake. I want to mention in Winnipeg, there is a successful story. There is I don't know if you know, but a Bridge Care Clinic is a primary care model that focuses on refugees. And when they implemented integrated care model, the treatment acceptance was 75%, and treatment completion of tuberculosis infection treatment was close to 80%. But when they analyze the socioeconomic model level, so intrapersonal, facilitators and barriers, interpersonal, institutional, sociocultural, community, and structural policy, they identified that some facilitators are a strong relationship with the clients, a significant focus on client health education, nurses in central program management and roles, accessible and well-utilized interpreter service, a patient-centered approach to care, improve efficiency and accessibility of laboratory service. For example, in the sociocultural and community, increased likelihood of refugees having personal experience with active tuberculosis patients and fearing disease consequences. The other is a comprehensive healthcare coverage for refugees during the first year in Canada. Some of the barriers are on the personal level. For example, one of the most common is pregnancy and family planning, because they are afraid of the side effects of tuberculosis treatment during pregnancy. Language barriers, low literacy levels, but other that is important is laboratory service availability, staff and resources limitations, and lack of familiarity with prophylactic and preventive medicine. And one that is very important is the temporary nature of clinic services and lack of material incentives for treatment completion and limited staff and resources. This was a publication that was reported. This treatment acceptance and completion was until 2014. When this integrated model included a short course tuberculosis infection treatment, Bridge Care Clinic achieved 90% of treatment coverage and 90% of treatment completion rates targets identified by the NTB strategies. So it means that when the clinic implement an integrated care model, patient-centered model, plus a short course tuberculosis infection treatment, achieves the NTB goal strategies. Moving into current treatment, tuberculosis disease recommended treatment in Canada. Again, this is in chapter 5 that you can review in detail, but it is divided by suspected drug susceptible preferred regimen and known drug susceptible preferred regimen. It means when we receive the culture test results. So for those with suspected drug susceptible preferred regimen is isoniazid, rifampin, pyrazinamide, and ethambutol daily during the first 2 months, with a continuation phase of isoniazid, rifampin, and ethambutol daily for 4 months. Once the clinicians receive the culture results, and if both 4 drug regimens, if the strain is fully susceptible, when it is non-drug susceptible, it can drop ethambutol. So it means the patient can receive isoniazid, rifampin, pyrazinamide daily, and the continuation phase is isoniazid, rifampin daily for 4 months. And there are alternative regimens based on side effects. When we were mentioning those social and structural barriers and this type of treatment among immigrants and among indigenous population, for example, currently there is an invitation to implement not only a patient-centered model, also an equity-oriented approach to tuberculosis, which means this is a hypothetical example of a community. These mountains represent that there are communities that are in remote and rural areas. So these cross represent health facilities. But when we talk about patient-centered and equity-oriented approach, it means that those implementing partners and organizations that want to address social and structural determinants, instead of requesting people to travel hours, is that those partners go there, go to their communities. So in this case, for example, this blue represents housing, so partners that want to improve housing conditions. The green one related to nutrition, and the gray one is related to geographical, so to decrease the barrier of for example, 8 hours or 24 hours, or taking airplanes to go to a clinician or a nurse station. So in this case, what is the invitation is, instead of bringing people from remote and rural areas to the city, for example, is that governments and partners implement or address these disparities in their population. Here is just an example of how to, what are the elements of a patient-centered and equity-oriented approach. So basically engage affected community to understand sources of individual and community vulnerability to tuberculosis. And for example, identify communities most affected by existing disparities. Design a scalable approach that address these multiple barriers faced by individual people, and implement any other interventions that enable that people complete full cascade of diagnosis, treatment, and prevention, as well as other disparities that increase vulnerability to tuberculosis. So among all of these, we historically have known tuberculosis as a dichotomous disease. So we have people who are exposed to an infectious case of tuberculosis, and among them, 30% become infected. And among those that initially are infected, around 5% progress to active TB disease, and 95% remain as we traditionally knew as latent tuberculosis infection. And among those, they can progress to active TB disease around 5%, and 90% won't progress to TB disease. This progression to active disease will change if the person has any immunosuppressant condition. But for several years, the first one that I recall is 2001, but most recently, since 2018, there have been several papers that have shown that tuberculosis is not anymore a dichotomous disease. That, however, what I want to show in this slide is that there is no consensus about the tuberculosis state's definition. How did we arrive to these definitions? Through research. So this is a cohort, this is one of the examples, there are several. This is a cohort study that followed people that were uninfected but exposed to tuberculosis cases. So people who are uninfected, and they underwent to chest positron emission tomography. So it's a highly high resolution tomography where you can identify that the person has a clear lung, and after the exposure and infection, the person progressed to what is called incipient TB. I'm gonna tell you in a second. And you can see how the lung, it's become affected over time. So again, traditionally we knew latent tuberculosis infection and tuberculosis. Currently, there are reported at least 6 stages of tuberculosis. So an infected individual, which means the person does not have any bacilli. Then the person is exposed to a TB case and the person become infected. And this tuberculosis infection is what was traditionally known as latent tuberculosis infection. Contains dormant bacilli. It means that they are not replicate, they are viable but not replicating. And then depend on, we don't know yet which conditions, but it is believed that comorbidities, for example, the person can progress to incipient TB. And in this incipient TB, the person has viable, slowly or intermittently replicating bacilli. And then depend on some risk factors like immunosuppressant conditions, undernutrition, etc., the person can progress to subclinical tuberculosis with no sign and symptoms. And the person can progress to subclinical tuberculosis with unrecognized signs and symptoms. And the more replication of Mycobacterium tuberculosis bacilli, so we finally end up with tuberculosis disease, the classical presentation that we all know. The main change was related to tuberculosis infection. Includes tuberculosis infection, or you will find in some papers latent tuberculosis infection to this state, incipient TB. Those are the tuberculosis infection stages. Those are subclinical, which means that the person does not have any sign or symptoms, so or that has unrecognized signs and symptoms, traditionally were treated as pneumonia cases. So in this case, they are diagnosed, so they do not have symptoms, but they are diagnosed by radiology or microbiology. So people who has culture positive or chest X-ray positive. So what are the implications of these changes? So the problem is that most screening algorithms start the tuberculosis pathway using positive symptom screening. However, when we talk about subclinical TB, we have asymptomatic people who are infectious. It means that contribute to transmission, and most important, we are missing these cases because the starting point in all guidelines are positive symptoms. So this paper was published in 2021, and they wanted to estimate the proportion of subclinical TB. What they did is that they screened tuberculosis, they screened all surveys that study tuberculosis prevalence among high burden countries in Asia and Africa. And they excluded several conditions like drug resistant, women, etc. So the definition of subclinical TB that they identified or that they defined was negative on symptom screening, confirmed on bacteriological testing, which means at least one positive culture or PCR-based test, and participants not eligible for X-ray screening were considered negative. But the main point is negative on symptom screening, bacteriological positive or X-ray positive. So they screened, they identified multiple national surveys. And among these papers, they identified that account for 36% of the global TB burden. But the main implication is that the proportion of subclinical tuberculosis, you can see here that in red is African countries and in green or blue is Asian countries. Subclinical TB accounts for 50% of all cases. So the conclusion is that half of the prevalent infectious tuberculosis burden is subclinical, which means that if we ignore this burden, it will diminish the impact of TB care and prevention efforts. And the second thing is that the cornerstone of symptom-based screening policies was only self-reported by around half of bacteriologically confirmed cases in populations across Asia and Africa. The second conclusion is that 9 out of 10 individuals with bacteriologically confirmed tuberculosis, including subclinical TB, were positive on chest X-ray screening. So the proposal now is symptoms means around 50% of subclinical, 50% of all TB cases. So there is a trend that is inviting to explore instead of symptoms, the X-ray as a clinical screening tool as part of the TB strategy. There are several limitations of this paper. It reflects only the 36% of the global burden, did not disaggregate it or include papers in high-risk populations. And this is prevalent cases, not incident, not in low TB burden settings. But one of the things it did not include pediatric and extrapulmonary tuberculosis in these surveys. And there are papers that shows that in children has been reported 31% of all tuberculosis cases in children were subclinical. This is very important because the tuberculosis definition in children actually is heavily focused on clinical symptoms and what I call chronic cough, chronic symptoms. So the entry point is persistent coughing, which means more than 2 weeks of unremitting cough, and other symptoms. And in one study that we did in Colombia, we included 525 children and adolescents with community-acquired pneumonia, which means less than 15 days of symptoms. So actually, we didn't meet that criteria for tuberculosis, but because we were studying the etiology of community-acquired pneumonia, we decided to study tuberculosis, and we found 12 cases of intrathoracic tuberculosis, and confirmed by culture. So it means that we are missing several cases. So in conclusion, the impact of subclinical TB is that we are missing a significant proportion, 50% of global tuberculosis burden, and that are not detectable by current symptom-based screening efforts. And the other thing is, if we detect subclinical TB, it means early stages, is an opportunity to prevent extensive lung damage and the risk of post-TB sequela and interrupting transmission of tuberculosis. So what is the future? The future is that we traditionally saw tuberculosis as a latent infection treatment pathway or as an active disease treatment pathway, like 2 dichotomous, where we treat for a tuberculosis infection state and we treat for tuberculosis disease. However, in between, there are some states that we have no idea how to treat. We don't know how to treat incipient. Do we treat as a tuberculosis infection? Do we treat subclinical tuberculosis as an infection or as a tuberculosis treatment? For 6 months, for 4 months, for 2 months, we have no idea. So future research should focus on what are the preferences for treatment in people with subclinical TB, what are the attitudes of healthcare workers and policymakers to moving away from one size fits all strategy. What is the role of new diagnostics in identifying those likely to have bacteriological negative tests? And what is the optimal therapy for the management of less extensive disease? And if can treatment biomarkers inform duration of tuberculosis? So what are the challenges in Canada? How do we screen for subclinical tuberculosis? Do we do X-ray in all people, which we already are doing it, but we use the traditional X-ray. Do we use a tuberculosis CAT? Do we use biomarkers for diagnosis, prediction of progression to TB and response to therapy? Do we treat subclinical tuberculosis? How and for how long? I just want to mention this recent paper from Alberta that compared the chest radiograph and computed tomography features of subclinical tuberculosis. So they screened among—
3 minutes left.
Perfect. Among all cases, they identified that 21% were subclinical, which is significant. And the other thing is that most subclinical pulmonary TB patients in Canada have minimal or no lung parenchymal disease. It means that normal chest X-rays in many of them. However, when they read the CT scans, In the same patients, the chest radiograph may be shown significantly under-detect the presence of key features of potential importance to transmission. So this is endorsed by WHO. CAT is computer-aided detection software, use artificial intelligence, is to use in people 18 years or older. You can use anywhere. So in rural and remote areas, it's a very simple portable chest X-ray, which what it does is that take that image and goes to classification algorithms, and it has a score from 0 to 100, and which represents the probability of having active TB. So for example, here is no active TB, so the score is low, or high probability of tuberculosis. There is no clarity about the threshold of tuberculosis in this case. But we need more studies to understand in other high-risk populations. And the biomarkers, which is our immune response in different states of tuberculosis. So in conclusions of this talk, despite declarations, we have not achieved proposed goals in Canada or Manitoba towards ending TB. Understanding and monitoring the structural and social determinants is critical for achieving progress. Understanding of TB biology is evolving and will likely result in changes to screening algorithms and treatment. So take-home messages from this presentation is there are still structural and social determinants that must be addressed to end TB in Canada. Relying on respiratory symptoms misses approximately half of persons that may be infections in high burden settings. And there may be diagnostic assistant tools applicable to rural and remote Canada that I personally believe it will be a game changer. Thank you very much for your invitation, and you can follow us in this website where we post training and other things. Thank you.
Thank you. We have time for literally one question, and there's some phenomenal questions, but one of the questions that is of interest is, for foreign-born who are likely repeatedly exposed to TB during visiting friends and family, how can we address screening for subclinical TB in this population?
That is a great question, which I do not have an answer. Actually, there is a Canadian paper that mentioned the importance to follow up non-referral immigrants, which means the population that you are asking for. And they are advocating how to follow up this population. I would say there is no clarity among what I read from recommended guidelines, but it's a wonderful question to think about it. We need research to understand the transmission.
And then one more question. Who pays for the screening tests for new immigrants coming to Canada?
The immigrant, like pre-screening arrival, the immigrant pays for that. Post-screening arrival, so the first 2-3 months while the person gets the healthcare, like for example, Manitoba health card. So the immigrant must have a healthcare insurance that pays for that. Otherwise, the person pays for that. But there are, for example, refugees that are supported by the Canadian government and local provinces.
Excellent. Well, thank you very much for your presentation. We look forward to having you at BugDay again in the future. Thank you.
Thank you, Doug.
And we're going to switch gears now and introduce Dr. Daryl Tan, who will speak to us about monkeypox, everything you ever wanted to know in 15 minutes. Daryl is a specialist in infectious diseases located at the University of Toronto. Daryl has been at the forefront of the monkeypox epidemic in Toronto. So Daryl, we'll turn it over to you.
Thank you so much for the introduction and for the privilege of presenting this year at BugDay. I'm going to share some slides, so you can please let me know if it's showing up properly. Does that work? Looks okay? I'll guess so. It's a pretty ambitious title I've been given. Everything you need to know. I don't know whether I can quite fulfill that tall order, but I'll try my best. And I wanted to start by giving us some historical perspective. Doesn't look like my screen is moving, so I'm just going to try that one more time here. And you can let me know if this is sharing properly. Are you seeing this, the next slide?
It looks good. You just need to put it in presenter mode.
All right. I'm so sorry that it's not doing that properly. I will give that one more try here. I'll go ahead and present some of the content anyway. So, prior to what explosively occurred earlier this year in 2022, monkeypox, or what I'll call mpox, had really been confined to a number of countries in Central and West Africa, as you'll see on this slide here. You're seeing this map here on the left?
Looks good.
So really, we had seen cases sporadically occurring in parts of West Africa and in parts of Central Africa, and had really been confined there. It had actually been historically identified first in a lab in Denmark earlier in the 20th century from a monkey, and that's where the virus gets its name, but that's actually a bit of a misnomer because most cases that have been seen in West and Central Africa have in fact been zoonotic infections, meaning infections acquired from animals to humans that were probably residing in small mammals, particularly rodents of various sorts. And in fact, somewhat famously, the only real outbreak of mpox that had occurred outside Africa in the past had been in the United States in 2003, linked to these cute little guys over here, which are actually prairie dogs. It's again a misnomer. They're not canines, they're rodents. These animals had been imported as pets, and they had been housed in a facility adjacent to some animals that had been harboring that virus from Ghana in West Africa, and this led to a serious outbreak of several dozen cases in the Midwestern United States that fortunately ended after just a few months. Now that's a far cry from what we are seeing these days. So this is a map of the world showing you by the darkness of the blue shading the number of cases of confirmed mpox seen in various countries around the world, and you can see that there are large burdens of infections in the Western Hemisphere, in many Western countries, with Canada having the dubious honor of being number 10 in terms of absolute number of cases of mpox around the world. We're quickly being outshadowed by the United States, but we did see our first our epidemic really emerge a little earlier than the United States. It was first seen in Montreal in May, followed by Toronto, and subsequently in other major cities, notably Vancouver out west as well. So what actually happened? Well, myself and some others had the privilege of collaborating earlier this summer on one of the earliest reports about what was happening with mpox infections in humans in the spring. And what was observed was that in the first 600 or so cases reported across 16 countries, the vast majority of infections that we were seeing were occurring in gay, bisexual, and other men who have sex with men. These are folks who are self-reporting same-sex activity. So you can guess that even the small sliver of 1% of people who did not voluntarily self-report that may have had stigma-related or homophobia-related reasons not to disclose that. In other words, it was abundantly clear that this was an infection that was being transmitted globally through existing sexual networks of people. Now that fits with what had been known about how this virus can be transmitted from person to person. It's largely known to potentially be transmitted through direct contact. And of course, during sexual activity, you have a lot of direct contact with somebody else. There was a lot of quibbling, I think, in the literature, there still is, and in the lay media about whether or not this means that it is or isn't a sexually transmitted infection, which I think is kind of an academic debate rather than a useful one. Whether or not this fits the bill of something that can only be transmitted through sexual fluids and sexual activity as a result or not is kind of irrelevant when we clearly see that it is being transmitted and propagated globally through sexual networks. It's epidemiologically behaving like other sexually transmitted infections, and our response needs to take that reality into account. Now, there are other potential routes of transmission that are largely hypothesized based on extrapolation from another really closely related orthopox virus called smallpox, which many of you will know has fortunately been eradicated from the planet through a vaccine campaign in the 1980s. Notably, I really thank the team for their land acknowledgement earlier, because the close relationship between the two means that in a discussion about monkeypox, we must remember the sordid history of so-called gifts of blankets being given by colonists to indigenous people, really as an intentional form of biowarfare. And that really speaks to the potential for smallpox to be transmitted through fomites, in other words, inanimate objects. And by extension, it's hypothesized that Mpox could potentially be transmitted through fomites as well. There have been some reports of that happening already as well, although it's clearly not an important mode of transmission and certainly not a major driver of what we've seen. Similarly, airborne and respiratory droplets, which we've all learned about through COVID, have thought to potentially be routes of transmission for Mpox. But again, clearly these are not major drivers of what we've seen. Otherwise, the epidemic really would have unfolded in a very different way from what we've seen. Now, in terms of what actually happens when someone acquires this virus, the usual manifestations include three types of symptoms. One is skin symptoms, so a rash that I'll talk about. Second is lymphadenopathy, in other words, swollen, tender lymph nodes or swollen glands, often in the neck or in the groin region, as well as flu-like symptoms. So these are your classic fever, chills, feeling gross, malaise, fatigue, headache, etc. They can occur in any order, although historically it had been reported that the flu-like symptoms always occur first. We've clearly seen that they can occur in a different order during the current epidemic. And on this diagram here, what you're seeing is a nice illustration of how the lesions of the skin, the rash, evolve over time. And it really evolves in a way that's analogous to how other viruses that cause what we call vesicular or blister-like infections change over time. The individual skin lesion or part of the body can evolve from a dot or a macule in medical parlance, to a bump or a papule, to a blister or a vesicle, to a pus-filled blister or a pustule that's got this central area of indentation, or what we call in medicine umbilication, which is very characteristic for Mpox. And then finally, a scab or a crust. And from this diagram on the right, you can see that the lesions can really involve any part of the body, but typically have had a bit of a what we call a centrifugal pattern. It tends to go to the extremities and the further parts of the body. Now, I'm going to show you some more pictures from actual patients who have agreed to let us show their images in the next few slides very quickly. What we've often seen is that lesions first appear at the site where the virus is first inoculated through sexual activity. So we see it around the mouth. On the right here, this is the shaft of the penis and the pubic area. Again, the tongue from oral sex, the perianal area from receptive anal sex. Here's some evolution from little pustules on the penis, evolving to larger, really painful lesions on the penis just a few days later in the same patient. You can imagine if the same thing is happening in the rectum, people have complained of really horrible pain that they've suffered from, as well as the swollen glands that I mentioned a moment ago. But again, it can take many forms. Here's the same patient on more or less the same day with flat spots, little bumps, some with a little bit of fluid in them, and then some with pus in them, so pustules. And you can see how it has changed over time in this individual on the forehead. And in that same individual really caused a really remarkable rash over the trunk, which is a little atypical. The palms and the soles of the hands, which medical people always like to look at, can also be affected. You can see lesions here on the palm and on the soles of the foot. Those are the usual manifestations that we see on the skin, but what's been really fascinating through this epidemic is how you can also have more unusual manifestations. And we were privileged to care for a patient who actually had involvement of the heart in what we call myopericarditis. A colleague here at St. Michael's in Toronto had a patient who had involvement of the esophagus, who presented with central pain that turned out to be related to this lesion over here. And on the right, involving the eye as well. There have even been really rare fatalities related to more dramatic presentations, some of which have included involvement of the brain tissue or just bacterial infections of the skin, as well as severe infections of the throat that have compromised people's breathing and led to hospitalization.
4 minutes.
Though, in terms of those serious manifestations, we don't have all that much in our armamentarium. For mild cases, unfortunately, we have to just wait this out and most people will recover spontaneously. But there is a drug that has been stockpiled for many years in Western countries, including Canada, mostly for potential use in the event of a bioterrorism event involving smallpox or monkeypox. And that's this drug called tecovirimat. It binds to a viral protein that prevents the virus from exiting cells and is given for a 14-day course. That's based on data from animals showing that it seems to work, as well as data from humans showing that it's safe. But we haven't got a lot of experience in the current epidemic, and we really never had the opportunity to study it formally before because this was so confined geographically. In the current epidemic, folks have started to report on its use, and we've certainly used it a number of times in folks who really were suffering and we didn't know what else to offer them. So you can see severe proctitis or rectal involvement was a common reason to give this drug. But I really want to emphasize that although folks have pitched it as though it might be a panacea, notably there was an amazing episode of this amazing podcast, The Daily, that I like to listen to that spoke about this, the experience of people with Mpox. But I did take issue with how that podcast really presented this drug as though it was clearly the solution and a panacea. I would argue that we really do not have clinical data to prove that it works, and we absolutely need to study it formally. There are research studies that are being initiated here in Canada by myself and amazing colleagues from Montreal and other cities, in collaboration with other research groups around the world, in the United Kingdom, in the United States, in the Democratic Republic of Congo, many of us unified through a WHO initiative. And we really need to emphasize the role of science to prove to us whether a drug that we think might work actually works or not. I'll close with just a couple comments about prevention. There have been a lot of efforts to raise awareness about this virus in communities that have been largely affected. So queer communities have really mobilized, and you can see this report from the United States showing that as the word got out through the spring, people were really changing their sexual behaviors in meaningful ways. On top of that, we do have a vaccine that again was stockpiled for potential use against smallpox, does seem to have some activity against monkeypox, and that's probably at least a part of why we've seen dramatic decreases in case counts. These are data from PHAC showing where we're at presently with just individual cases being detected rarely from week to week. And this mirrors what we've seen globally, fortunately, largely related to the behavior change as well as the rollout of vaccine. But we'll see what the future holds. And we've seen with COVID and other infections that there can often be waves of infection one after the other. I'll close by just emphasizing that as with all things that are new, we really need to study this. Myself and others have launched already a prospective observational cohort study to learn more about Mpox in our setting. And I have to thank the amazing community partners who we've mobilized with from day one of seeing this appear in Canada. It's really been through this amazing collaboration with community groups representing sexual minorities and others that we've been able to come as far as we have so far with our understanding, with the awareness raising, and hopefully with the ongoing rollout of prevention and treatment options. So with that, I'll thank you as well as our funders. And again, thanks for the privilege of speaking to you today at BugDay.
Thank you very much. And don't go away. We'll get you for the questions and answers at the end. I'd now like to switch gears and invite Brent Rusin. I don't think Brent requires any further introduction. Brent is a specialist in public health and preventative medicine and the Chief Public Health Officer for the province of Manitoba. And sadly, Brent was on the hot seat for the past has been on the hot seat for the past 2.5 years. I'm sure Brent never imagined what lay ahead when he accepted the position of Chief Medical Officer. Brent will give us the COVID roundup to date. Where are we? And what potentially could lie ahead? Thank you very much, Brent. And you have 15 minutes.
Great. Yeah. Hi, everyone. Yeah, Brent Rusin here. Thanks for having me. I take it my slides are showing okay there. I have no conflicts to declare. So just going through the presentation, we want to look at that the epidemiology to date in Manitoba. We're going to take a stroll through our epi curve and see what sort of information we can glean from looking at that.
I'm sorry to interrupt. We're not seeing it in presenters mode.
Oh, let me see here.
Yeah, just switch that.
How was that?
Perfect. Thank you.
Oh, great. Thanks. And then we'll look at reasons why we're at a different stage in the pandemic than we have been in the past 2 years, looking at that seroprevalence, and then of course looking at those public health ethics. When we're talking about public health ethics in this context, we're really discussing the public health restrictions, which were hotly debated and continue to be. Yeah, I think with the pandemic, certainly we've seen so many harms from the direct effects of the virus itself. We've seen harms and continuing harms from the restrictions that we use to try to limit the transmission of the virus. But even more so, we've seen this division. A division in many parts of society. We've seen division amongst colleagues. We've seen division even in families. Due to the nature and the length of this pandemic. So hopefully as we move on to the next stages of this pandemic, there can be healing that goes along with it. So here's our epi curve. Everyone's probably seen this quite a bit, and we can get a lot of information from this. If we look over here in the fall of 2020, this is our second wave. And so this was still ancestral strain. As we move into the winter or the spring of 2021, then we see our alpha wave. And as we move over here into that fall and early winter of 2021 was our delta wave. And then we see the huge peak with Omicron, which really changed the way we approach COVID. What else can we see here? So we see the dots as a number of deaths plotted against the number of cases. So essentially a case fatality rate we can see plotted here. And you can see that in early 2021, as we started vaccinating the highest risk Manitobans, you can see that case fatality rate significantly decline. And which continues, and a very significant decline in the case fatality rate when you consider Omicron and the underestimate of actual cases that were detected for a number of reasons. So Omicron certainly changed our approach to the virus for a number of reasons, although a lot of the approaches served us well. And if we look at the Delta wave or Delta period here just before the Omicron wave, we could see that largely this was due to the benefit of vaccines and higher use uptake of vaccines, possibly related to some of the vaccine requirements. But we see here during this period, the fully vaccinated were essentially living restriction-free at this point. We saw very, very few fully vaccinated people in ICU. And just as we're starting to creep to the end of 2021, we started seeing that waning of immunity. And then we started to see some fully vaccinated people enter the ICU. But for the most part, that Delta wave vaccines protected us quite well and allowed us to live restriction-free for the vaccinated, at least at that point. Omicron changed things, very highly infectious, much shorter incubation period, less virulence, and so it really required us to change our approach, and that's where we're at right now. If we look at our seroprevalence, remember at the beginning, late 2019 or late 2020 with the introduction of the novel coronavirus, really universal susceptibility to this. But if we look at the seroprevalence now, obviously we're in a much different place. If we look at nucleocapsid on the left here in the gray column, this is a proxy for natural infection. Manitoba is similar to many other provinces, looking about 57%. Now, this data is from Canadian Blood Services, so it's on blood donors, so certainly there's some selection bias with that. But the trends have been very good over time, and we see similar results throughout Canada. And we move over to the pink side here, and so this is spike antibody. So this is really a proxy for both natural and or vaccine immunity, and you can see that 100% of those sampled had some level of protection. Yeah, so really we are in a much different place with one of the nature of the virus. As well as the amount of immunity that's out there, which really required us to change our approach to COVID. And so as we move into this fall, we're going to again deal with a respiratory virus season. And we're going to see a resurgence, and already seeing a resurgence of many of the usual pathogens. RSV, we're going to be seeing influenza. Australia had a fairly significant and early flu season. Very likely we're going to be seeing a similar pattern here. But as we move into that new aspect, new time period in this pandemic, we also have to reorient and remember the risks that were present in all respiratory virus seasons and in the pre-pandemic era. And so this is just one example of those indicators, ILI visits to the emergency department. So you can see pre-pandemic, very busy times, significant amount of ILI presenting to the emergency departments. Every respiratory virus season, we see significant admissions to hospital and to ICU due to respiratory illness. And there's no doubt that we'll be seeing that again this year. We know that adds extra risk because of the nature of the healthcare system right now, recovering from that pandemic with staffing issues, etc. But we can definitely expect a significant respiratory virus season, just like we do every year. We've had some innovations during the pandemic, one of which is the wastewater analysis. And we can see that depending on where sampled and the timing, we usually get results that some are up, some are down, and that's just the place we are at this stage in the pandemic. But nonetheless, it was a great innovation. We'll continue to be using that for COVID and looking even at other pathogens. You've heard it being used for polio in other parts of the world. So this is one of those innovations that will carry forward and hopefully be able to expand for surveillance activities with many pathogens. Some of those other innovations that have come out during the pandemic that we hope to continue to use forward for other issues, alternate accommodations. We knew many people who were unable to isolate at home or perhaps didn't even have a home. We set up the alternate isolation accommodations, which served Manitobans quite well, various levels of services, and now we're looking at other uses for that with the other medical indications. We know our REI data, race, ethnicity, and indigeneity data collection led by Dr. Marcia Anderson and her team really showed the disparities in severe outcomes in the BIPOC communities, which really led to public health action in changing the ages of eligibility for vaccine for COVID, as well as setting up culturally appropriate and Indigenous-led clinics to get those vaccine numbers up. So it's a lot of innovation that we're carrying forward with this. So where are we at now? If we look at our vaccine, early on in the pandemic, we saw a very high case fatality rate. We had public health restrictions. We had vaccine mandates. So we really drove a very high vaccine uptake, really unheard of though in other campaigns to get close to 90% of Manitobans vaccinated with 2 doses. But you see that for many reasons has trailed over time. We're certainly at a different stage in the pandemic. Our bivalent uptake is certainly lagging more than what we would prefer. There's a couple of reasons for that. We know that there is the interval. We still see very good protection, up to 6 months, and people can get vaccinated up to 3 months after their last dose. So between that, the last dose, and widespread infection, we see many people probably still in that interval, which will hold back a bit of that bivalent uptake. But again, when we see we're at a different stage in pandemic, when we have no more of the restrictions or mandates, we lose some of those incentives with it. So we'll continue to be advocating for further bivalent uptake as we move further into this respiratory virus season, and of course, along with influenza uptake, because we know we will see a significant flu season.
3 minutes.
And so when we look here at the public health ethics, which we had to deal with for 2 years using the Public Health Act, really like it's never been used before, and hopefully we're not challenged with similar requirements in the future. But we have seen, numerous heated debates on the use of these public health restrictions, on the coercive measures, on limiting gatherings, on vaccine mandates, and certainly these decisions need to be made during periods of crisis in the population and the healthcare system, and we'll keep seeing evidence coming back in retrospect, looking at what was the best way to approach this. But even now, we'll see studies looking in retrospect on the significant benefits of those coercive measures of limiting contact between individuals, and other studies showing very little connection between virus transmission and the use of the coercive measures. So we were always needed to find that appropriate balance. The least restrictive means is definitely a requirement when making these. It's required under the Public Health Act. It's required under Section 1 of the Charter of Rights and Freedoms. So we always strove to find that balance, to use the least restrictive means, and based on all of these factors is why we find ourselves without public health restrictions right now, or vaccine mandates moving forward, as it's just not justified right now as we move forward, but certainly we'll always be ready to act if the scenario arose. So looking at where we are, we have a highly infectious pathogen, which has much lower virulence than it originally had. We have widespread seroprevalence. We can really see we're at a different chapter in the pandemic. There are new variants that we continue to follow, but as we move forward, hopefully we can heal some of those gaps throughout many aspects of our society that were caused by this pandemic and the restrictions and the virus itself. So thanks for having me, and happy to answer any questions.
Thank you, Brent. So the questions will be at the question and answer period, so please don't go away. I'd like to shift gears and introduce Gordon Jolly. Gordon, believe it or not, was a former rocket scientist and system engineer. Gordon's role as the Executive Director of Genomic Surveillance Systems for the Public Health Agency of Canada is focused on how information in specimen or data files goes from collection to decision. Gordon works at the National Microbiology Laboratory and draws from federal, provincial, and territorial surveillance programs. So Gordon, the floor is yours, presenting your presentation entitled, "How many genomes does it take to change a pandemic?"
Thank you very much, John. And I'd also like to thank Brent for the COVID summary and an introduction that hopefully places what I'm going to talk about in a little bit of context. So the question on the slide is, how many genomes does it take to change a pandemic? So I'm going to trust that everyone's aware of what a gene is, what genomics is as the instruction set within a cell that defines you, an aardvark, a zebra, and the SARS-CoV-2 virus, the virus that causes COVID-19. So I'm going to focus on is the surveillance aspects. And if I grossly oversimplify what traditional surveillance looks at, it looks at our cases going up and down. Are the cases changing over time? The epi curves that Brent just showed. Are the outcomes different from place to place? Are they different in Manitoba from other provinces, from other countries? And not everybody's affected in the same way. If we look at different demographics, if we look at different parts of the community, is the virus affecting them in different ways? And this tends to give us a view of what is happening, but not necessarily why. So what lab techniques and genomics in particular does is gives us a little bit of extra insight as to the causal factors, the cause of a pandemic. So genomics as a discipline provides us with precision. So viruses, like other living organisms, evolve, they mutate over time, and genomics gives us visibility of the mutations or the sets of mutations that can then be identified. And we've been labeling these as lineages. You may be familiar with B117, which was alpha, B1617.2, which was delta, and the various BA lineages that are Omicron. It gives us traceability between one infection and another via the mutations that are passed on through transmission. So this phylogenomics gives us transmission pathways that allow us to look at, if 3 people show up at a party and infect, the people that are there, and some are asymptomatic, some have mild symptoms, and some have very severe symptoms. Can we trace back to which version of the infection caused those different outcomes? And that speaks to the accuracy that we can get through genomics of looking at the growth and spread of infections. It can be mapped in space and time, and even when there are multiple coexisting infections. And this really helps us with outbreak investigations to extract the pathogenic signal from the noise of other infections, even of the same disease, to say that we can now identify that an individual infection is different to the background majority. And this diagnostic power allows us to look at changes in the pathogen, and hence changes that are observed in the outcomes. And ultimately, that allows us to differentiate the differences in outcomes in different environments and populations with different interventions. And that's really, the discipline of genomic epidemiology. And that strengthening of the understanding of the steps between the cause and the effect, not just the correlations, but beginning to sort of break those down. And what you can see on the graphic on the right is kind of the phylogenetic tree of the COVID-19 pandemic from its origins with the Wuhan 1 sequence that was first sequenced and is the basis of PCR tests and the majority of the vaccines that we've received. Over time, diversifying and emerging in progressively more and more successful strains, with alpha and gamma, in sort of 2021, and then the emergence of delta later that year, and then of course the massive eruption of Omicron almost a year ago. So if we look at genomic surveillance in Canada, we have kind of 3 layers of surveillance. We have had, until a couple of weeks ago, mandatory random testing of arriving travelers. This is a representative surveillance of the various lineages arriving into Canada, traveled by you, me, and everybody else who's been sort of traveling over the past couple of years. We have national genomic surveillance, which is a mix of targeted, often hospital and long-term care testing, and some representative community surveillance. Less now than there was earlier in the pandemic, but still a really important way of understanding the mix of variants that are circulating in Canada. And then there's the National Wastewater Surveillance Programme that Brent referred to, and my colleague Anil Nishani will be talking about in much more detail this afternoon. So I won't go into the wastewater aspect too much. So those are the three flavors. And if we look at the mandatory random at the airports and the land ports of entry and national genomic surveillance, an important part of that is that's where we're testing, but how much are we testing? Now, I don't have time to go into the detailed statistics of it, but I can illustrate. An individual detection doesn't necessarily tell you very much other than you have a variant. There are over 2,000 named COVID-19 variants already. Lots of mutations go unlabeled. They simply don't do anything particularly interesting. They're just, part of the background noise of the process of evolution. So we've used a 1% prevalence threshold to say, yep, this is a significant enough variant that we need to be tracking it carefully. And in order to do that, we need a certain minimum number of detections to give us confidence. Basically, that 95% confidence interval, covers 0.5% up to 1.5%, so we can be sure that it's really 1%. And part of the reason for that is not to be able to say whether we have it or we don't have it. It's actually the next step. The next step is measuring change, because a key part of any surveillance program is how is it changing over time? How is the prevalence changing? Are we seeing more or less? And that's where the table on the right comes in. If we go from 1% to 2%, how confidently can we say that that's a real change? So that drives the number of samples that we need to pick up, either at the airport or within a particular community, whether that community is the whole of Canada or the province of Manitoba. But what are we actually looking for? If we think about genomic surveillance as a tool that allows us to track the evolution of a pathogen and the relationship between that evolution and the infection outcomes and the interventions that we apply, there really are two trends that have been fairly clear if you've been sort of following the headlines over the last 34 months. There's the slow antigenic drift of individual mutations, small clusters of mutations that incrementally change the characteristics of the underlying virus and therefore its effect. It's a general prevalence risk within the population. The more infection there is, the more antigenic drift, the more mutations emerge in a period of time. And it's relatively predictable in terms of it's going to happen. The virus will improve its fitness over time. It will adapt to the interventions that we apply to it, and we'll see the slow emergence that allows us to identify it, see it coming, and potentially make changes to the diagnostics or therapeutics. For example, the bivalent vaccines that have emerged, using some of the Omicron variants in addition to the original wild type. The one that causes much more havoc are these sudden antigenic drifts, sudden antigenic jumps. These have happened occasionally. Alpha, beta, gamma, delta, and Omicron are the headline versions of this. And they tend to emerge from isolated populations, not necessarily geographically isolated. It may be culturally or socially isolated. And they tend to be obscured from routine surveillance so that we don't see them coming. So really, they're just slow antigenic drift that has been ignored for long enough that the migration of the viral evolution has achieved a certain distance from the rest of the infection that we've been looking at. And this can happen in animal hosts, again in isolated communities, not part of surveillance reach, and immunocompromised individuals. It can be fairly unpredictable in terms of when it emerges, but it's also a fairly likely result of failures in our surveillance system or a lack of reach in our surveillance system. So, and it can have an enormous impact on diagnostics and therapeutics because we don't have that opportunity to see it coming, to make some provision in our research and development of therapeutics and diagnostics, and therefore we need to respond after the fact. So let's have a look at some of those cases of where we do see hidden evolution. So the first of those is amongst the immunocompromised. While mutations may be random in the virus, selection is not, and we do see that the environment affects the evolution of the virus. The longer an infection lasts, the greater the opportunity for mutations. With 2 to 5% of people globally being immunocompromised, there's a lot of people out there that have been infected with COVID-19 who have had the opportunity for evolution to take place within them as the virus replicates. Then,
4 minutes.
Yeah. Then there are the zoonotic cases. This diagram shows the spike protein and all the different hosts that have influenced the shape of that spike protein through the evolution of the virus over the long history of coronaviruses. I've mentioned travelers before. So if we look at the emergence of the Delta variant last year, it took 16 weeks from first detection to 80% prevalence in Canada, whereas Omicron showed up. It was identified on a Tuesday morning publicly. There was a press conference on a Thursday morning. We detected our first cases the Thursday evening, and by Sunday we'd implemented border restrictions, yet it still overwhelmed Canada in just 5 weeks. Now, in that period, there was already a large infection base of Delta cases, which were then overwhelmed by Omicron. And that created the case that some people were unfortunate enough to be infected by both at the same time. And the processes of replicating the RNA that contain the genetic material for COVID-19 meant that some of those got spliced together. And we saw the emergence of recombinants, so hybrid versions of the virus. And we're seeing this again with still very high prevalence of BA lineages in Canada and elsewhere. And it's resulting in things like there's an XBB recombinant that's been identified that contains BA2 and BA5 variants. So where do we look in order to find these? We're obviously looking at community surveillance to understand that background pervasive evolution of the virus through the population in Canada. We're looking at the borders to look at that inward pressure, including significant new variants. We're looking at hospitals and primary care surveillance, looking for severity trends and accelerated drift in individuals. And we're also looking at One Health surveillance to identify reservoirs and isolated evolution. For example, the white-tailed deer population in southern Ontario, has shown that it has some cases of COVID in it, and we've even seen a hunter, who contracted COVID from one of those deer. There's also a matter of where and when to look. So if we look at hospital and primary care surveillance, it tends to be on the back end of an infection and therefore tells us much more about the severity and the outcomes. If we look at community surveillance, that tells us what's active just now. Border surveillance gives us a little bit of a head start as to what's coming into the country, that inward pressure. And then One Health, looking at the zoonotic population, has the potential to tell us more about what is possible and what we may experience shortly. So that brings us to what next? COVID-19 is not over, and the nature of the fall wave remains largely unknown. As was mentioned by Brent earlier, flu is likely to make a significant return this year, and other diseases have commanded a lot of public health attention already this year, including monkeypox, polio in New York, and Ebola in West Africa. Within Canada, TB, we've heard about earlier today as well, syphilis and Lyme disease remain significant and pervasive risks to Canadians. So how do we take the COVID-19 genomic legacy to ongoing neglected and future public health threats? Which diseases do we prioritize? What forms of surveillance do we support? And what public health actions can we enable? So with that, I'd like to thank you for your time this morning and hand back to you, John.
Thank you very much. So when we look at the Slido questions, the first one's a difficult philosophical question that I think Brent and I can probably both tackle. Do you see in the near future a time where hospital staff would not have to wear masks in hospitals and clinic all the time? I'll begin and then Brent can jump in. This is a difficult question. The issue that we've got is that COVID is alive and well. It hasn't gone away. Just because there aren't public health mandates doesn't mean the virus is gone. And if you think about it, people who work in hospital are members of the community. So whatever's going on in the community will be affecting our healthcare workers. We have a vulnerable population. At some point, masks will disappear from hospital. I just don't know at what threshold. Brent, your thoughts?
Yeah, I think it is. It's difficult to predict when that is. I don't certainly foresee it this respiratory virus season. Like you said, COVID is not gone, and the other respiratory viruses will never be gone either. And so, working in a higher risk setting, especially during periods of very high transmission in the respiratory virus season, it's very likely we're going to find it very difficult in those settings to move away from masks, certainly entirely.
No, I agree. So there was a question that began early on, and this is a Daryl Tam question. What was thought to be the main mode of transmission in the 2003 outbreak of monkeypox?
Yeah, thanks for the question. That was really related to these prairie dogs that were disseminated as pets to people. So the animals were, they're rodents, they were scratching or biting people. There was some evidence that the severity of the Mpox infection in the humans related to the intensity of the inoculation. So like bite-related transmissions were worse than those that were just related to, licking or something like that by the pet. So that's clearly what happened. Zoonotic transmission, spillover, what we call from spillover events from animals to humans, very different from what we've been seeing in 2022.
Thank you. A great question. And again, another Brett Rusin question. Do you believe that the mixed messaging in the early days and then differences in interprovincially may have undermined public health trust and compliance if we are to see future pandemics? So I guess the question really becomes, how did the messaging of all COVID restrictions, activities, federally, interprovincially, and even within the province, how did that play a role in adherence to public health activities and the trust in public health activities?
Yeah, I think it's a good question. I think there's a lot of things at play there. One is we're dealing with, public health restrictions for the better part of 2 years, which really we've never seen before. And so to keep people from interacting with each other for years is something that's going to be really difficult. So I think it's a crisis. We'll hopefully look back and learn from this. But I think that it was a tall order. I think there's a lot of things that challenged us. And if you look at very tough decisions with these restrictions that we knew had many impacts on other aspects of health, and pretty much every announcement that public health made, there was a lineup of people being critical on either side of it. And so again, I think that is challenging to try to get the public to buy into very difficult decisions when there's immediate criticism on either side of it. So I think it's a challenging time. I think we're going to learn, but to have that impact for that long is just such a challenge.
So thank you. Gordon Jolly question, which is sort of a derivative of the questions that have been put up. So how quickly can the molecular biologists start genomic testing? Because one of the issues that we saw during the pandemic, and we saw it during H1N1, was that there was a bit of a lag between the time the virus appeared and we started seeing the different strains of the virus?
So there's always going to be something of a time lag. We sequence the PCR positives, and that takes a day or so before we get those results. There's often some transport of samples, which might add a day or two, and then the sequencing itself takes a few days. So we've always got to recognize that there's going to be a bit of a delay between the sample collection and the sequence results. The case of the first travelers coming into Canada, where we took the sample on the Thursday evening and had the result on Saturday evening, was something of an exception. So one of the things in surveillance is we have to look at it not so much from the clinical perspective, where you're looking for an immediate decision on an individual case-by-case basis in order to shape the diagnosis. Which treatment are you going to use? But when you're diagnosing a community or a population, you're looking at the trends over time. So the cadence of the sampling, whether you're looking at a weekly cadence or 2 weekly or monthly, depending on the characteristics of the infection you're dealing with, gives you that insight and the trends that are necessary. So, it'd be a mistake to try and over-optimize to say you want immediate sequencing results, although it would be nice. There's a lot of information that is available within the data as, at that very low prevalence and low growth rate, you get insight as to which lineages are going to cause trouble, which ones are going to be difficult for the population and are displaying different transmission characteristics. It then takes a lot longer to get the outcome characteristics through the hospital records, if you can connect them back to those original lineages that were at the causal end of the infection.
Thank you. Daryl, 10 question. So we all watched the monkeypox, I guess we'll call it epidemic, spread across North America over the summer. What is your impression of the successes and failures of the intervention to bring this under control?
A great question. I think that there are many things that fortunately went fairly well, all things considered. There was, first of all, a lot of awareness on the part of frontline clinicians, allowing us to detect the first cases very quickly, and astute individual clinicians in Montreal brought a weird clinical observation to the attention of colleagues immediately, and we did the same in Ontario after hearing about what was going on in Europe. So that kind of sentinel surveillance on the part of frontline clinicians went well. Another key piece that I tried to emphasize at the end of the presentation was community engagement. I think we've learned from other infectious diseases, notably HIV experience, other sexually transmitted infections, a field in which I work, that community engagement is absolutely critical. I think other fields of medicine recognize this very, very well as well. And that allowed us to very rapidly kind of leapfrog over some common barriers related to stigma, kind of butting heads between community members and public health officials in a way that allowed for policy to be set in a way that was very respectful of a historically equity-seeking community, and allowed word to get out to, again, potentially folks who might otherwise shy away from engaging with health authorities. So I think a lot of that went very well. And then a final thing that I'll just mention is that it was a bit of a serendipitous good fortune that we had stockpiles of drug and vaccine present in this country that were already approved by Health Canada, albeit in some cases for a slightly different use, but they did exist in the country and they were able to be deployed very rapidly as a result. Of course, very different from the situation with SARS-CoV-2 and COVID, where we had to do the discovery science up front. So I think in those senses, some things went well. Of course, there's always room for improvement, but I think we always are learning from this experience, and the research, I think, will come out on further things that we could have improved on with future epidemics.
Thank you. A question for Brent Rusin. One of the attendees inquires about what behaviors changed the outcome let me just find the question here. You mentioned behaviors modifying the outcome of or the magnitude of the pandemic. What are your thoughts about behaviors that modified the pandemic, or the outcome or the magnitude or the gravity of the pandemic?
Yeah, so certainly I'm not sure if this one was for me or regarding there's a slide on this on the Dr. Tan's monkeypox presentation, but for us this is a virus that's transmitted through contact, and so the more contacts people have, and speaking on COVID-19, the more likely the transmission, and the greater number of people, the more likely that one of those people is infected, and the more people that person's infected with, the more likely it will be spread to a greater number of people. So it's all about contact. So during the peaks of these transmission, the less contact each individual had. I think on previous presentations, I showed the formula of R naught. And it's really the nature of the virus times the duration of infectivity times the number of people that you're in contact with. So the duration of infectiveness we can deal with by having people stay home when ill. We're isolating people, and then the other contact was just the number of the kappa, the number of people you become in contact with. So anything that reduces the contact or the duration of infectiveness will decrease the transmission of that virus.
Thank you. And I guess, Dr. Tan, I presume that the exact same thing applies to the monkeypox outbreak.
Absolutely. I think people learned that this was going on through communities, largely again because people were willing to acknowledge this was an epidemic that was being transmitted through specific behaviors and to specific communities. Again, I'll just point out that although there was some reluctance and some reticence about stating the epidemiological facts that 99% of infections were in gay, bisexual, and other men men up front, that fear was out of fear of stigmatization, and I think lessons learned from the HIV pandemic. Once we were able to vocally say that that's what the data said, it allowed communities to take control and ownership of what was going on and change behavior accordingly. It's really important that we not shy away from facts, but rather we reach out with facts to the right folks and engage people. That plus the provincial and federal health authorities, again, reaching out to communities and getting input on how to roll out the biomedical countermeasures like vaccine were critical. So a combination of traditional non-pharmacologic, non-biomedical behavior change, plus the deployment of biomedical tools in a really community-engaged, thoughtful way.
Thank you. There's a question that's actually interesting that basically reads, should pandemic planning shift focus to coronaviruses based on past outbreaks of SARS, MERS, and now COVID? So my question to Brent Rusin is, instead of focusing on specific viruses, should we have a global or a generic template of addressing respiratory pathogens? Because it will take us a few days, as Gordon Jolly mentioned, to actually learn which virus is causing these outbreaks. And I can tell you in the hospital, we're shifting gears from a specific virus to a more generic template of respiratory disease, because by the time we know what we're dealing with, it may be too late. So all persons will be managed in a similar fashion until we know what we're dealing with. Your thoughts?
Yeah, I think with the emergency planning and pandemic planning, the all-cause planning is much more effective with it. But if you really want to prepare the next population for the future pandemics, is really to pandemic-proof the population. We saw the disparities which led many of the negative outcomes in this pandemic. BIPOC, those living in poverty, those living in crowded housing. So if you really want to improve outcomes now and in the next pandemic, reduce those disparities that lead to those outcomes. That's how we can prepare best for next health issues.
Well, that brings us to 10 o'clock. So thank you for all of the participants in the first session. We'll have a 15-minute break. So we'll see you back at 10:15 with Dr. Armel Perez Cortez Villalobos. So thank you, everyone, and we'll see you back in 15 minutes. Well, welcome back, everyone. I'd like to take this opportunity to remind everyone to fill in your evaluations of all of the speakers and of the program in general. I'd like to introduce Armel Perez Cortez Villalobos. Armel is a specialist in infectious diseases whose clinical and research focus is that of infections in persons who are immunocompromised or who have organ transplants. Armel's presentation is entitled COVID-19 and Solid Organ Transplant Recipients. Armel, the floor is yours.
Thank you so much, and thank you so much for the present introduction. Today I'm going to talk about COVID-19 and solid organ transplant recipients. I have no conflict of interest, and through the talk I'm going to try and answer a few questions trying to explain what the COVID-19 pandemic has been for transplant individuals. So the first question is, why are solid organ transplant recipients susceptible to infections? So the natural response of the body and the immune system to an antigen or an external tissue or organ is try to reject it and trying to get rid of it. That's why transplant recipients are going to require deep immunosuppression to tolerate the transplanted organ. As we know, transplantation is really the gift of life. However, these patients who are chronically immunosuppressed, they're going to be in risk of opportunistic infections. So on one side, they're going to be immunosuppressed for the rest of their lives, and on the other side, we'll have to keep them infection-free. And of course, transplant recipients are going to have different clinical courses and different presentations of common infections. So it is more difficult to recognize infection in immunocompromised and transplant recipients than in patients with normal immune function. And why is that? The reason is due to many, many reasons. First of all, transplant recipients really have a mass clinical picture. They can have dual or multiple infections. And we learned that through the pandemic. With transplant and immunocompromised individuals, they could have COVID and also fungal infections, or also other viral infections in the case of transplant recipients, CMV and EBV, while they're having COVID. They can also have an advanced infection at the diagnosis. Since all the symptoms are quite abnormal, they're not the same as an immunocompetent individual, they can be masked, and therefore, whenever we diagnose them, the infection can be more severe, or they can progress rapidly. Also, at the moment that we treat the infections, because they are immunosuppressive drugs, they can have toxic effects, they can have drug interactions that makes the treatment even more difficult. There's also a very broad list of differentials, not only infectious, but other causes of non-infectious fever, for example, rejection. There's also a poor tolerance to established infection, and there can be some cases where there's even poor response to a treatment just due to the immunocompromised state. So what happened with transplant recipients and COVID? Really, the clinical features of COVID-19 in transplant recipients, they really are variable, and they are in many ways similar to immunocompetent patients. However, it has been consistently found that transplant individuals have less fever than immunocompetent hosts. And that's probably because they are immunosuppressed, they're taking steroids, and they're taking multiple drugs. They are going to decrease the cytokine and the inflammatory response that can trigger fever. Also, lymphopenia, which is a marker of severity for COVID-19, lymphopenia is actually more commonly found and also more profound in transplant individuals with COVID compared to non-transplant patients. So the second question, we know now that transplant individuals can have a higher risk of acquiring infections, but do transplant recipients have a higher risk for severe COVID-19? The answer is yes. And we learned that very early in the pandemic. This is one of the most classic, probably one of the most important cohorts of COVID-19 in transplant individuals. It's a report with 90 solid organ transplant recipients from 2 centers in New York. If you remember, back in 2020, New York was really an epicenter for the pandemic in the United States. And it really described the experience of the management of transplant recipients in the first 3 weeks of the pandemic. So as you can see, very early, we found that age contributes to the severity of the disease. So even though they are transplant individuals, if they are older, they have a higher risk of presenting a severe infection. Also, is very, very remarkable the percentage of patients, transplant patients, that require hospitalization. So that's about 76% required to be admitted. And the mortality on your right side, it went high if the disease was more severe than maybe a mild to moderate disease. And in here, if they had a severe disease, probably in patients that had to be admitted in the hospital, the mortality was around 60%, so quite high. So what has happened with COVID-19 and transplant individuals? And we're gonna compare it to the general population. Of course, there are many numbers depending on the age, on the comorbidities that the patients have, but I'm going to present a rough information about the general population. So let's talk about the first wave of COVID-19. We know that the general population, about 20% of individuals had to be admitted in the hospital, and the overall mortality of COVID back in 2020 was around 5%. In transplant individuals, the hospitalization, as we saw, was 76%, and the overall mortality was 28%. And that has been studied also in individuals who have the same age, adjusted for comorbidities, and being a transplant recipient increases this risk. So we moved and several variants started appearing. What happened with the Delta variant? With the Delta variant in the general population, the hospitalization, it depends on the series, but was around 15 to 20% with a mortality to 3 to 5%. And in transplant individuals, the hospitalization was still really high, 60% with a mortality of 10%. Now, a little bit of information more recent, and that probably is more relatable now. With the Omicron variant, we saw a significant decrease in hospitalization, 0.6% in the general population with a mortality of 0.03. Again, it can be higher in certain pockets of the population and certain groups of patients. Then with transplant patients, the hospitalization is around 10% with a mortality of 2%. So it's very clear that the pandemic is not over for transplant individuals. They're still getting admitted in the hospital. They're still getting having severe complications due to chronic, prolonged, acute COVID, and also they still have a significant mortality. So do all transplant recipients have the same risk of having severe COVID-19? The answer is no. It definitely depends. There are many factors and risk factors that contribute for patients to have a severe disease, not only being a transplant recipient. For example, if we have a younger individual, less than 30 years old, who is a transplant recipient, that probably is a lower risk compared to elderly individuals that are transplant recipients. Also, if it's a 30-year-old and has no comorbidities, that is a lower risk compared to someone who's elderly, who has obesity, who has diabetes, or have other diseases. There are independent risk factors for severe disease. It also depends on the vaccination status. We know that vaccines are protective for severe disease, so it's definitely a lower risk compared to individuals that haven't been vaccinated. And also the immunosuppressive therapy, even though it's really difficult to try to categorize and say this drug that is immunosuppressive is less immunosuppressive than the other one, because they all work in different ways and affect different pathways of the immune system. There are definitely some like rituximab or thymoglobulin who are really deep immunosuppressors that can have been individually associated with risk of severe COVID-19. So let's put an example. It's definitely an individual risk. Let's say that we have a transplant patient who had recent episode of rejection and had to be immunosuppressive drugs recently, but he also has diabetes, and he also has hypertension, and also has some chronic immunosuppression or is in high doses of prednisone. On top of that, he has a high risk of exposure, let's say healthcare workers, or he works in a school with small kids. And on top of that, he has obesity. So all these factors, regardless of the fact that he's a transplant individual, is going to increase his risk for severe COVID-19. Therefore, not all transplant patients have the same risk. So we can then say that the clinical course of COVID-19 in transplant recipients in many ways is unpredictable because it's based on their immune system, the immunosuppression that they're on, the amount of virus that they inhale, and also the comorbidities that they have. However, in multiple multivariate analysis, we know that the risk factors for severe COVID-19 are lung transplant individuals. Consistently having a lung transplant is a higher risk for severe COVID-19 compared to other organs like kidney, liver, or heart. Also, elderly individuals more than 60 years old, those who have more than 2 comorbidities, who have received rituximab, thymoglobulin, alemtuzumab, or belatacept in the last 6 months, and also who have proof of being seronegative after 3 doses of the vaccine. So to finish up, do transplant recipients have a lower immune response to COVID-19 vaccines? Yes, definitely they do. So this is a study that was published a few months ago in France. And what they did is that they published the experience of vaccinating kidney transplant recipients with a 3rd dose of the COVID-19 vaccine. They did this trial really in April 2021. And what they did is that they measured the anti-RBV antibodies after like 28 days after the 3rd dose of the vaccine. And as you can see in the color orange, these are 49% of the patients who received a 3rd dose of the vaccine and did not have any humoral response, meaning that they didn't increase the amount of antibodies after having 3 doses of the vaccine. And only 51% have and so only 49% have response and 51 did not have response after 3 doses. So the conclusion is that after receiving 3 doses of the COVID-19 vaccine, half of our transplant patients won't have a humoral response. Then what happens if they get 4 doses? If they get 4 doses, this is also a study from France. They included 93 kidney transplant recipients who receive a 4th dose of the COVID-19 vaccines, and they measure a different type of antibodies, anti-spike antibodies, 29 days after receiving a 4th dose. And they did a threshold of 143 of antibodies, and only 48% of the transplant recipients had above that level, which was considered protective in their cohort. So again, half of the patients, even with 4 doses of the vaccine, they don't have a good humoral response. What we have learned with all these trials is that the COVID-19 vaccines, including 2 boosters, are safe and are well tolerated. So what are the risk factors that are going to make transplant individuals probably not having not really a good humoral response to the vaccines? Well, that has been studied, and at least in transplant individuals, elderly individuals, just like in immunocompetent patients, age is a risk factor for not having a good response to the vaccines. Also having triple immunosuppression, which is extremely common in transplant recipients, that they are in tacrolimus, prednisone, and mycophenolate. Also receiving high doses of corticoids in the past 12 months or high doses of prednisone. That is also an independent risk factor. And probably one of the most known ones are having mycophenolate as maintenance. Having mycophenolate as an immunosuppressive drug has been associated consistently in multiple vaccines as a risk factor for not having good immune response to the vaccine. So what are the common recommendations? Currently, the transplant individuals, and actually not only transplant individuals, but moderately and severely immunocompromised individuals are supposed to have 5 doses of the COVID-19 vaccine. This is the current recommendation. That's also the current recommendation in Canada, receiving the 5th dose at least 4 months after receiving the 4th one. So my conclusions is the solid organ transplant recipients are in high risk of severe disease and death from COVID-19. As we discussed, the clinical presentation of COVID-19 can be variable. They have poor humoral and cellular response to the vaccines. And therefore, in addition to be vaccinated, transplant individuals and the people who live around them should continue with all public health measurements. And thank you for the invitation.
Thank you, Armel. Don't go away. We'll have a question and answer session shortly. I'd now like to turn things over and shift gears completely to the history of the Canadian healthcare system And this will be presented by Brian Postal. Brian was the founding president and chief executive officer of the Winnipeg Regional Health Authority, a position that he held for 10 years. Brian subsequently became the dean of the School of Medicine at the University of Manitoba, a position that he held for 2 terms. Brian is a pediatrician and has a great interest in the Canadian healthcare system, and therefore Brian's presentation is entitled "The History of the Canadian Healthcare System." Brian, the floor is yours.
Thanks, John. It's I guess I'll start by saying this is a fascinating story, really, that we're all continuing to be part of. That really began at Confederation, the BNA Act of 1867, and just in practical terms, whenever you're creating a new structure, there's a process of lumping and splitting. Who's going to be responsible for what parts? So health fell to the provinces as part of that BNA Act, although of course it was inconsequential in those days because there were no health expenditures. There were no health systems. There were a few things run by churches most predominantly. And the federal government, of course, had no responsibility for health care. The area of Indigenous health is still up in the air. It's largely seen as a shared responsibility, but the federal government has never exceeded that it's their responsibility. They do it as a form of common practice to them. Now, let's remember that there were no income taxes until the First World War. And then going in between the First and Second World War, there were a few developments in healthcare, largely rural or farm-based cooperatives in places like Sault Ste. Marie and Swift Current. World War II, of course, brought a whole different environment. Their government was full of enthusiasm and optimism. The taxes, of course, that were once put into the war effort were now available for other expenditures. There was a commission, the Roel Sirois Commission, that really developed all of the social networks that Canada now enjoys. Canada Pension, Old Age Security, Family Allowance was initially part of that, but nothing related to healthcare. Although around 1948, the federal government, because they were still flush in cash, did some grants in aid and really funded a huge amount of capital expansion of hospitals across the country. Many of our facilities in Manitoba were part of that funding. Now, every 10 years after that, there have been kind of new developments. In Saskatchewan in the mid to late 50s, Tommy Douglas as premier was really engaged around the issue of trying to improve health services. And just to remind you of the political nature of healthcare in this country, you might remember that about 15 years ago, the CBC had a contest to determine who the most influential Canadians in our history were. And the two, first and second, first was Tommy Douglas, which tells you how important healthcare is to our psyche. And the second, of course, was Gretzky, which tells you how important hockey is to our psyche. So those two H's were important. But in 1957, in the earlier 50s, he began in Saskatchewan. And then finally in 1957, the federal government launched the Health Insurance and Diagnostic Services Act. It took provinces 2 to 3 years to get on board because that split between jurisdictions, provinces have always guarded their capacities around healthcare very jealously. They don't want the feds getting involved in healthcare, but I would say what they want is more money from the feds, and I'll get to that in a second. There was a subsequent doctors' strike in response to further discussions as Saskatchewan moved forward to ensure physician fees. And the result of the doctor's strike, A, it was generally broken, but secondly, there was a bit of a guarantee that physicians would always be able to remain as independent contractors. And that to this day is part of ongoing discussions. In any case, following that, the Royal Commission was struck, Emmett Hall as its lead, and in 1964 reported the need for a nationwide medical system. And in 1967, Medicare was introduced with 4 key constructs. One, that it be portable between provinces, that accessibility had to be very high, it had to be comprehensive in its nature, and had to be publicly administered. So these, especially the public administration part, remains a key part of ongoing debates. Now, once again, it took the provinces several years to get on board because they didn't like the federal insertion. The feds offered 50-cent dollars, which was a huge contribution. But it was really an all or nothing thing. If the provinces wanted these 50-cent dollars, they had to abide by the rules of Medicare. And this is one of the probably flaws in our system. Both hospital insurance and Medicare came in by developing a basket of services that frankly included physicians and hospitals as their main components. So all of the other services that now exist are outside of that basket unless someone has chosen to fund it. Now the feds, and this was the first, the provinces will routinely accuse the federal government of baiting and switching, i.e. enticing them to get on board with expenditures and then pulling out. In 1977, the feds, so this is within 20 years of the onset of hospital insurance, decided 50-cent dollars were too expensive. So they passed what was called the Established Programs Financing Act, which in essence changed the funding formula to be roughly a per capita and disease weighted allocation to each province based on expenditures, and vacated tax room that the provinces moved into. So the 50% was replaced by roughly 25% in cash and roughly the equivalent in tax room. Now the provinces, of course, when they're describing the federal contribution, refuse to acknowledge that tax room, which of course then drives the federal government crazy in this debate about who should be paying for what. Now, the things cruised along, and once again, about a few years later, 1982, extra billing had been commonplace across the country and reached the point in some jurisdictions of excluding access for patients. All of the physicians were extra billing, leading to a second Royal Commission, also with Emmett Hall, who thought we should ban extra billing. In 1984, the Canada Health Act did ban extra billing, and the vehicle they used was, I said it was all or nothing under the previous acts. This now said the federal government could withhold dollar for dollar any extra billing amount going on in a province. So it was a fascinating move and change. Interestingly, the withholding has never been used by the federal government for any time in the history of healthcare, with the exception of a threat in New Brunswick when they still weren't allowing therapeutic abortions. Now, so that takes us to the early 80s, the early 90s. There was, of course, a great fiscal crisis with Paul Martin as the finance minister. There was truly cutbacks at this point. Transfers were reduced to the provinces. There were widespread bed closures in this province. Some of you might remember Connie Curran coming to say she can find all kinds of savings. She did not. But in any case, it was a very stressful time, not too different from what's being experienced now. And then, of course, in the late 90s, regionalization occurred in Manitoba with a large number of regions. We were late to the game. Regionalization was much farther ahead in most other provinces. And of course, we came out of the 90s with huge issues because of the cutbacks, with waiting lists, with access to services. Many physicians had led the country for the United States, many nurses, and led to a recognition that more money had to come into the system. So in 2003, 2004, there were 2 healthcare accords that the feds actually came to the table with money for wait times, $5.5 billion. a guaranteed escalator in annual grants that was generally in the range of 6 to 7%. It was a 10-year effort, and they put extra money in primary care development, in mental health, and in home care. They're still talking, of course, mental health and home care. Nobody's talking primary care anymore. It's been totally abandoned by governments because nothing they've done, despite billions of dollars, seems to have changed it. Now, the provinces were expecting 10 years later to have another accord, and we're gearing up. It was quite fascinating to be part of for the debate and the negotiation about what's coming next in the hopes of getting more money from the federal government. The Conservative government of the day showed up and said, we're not negotiating anything. There's no new accord, and you're going to be limited to cost of living or 3%, whichever is greater. Now, through this period, regionalization began transformations. All provinces moved to fewer regions. Several moved to single regions for the whole province. And much of this, of course, was tied to the concept of transformation, where although there were changes made, austerity was always part of the transformation, and it became very confusing, certainly to folks working in the system, what was transformation to make the system better and what was austerity. Now, in the last decade, there's been a shift right politically across much of the country. There's been a huge effort to cut taxes in those jurisdictions. In our province, we've cut about $1.3 billion in taxes. And unless you have new sources of revenue, like Alberta does sometimes with oil, you can't cut taxes without cutting services. And healthcare being roughly 45% of all provincial expenditures means you've got to cut healthcare if you're going to cut taxes. So all of these things came together, and unfortunately also had COVID superimposed at the same time. We had these austerity measures. We had restructuring, in part tied, but not completely tied to austerity. And of course, the impacts of COVID. So we've seen a huge increase in wait times. Morale of staff is low, losing personnel to either retirement or other roles, and really approaching the same set of phenomena that occurred both in the early 90s and in the early 2000s. Now we're beginning to see more expenditures in healthcare, largely related to polling results, and the recognition that once again, we've gone too far on the austerity side and need to put money back into the structure. But it's always the same game, which I've always found fascinating, that the provinces don't want the feds involved except to give raw cash. And they don't want the feds to dictate how that cash is going to be spent or how its impacts will be evaluated. So they want it unfettered. The feds don't want anything to do with that because, of course, they get no political credit for those kinds of expenditures. The feds will be putting more money in as well. It's quite clear. They've announced dental service programs that are beginning. Pharmacare remains high on the agenda. Mental health high on the agenda. Personal care home debacle through COVID-19, in particular with private personal care homes where morbidity and mortality were higher by far. Money for home care, and of course it's quite likely that they'll put some money into capital supports as they negotiate this with the provinces. I don't see them giving more money to the provinces to support the provincial healthcare systems as a general contribution. So we've got these bipolar responses, federal and provincial, to healthcare, the province with the constitutional responsibility, the feds with spending power, but no authority, who, if they're going to spend money, want to spend it in ways that they think serve the entire Canadian public and for which the federal government can get some credit. So this is not a marriage made in heaven. Neither side trusts each other. Both are trying to perpetually claim credit with the voters, which is always interesting because money only comes from one source. But I think this saga will continue, and you'll see this debate between the feds and provinces in an ongoing way, probably for the rest of your careers. So John, I think that's a 15-minute synopsis of what's gone on, and I know there'll be questions later.
Thank you very much. Now, we've invited Ronan Seagrave to give a presentation entitled The Future of Healthcare in Canada. Ronan is currently the Senior Vice President and Head of Digital Healthcare Consulting at Narima Consulting. He has advised healthcare systems across Canada in relation to digital strategy, optimization, and COVID recovery. Ronan was previously the Chief Operating Officer at the Health Sciences Centre, which is how we know Ronan. Ronan previously worked for KPMG's National Healthcare Consulting Practice and led the Health Sustainability and Innovation Review for the Manitoba provincial government. Now, I suspect that it is impossible to predict the future of healthcare in Canada. So this topic allows for some blue skying, some imagination, and probably some provocative thoughts. Ronan, the floor is yours.
Well, thank you very much indeed, John. It's a pleasure. Greetings to you all. I'm in Edmonton today. It's great to be attending this wonderful event every year. I wanted to start actually and shamelessly take this opportunity to pay my personal tribute to John Emble. As John said, I was Chief Operating Officer of Health Sciences Centre for 3.5 years, and through really the first 18 months of the COVID-19 pandemic. And I'll talk a little bit about that in my presentation, but the work that John and his team did was incredible, and it saved lives. And John always made himself available. He'll remember the COVID chief meetings well, always made himself available for phone calls, meetings at any hour of the day and night. And those are things that as we move forward that I will never forget. And I'm deeply grateful for his work and for his friendship. And it's great to be with you this evening. John, I'm going to attempt to bring up the slides here. Please, I click on share screen. Yeah. So it's great, as John was saying, I now work for a company called Narima Consulting, where we have the privilege of doing some really interesting work across Canada in the current context. And just to start off with just a bit about the landscape, I mean, roughly 265 billion spent on Medicare in Canada. As you know, it's largely a universal healthcare system. There are some gaps, but it's largely a universal healthcare system. It is, as Brian was saying, primarily funded and administered. Okay, I'll plow on. Anyway, I'll talk through a lot of this anyway. In looking at the expenditure, as I say, it's about 265 billion. I'm going to talk a little bit about the last report released by the Commonwealth Fund. And what that does is it looks at top 20 OECD countries and compares to various international benchmarks the differences between those systems. And I think a mistake that often is made is we automatically start comparing ourselves to the United States of America. I'm going to argue that we should not be doing that, and we should be comparing ourselves to similar OECD comparative countries that are largely publicly funded. In the last report last year, it does reveal some unpleasant truth about Canadian healthcare, and these truths were true prior to the COVID pandemic. It certainly were better than, if you value things as I do, like universal access to healthcare, we're better than the Star-Spangled system south of the border. But quite frankly, we're just about worse than every other developed universal healthcare system in the world. And when we look at it, at the expenditure, the spending is at an all-time high. Brian talked about obviously the various politics that plays through around federal and provincial government contributions. But I would argue that the spend is becoming unsustainable. We're looking at 35–40%, some provinces even ticking nearer 50% of their budgets being spent entirely on healthcare. The true costs of healthcare are probably unclear due to, frankly, data quality issues. Our system is expensive by international comparisons and by talking about those comparator OECD countries. And the data from the Commonwealth Fund report, and indeed others, demonstrates poor value in terms of both quality and outcomes. We know, and other speakers will be talking about, issues that impact our health system, such as lack of access to family doctors, the overuse of hospital emergency departments, and resulting in sort of hallway health and corridor care, things that you're all familiar with and many of you deal with day to day. What's very interesting around that, happening right now, is an increasing and, in my view, necessary public debate around demand for reforms, looking at service improvement, and if it wasn't already, healthcare is becoming a top political priority in I've mentioned just 4 of the largest provinces, but I think you could say in every province in Canada. So when we start looking at data and reports, how well are we performing here in respect of OECD comparator countries such as Germany, the United Kingdom, Australia, France, etc. And it's not good in respect of Canada. We're one of the highest spenders among universal healthcare systems, and our performance is modest to poor. So if we're looking at healthcare spending, percentage of GDP, top 20 OECD countries, we're number 2. Only Switzerland is ahead of us. And when we start looking at metrics around doctors per 1,000, quality metrics, including things like specialist weights, we're performing poorly. And in 2018, after adjusting for age, Canada ranked 7th out of 28 high-income universal healthcare countries for healthcare spending per capita. And frankly, the blunt facts are that we operate a remarkably inefficient healthcare system with a world-class price tag for taxpayers. I believe, as I'm sure you do, that there is a compelling case for change. There is, in a democracy, there should be healthy and open debate around what those changes should be. But we simply have to accept that there's a fairly growing body of international evidence that our performance does not match or equate to what we're spending in terms of our investment inputs and the outcomes that we're getting when compared to other international jurisdictions. There is an imbalance, in my opinion, between the value that Canadians receive related to the relatively high amount of money we're spending on healthcare. We have to accept that our current high rate of spending compared, as I say, to our international comparators does not correlate with higher relative performance on key measures of access, outcomes, and equity. Key things that I believe any healthcare system should be judged on. And the data is also showing that there is suboptimal use of resources. In other words, we're just not targeting our money in the way it should be. Of put some slides there around sort of wait times and around CT scanners and MRI units and how we're sort of really lagging behind. So we have to accept that there is a problem here, and it's a problem that cannot be blamed on COVID. It existed prior to COVID. With the COVID-19 pandemic, in my opinion, has made a lot of this worse and has increased the pressure and focus. And indeed, as I say, what I think is a very valuable debate and a real national conversation we need to have on the future of our healthcare system. So as I say, if we look at the trends, Commonwealth reports, other international reports, it's all telling us the same thing. We're performing poorly against our international peers. We have, and I know these are not unique to Canada, but they are exacerbated in Canada in terms of workforce and skill shortages, things like family doctors. We're spending, compared to our international comparators, we're spending more and we're getting poorer value. We also perform more poorly against our international comparators in relation to access and wait times. And of course, just opposing all of this is the demand side, where we have an aging population with increasing complex needs. The shift that's been happening over the last 20, 30, 40 years in relation to growth in terms of lifestyle diseases, chronic conditions such as type 2 diabetes, COPD, CHF, etc. We're living longer, and this is only going to increase the pressure in relation to demand in our healthcare system going forward. And clearly, COVID-19, the pandemic, obviously it's been a global tragedy. I'm sure many of you, like me, were impacted personally by it. But my point here is that we were not in great shape nationally before the pandemic hit. And those issues in relation to how our health system is structured, I think, exacerbated the impact of the pandemic in Canada. If we're looking at how much has been spent to date, most accurate data I have is anything between $35 to $40 billion in increased cost for healthcare. And as Brian was talking about, the debate in relation to the provincial governments and the federal governments is ongoing, and increasing demands by premiers for the federal government to raise its share of health funding. The mechanism is known as the Canada Health Transfer, from the current level of about 22% to 35%. So all of those politics are playing out. The issues in our workforce were there prior to the pandemic and are there in many other countries. But again, this has been exacerbated. I've just put a clip of a book written by a guy called Mark Britnell, and this was published prior to the COVID-19 pandemic. And he was talking at that point about a global workforce crisis. He estimated globally that the gap in terms of workforce that we will need over the next 20 years is something between 40 to 80 million people worldwide. But we know that the pandemic has greatly exacerbated these pressures on our workforce. Those of you working directly in healthcare will know about the high attrition rates. Critical care nurses, ED nurses, things like PTSD, things we don't talk about a lot, but we should talk about a lot more, and how that's impacted our staff. Issues that have been occupying a lot of my work recently in advising systems around surgery and diagnostic backlogs. Staff who are redeployed in respect of mainly surgery nurses and anaesthetists who are redeployed from ORs and inpatient surgical units with surgeries postponed into the backlogs, deployed into critical care and medicine to deal with surges of COVID patients. Brian talked about all of the tragic issues in relation to long-term care and care homes. We've seen an increase in retirements. People, not just frontline staff, including executives who are nearing retirement and deciding that perhaps the stress of the pandemic was the final straw. Workers moving to other industries, phenomenons of nurses moving to the United States to become sort of traveling nurses there. Efforts now prior to the pandemic around reduced immigration of healthcare workers that we're now trying to really reverse. And an ongoing issue that really does predate the pandemic, and it's not just in Canada, but the desire of every health system to have people working at their full scope of practice. And while productivity in healthcare is poor compared to other sectors, it's particularly poor in Canada, as again, those international reports state. So we've got to not just look at filling workforce gaps, we've really got to start thinking about working a hell of a lot smarter here in terms of how we're using our resources. I'm not going to dwell too much on these because you know about these things in respect of the backlog, in respect of surgical procedures, diagnostic procedures, etc. All jurisdictions and provinces are working through various strategies to try and address this. So what are the options for reform? And in no particular order, and these are all things that are playing out in TV articles in newspapers, think tanks, you name it, they're talking about these things. And none of these things should be interpreted as a personal endorsement by me. These are just things that are being talked about. So a lot of talk around funding and payment models, the need to, rather than paying for fee for service or just using global budgets, if you're looking at hospital funding, to move to different types of payment mechanisms and funding mechanisms that reward value in terms of better outcomes for patients, better clinical outcomes, rewarding efficiency. Also looking at more population-based funding. Our funding should reflect the populations that we serve, and particularly targeting funding better in relation to populations that have greater health needs. The debate has also included things called publicly funded multiplayer Medicare plans. So in other jurisdictions, such as Australia, the Netherlands, and I could also include Germany, instead of just being, your provincial Medicare system, there are competing payer plans that are from private insurers that are publicly funded. And that the reason those systems have gone down that path, again, is to drive better outcomes, drive greater efficiency in their healthcare system. And it just so happens that the Australia and the Netherlands perform better than Canada, those OECD comparators. That doesn't mean this is automatically better, but it suggests from my mind this is something that perhaps should be looked at. An incredible amount of debate in respect of private sector provision. And what I'm talking about in this bullet point is private sector provision, but it's publicly funded. It is covered by Medicare. This includes things like diagnostics and MRIs, and it includes things like ambulatory surgeries and private clinics. For me, what matters around this is value for money. Does it increase access, and does it improve outcomes? And are we measuring and comparing private sector provision with public sector provision? Even more controversially suggested by some is people deciding that Canada Health Act needs to go. We need reform. We need to allow Canadians to be able to buy private insurance covering the range of services currently covered by Medicare. The number of court cases that have gone on around this, it's highly controversial, and a lot really depends on your personal philosophy and beliefs. But it is, again, being debated. Lots of talk, and COVID really accelerated this around using technology. We just need to work a lot smarter, using sort of virtual hybrid care, advances that have happened in things like artificial intelligence and robotics, things like something called robotic process automation, which allows a lot of tasks to be automated. I think whatever about some of the other things here, this is something that's going to happen and is happening. The issue will be the pace and scale, and that ensuring as we do these things, again, we're ensuring we get better outcomes, we get better quality care, and we deliver better value for money. Health spending accounts, there are other ideas that are being floated. This is around sort of trying to encourage people to take greater accountability for their health, and we're giving them some dollars by governments and allowing them to perhaps have greater flexibility around how they spend that money. And that's part of a kind of nudge theory type thing, that you're getting people to take greater accountability by giving them actual money that they can spend. Again, something I think is happening and is going to happen anyways around new healthcare roles, different types of workers, both professional and non-professional, a much sharper focus on the scope of practice issue and having people working at the full scope of practice, a much greater shift towards team-based models and addressing the productivity gap. It's not a question that we can't right now, we absolutely have to. Brian was talking about this, and I'll talk a little bit more about this, is adopting something what's called a more radical shift left approach. You'll see this language being used in other jurisdictions. The healthcare system in Ireland is embarking on this right now. And this is a fairly sort of radical reorientating of a health system to being primary care led, not acute care led. Other jurisdictions are looking at sort of structural issues and the need to sort of break down barriers between primary and secondary care, and indeed between social care and long-term care, and creating what's called fully integrated care systems, bringing organizations together, merging budgets, backing that up with greater accountability to local populations. Again, developments in New Zealand, Australia, the United Kingdom are moving in that direction. My personal view is that not any one of these single things, whether you agree with them or not, it was going to solve our problem here. I think what in reality will be a combination of all or some of the above. As I say, one or two are happening already, but there isn't one single thing that we can do here that will help address this problem. It's going to be a combination of some or all of these things. As I talked about, the media is focusing on Canadian healthcare in a daily basis. The word crisis is being used sort of continuously. Again, I talked about privatization. I talked about the two really, really separate things around that. One is around the use of private healthcare facilities or providers for publicly funded procedures under Medicare. The second is would require a change to the Canada Health Act or some repeal of it that would allow Canadians to buy private insurance for services covered by Medicare. Depending who you ask and depending on which one of those two things you're talking about, people generally say this is a growing threat, this is not the answer, or others saying, I think this could be a potential solution in terms of access and increasing access, dealing with our backlogs and the staffing issue. We've got to remember that for-profit clinics are nothing new in Canada, and certainly nothing new for surgeries in many provinces. And medical practices have existed to varying degrees across Canada. We've had commercial agencies filling staffing shortages. There's obviously concern around that in terms of the cost to hospitals and taxpayers and whether that's delivering value for money. But certainly, private surgical clinics are nothing new. They've existed in many jurisdictions, and in many jurisdictions they've been used for a number of years prior to COVID, and have had contracts to deliver publicly funded healthcare procedures. The issue now, I think, is around the size and scale of their role going forward, as opposed to not having a role. I talked about shift left, a left shift, and what does this mean? So this is a kind of a generic slide, but it really summarizes a lot of thinking and work in a number of jurisdictions around how things need to change. And it starts off where it should start off, right at the left, about us, patients, our family, our communities. The need to shift to a much more population-driven service planning. We have analytics and technology that can help analyze our populations in great detail and segment our populations in great detail. That can give us very powerful data around how we can better target prevention around health protection. Looking at place-based coordination, showing no matter where you live in Canada, services are coordinated and integrated. Using that to reshape our workforce and our assets. Using some of those natural assets in our communities better in terms of supporting healthier lifestyles and active lives and mental well-being. Looking at, as I say, a greater role for primary care in relation to case management, in relation to helping people self-manage their care. Looking at the integrated teams that revolve around primary care, ensuring multi-channel access for patients, and building on the rapid developments of COVID around virtual care and other models, creating more expert generalists in the community. As I say, those integrated teams, one place, one team, in terms of combining medical, nursing, and social care. Increasing role for primary care in relation to diagnostics, given advances in technology. Creating pathways that go across the whole system and that constantly try and support patients with that shift left model, not referring patients to specialists where that's either not needed or in their best interests, and avoiding, as I say, preventing unnecessary attendances at emergency departments. One patient, one record. And actually, I believe that the person who owns an electronic medical record or electronic patient record is the patient, who should have access to that record and control of that record at all times. And again, being really clear around what's the future role of secondary and tertiary care. And again, how that needs to change in relation to interacting with patients. Clearly, that means big changes in relation to sort of capacity and capability, better analytics, changing role for workforce, better workforce planning, new workforce models, ensuring that the collective voice of patients is not just heard, but actually leads the redesign of our healthcare systems, looking that we have the right leadership and government models to make the changes. So in conclusion, I believe that the need for change here is not just necessary, I think it's unavoidable right now. What the coming months and indeed few years will pan out is how and in what way those changes will take place in Canada. I encourage all of you to engage in this debate. I think it's a really, really important one. I'm really, really glad it's happening. And I'm really, really glad that I was able to share some perspectives with you today. And thank you.
Thank you. So we're running a little short for the question and answer period. There are a number of excellent questions that are all sort of getting at the same thing. So I'm going to try and combine them. And these are questions for both Brian Postal and Ronan Seagrave. Canadian geography is vast compared to many other countries. And in Manitoba, the geography is really unique because we've got southern pockets and then we've got northern pockets, and the distance between the northern pockets and the urban centers is vast. How can we consolidate and streamline the delivery of care? Because I'm certain that in Manitoba, a significant cost is just transportation and accommodation for patients and their families. Now, of course, some of that is provincial money, some of that is federal money. So as we often see, not my budget, not my problem, how do you reconcile what we've got, and how can we streamline the delivery of care? And then part two of that, how can we integrate other workers? There are a number of questions about physician assistants, which we've seen to be an incredibly valuable group of workers in the healthcare system. So Brian And Ronan, your thoughts?
Well, I think on the geography point, yes, it is vast, but so is Australia. And why is it performing better? Question. So when we look at our comparator countries, even if you look at Scandinavian countries that perform better, they're large, they're cold, and have vast amounts of emptiness having traveled around them with also rural populations. So what are they doing that we're not? Number one, care is better integrated. They've made more progress in relation to that shift left model. They're making better use of technology in respect of virtual care, now looking at virtual reality, augmented care, how specialist physicians in your tertiary centers support populations remotely, etc., and using that technology. They're simply doing those things. They're simply ahead of us, and they're arguably doing those things better. For me, if you're living in a remote rural area, it's about access, but it's also about ensuring that the models that we develop and utilizing technologies are safe for delivering quality. Simply sort of building more hospitals there and providing more services wouldn't be safe, because we know the issues around relation to volume and quality and safety and experience of physicians. So I think there's learning from our international peers. There's learning around, and a point I would also make is pace. I think looking and my work over the last 18 months in particular, I see other jurisdictions moving faster.
Ronan, I have to say, I kind of disagree with your perspective. There are
Feel free to do so, Brian.
There are no countries or provinces that have the vastness and the degree of population. And I think we repeatedly make the same mistake, that a lot of our healthcare resources are required to be spent on Indigenous people. When we do international comparisons, we do age sex matching as a way of saying we're comparing oranges to oranges. That's nonsense. Unless we're also matching for morbidity, mortality, social services, children in care, all of those surrogates, we're not comparing oranges to oranges. We're really not even comparing fruits to vegetables.
So you wouldn't see, Brian, a comparison with Australia and its vast emptiness, no?
No, because there's very few people living in it. And they don't have the kind of transportation issues that are routinely faced.
Really?
So we're dealing with a very different world. And I think this need to compare internationally is useful, because I agree the OECD stuff is important. But let's remember, most of those OECD countries have single systems. They don't have 13 systems begging for money from a national government.
Australia has state systems, Brian, in terms of...
Yes, but the federal government, and to be clear, the federal government has had to subsidize the private model there because it was failing when it was first put in place. So I think all of these things...
They still perform better, Brian.
We're living in a very different world. And I think when we're making these comparisons, I think we need to acknowledge that.
So I'm going to end that conversation. One question for Dr. Villalobos, and that is, we saw how transplant recipients performed when they didn't go to the ICU. Do you have any data on mortality in the solid organ transplants who ended up going to the ICU?
Yeah, that's a very interesting question. It also varies depending on the different strains and variants of the virus. In the first wave, as I show, like they had like 60% of mortality for the patients who got admitted in ICU with severe COVID. And more recently, it has decreased. I'm not really sure. I believe that is like around 23% of patients who get admitted in ICU. So it has decreased with Omicron too.
Thank you very much. I'll end this session and we'll switch gears and move into the next session. I would like to remind everyone that Dr. Bullard will be speaking about pediatric COVID vaccination from 12:45 to 1300, and Lane Torograd will be speaking about germaphobia between 14:15 and 14:30. Now, the next session, I hope, is of interest to the entire group. The Health Sciences Centre is a member of a collaboration entitled Canadian Nosocomial Infection Surveillance Program. And this is a program that collects data, interprets the data, and shares the data. And that data pertains to facility-based infections. And what we tried to do is get 3 topics of interest to allow the audience to see what the Canadian Nosocomial Infection Surveillance Program is doing, but also where we're at with all of Canada's germs. And the first presentation is entitled Canadian Nosocomial Infection Surveillance Program, Keeping an Eye on Canada's Germs. And we have lots. Our 2 speakers are Kelly Choi and Robin Mitchell, both of whom are epidemiologists with the Public Health Agency of Canada. Linda Palud, who was one of the speakers who was meant to give this presentation, unfortunately had a conflict, so Robin Mitchell will step in at the last minute. So let's find out what's going on with Canada's germs. Ladies.
Oh, hi, John. Thanks very much for having us today. It's a privilege. Can you see my slides and everything okay?
Perfectly.
Okay, great. So Kelly and I will start off by just providing an overview of the Canadian Nosocomial Infection Surveillance Program, touching on a few of our objectives, and then we'll be describing and talking to you about a few new projects and initiatives that we're going to be moving forward with, and hopefully they're of interest to some of you to join as well. And so we can see here on the map on the left how CNIS has expanded over the years. And so we started in 1995, and now in 2022, CNIS captures approximately 35% of all acute care beds. And so you can see here kind of the distribution of the sites. So the black dots represent kind of the bed sizes and the location of the hospitals. And so CNIS is a collaboration between the Public Health Agency of Canada, and that includes the National Microbiology Lab, as well as the Association of Medical Microbiology and Infectious Disease, so AMI Canada, and then the Sentinel hospitals across Canada who participate. And so as you can see here, CNIS has expanded to include 90 hospitals in 10 provinces and 1 territory. And typically, historically, I guess, CNIS has included kind of large tertiary acute care hospitals, but since we've been expanding, we've also included more rural, community, and northern hospitals. And as John mentioned, CNIS conducts surveillance of healthcare-associated infections, antimicrobial resistant organisms, and antimicrobial usage. And so this is just a quick overview of the process of CNIS. So on the left, you have a participating hospital, and they send their isolates to the National Microbiology Lab in Winnipeg, where molecular and microbiological characterization of these isolates is performed. And then that data is then sent to CNIS centrally. And at the same time, the hospital is also completing standardized patient questionnaires for all eligible patients through chart review. And so we collect demographic, clinical data, risk factors, and outcome. And so that data is also submitted to CNIS. And so the lab and the epi data are linked, which is quite a valuable resource. And so that's some of the data that we'll be sharing with you today. This is a timeline of CNIS surveillance projects going way back to 1995, and it shows our first surveillance project was MRSA. And then you can see as organisms have emerged, we have added them to our list of organisms that we conduct surveillance on. And so recently in 2017, we added MSSA, BSI, as well as antibiogram, and conducted a point prevalence survey. So that's the kind of the green dots there on the middle of the timeline. In 2019, we started conducting surveillance for Candida auris, as well as viral respiratory infections. And this year we started to pilot an adult cardiac SSI surveillance as well. We have also initiated a standardized or simplified data set for CDI, which Kelly will go into more detail. And then we're also planning on conducting a point prevalence survey in 2023. And so one of the main goals of CNIS is to monitor trends in national infection rates, to look at organisms and strain types, and monitor AMR and AMU. And so this is just an example using MRSA bacteremia rates of some of the data that we produce. And so you can see here, we've stratified our MRSA rates by whether the patient acquired their infection in the community or in the hospital. And we can see community rates of MRSA BSI are increasing in recent years, whereas the healthcare associated rates have remained relatively consistent. And then on the right, we see a figure of MRSA BSI all-cause mortality, which has remained consistent. So this is just kind of an example of some of the data that we produce. And next, we have also recently developed and launched an interactive data blog on the Government of Canada website. And so the goal of this is just to make the data as accessible as possible to kind of those who need it most. And you can see here, this is a screenshot on the left. And so there's several tabs. There's an overview tab that describes CNIS, so some of the things I've just mentioned. Another tab that looks at HAI and AMR rates, and then another tab that looks at all of our AMU data. And so if technology will work well with me today, we have this is the website live right now for you. And so this is the overview page, and it just shows you, you can kind of toggle through things. We have a list of all of the participating hospitals and their bed sizes, a list of recent publications. And then we've now scrolled over to our antimicrobial use page. And this is just, we don't need to kind of look at all the data, but it's just to show you how you can stratify the data, you can toggle through things, and just kind of pick the data that you're most interested in. And so this is the AMU data, and you can see how you can select the class. If you hover over items, it will provide the data point for you. Again, this is AMU stratified by ICU. And then our HAI and AMR page, we're just working on it, but this is kind of the plan right now, what it'll look like. So you can see we have our CDI, MRSA, VRE, and CPE rates, and that you can stratify those rates by community-associated healthcare, by region, and it's just an example of how you can kind of toggle through all of this and highlight the data. And then we also have our resistance data as well that you can kind of play around with. So all of this is, the AMU data is currently available. We have the website at the end of the presentation. And this is ribotype. So we've pulled together all of our lab and epi data into this one location. And then also our surgical site and device associated infections. You can stratify by types of hospitals, whatever is kind of most applicable to your needs. So that's a very quick overview. As I said, the website is at the end of our presentation. So if you want to go through it in a bit more slow motion, then it is available. And so we also, every year, we produce 2 surveillance reports, and they're published in the CCDR. One is looking at our healthcare associated infection and AMR rates, and then the other is looking at device and surgical procedure-related infection data. And so those are available in the CCDR annually, and we just recently published in the summer our most recent surveillance report. And so we have the link for these as well at the end of the presentation, if those data are of interest to you. And then another method of kind of disseminating our information and helping inform practices and public health action is peer-reviewed articles to disseminate the data. And so these are just 2 examples, some CDI and some COVID data that we have recently published. And then another use of the data, which the Sentinel hospitals find quite useful, is we produce very specific site reports. So your hospital receives, this is an example of an AMU site report for adult hospitals. And so they receive a report of their data compared to other hospitals that have submitted. So that's kind of a benchmarking report back to hospitals. So those are just examples of some of the things that we do with the data. And next are some kind of future directions that we're moving. As I mentioned, we are conducting a point prevalence study in 2023. So at the end of February, beginning of March is our goal. And this will be looking at all Canadian acute care hospitals. So this is not just limited to CNIS participating hospitals. If you're not currently involved in CNIS and would like to be, we will be extending this survey to other Canadian hospitals. We'll be doing a call out shortly through IPAC Canada and AMI for those that are interested in participating and providing a little bit more information. But if you are interested, please do let us know. And you can email us. We have a generic email at the end of this presentation. And then the subsequent year in 2024, our goal is to conduct a point prevalence survey in long-term care with the plan of eventually branching out into long-term care surveillance. So that's kind of our starting off point in the future. And next, I will just pass it along to Kelly, who's going to speak to the simplified data set portion.
Thank you, Robin, for a great presentation. So our next CNS initiative is the Simplified Dataset, shortened as SDS. Currently, as Robin mentioned, CNS covers 35% acute care beds in Canada. So our goal is to expand our representativeness through SDS. So we would like to use this opportunity to invite hospitals in Canada to join SDS surveillance. Just like the name, it is a project where hospitals submit simplified data such as hospitals' annual aggregate number of infections. Currently, we start with CDI and respective denominator data, along with few pieces of your hospital information, such as bed size and hospital type, etc. This will not only help increase representativeness of HAI national benchmark rates, but there are other numerous benefits for hospitals to join SDS. The first thing is hospitals will have access to our secure online platform called Canadian Network for Public Health Intelligence, short form as CIM5. As I said, it is a secure online platform where hospitals can submit data and have access to online interactive visualization. In there, hospitals can compare their HAI rates between your hospital and other Canadian hospitals, for instance, by bed size, region, and hospital type, and so on. So this will help hospitals to provide evidence-based data to inform your infection prevention and control programs, and also provides knowledge sharing opportunities with other hospitals across Canada. And the next slide shows, next slide, please, Robin. Next slide shows how does SDS work. Once you join SDS, we will assign your hospital unique ID for CIM5 platform, and you can apply for a new account. From there, you submit your annual data, and you can use and enjoy data visualization. Next slide, Robin. So this is just a repeat of what I introduced, but it is there for you perhaps to talk to your hospital staff for joining program. So we love to have you join the Simplified Dataset. Thank you. And now I'd like to turn it over to our colleague Jessica and Anada for their talk on HAIs and AROs.
Thank you, Kelly. Thank you, Robin. So Anada and I will be presenting on healthcare-associated infections and antimicrobial resistance data that we've captured via CNIS surveillance. And so again, to reiterate, CNIS is a national acute care hospital surveillance system that we work as epidemiologists for. And so just a couple housekeeping notes on acronyms. From here on out, we'll refer to healthcare-associated infections as HAIs, antimicrobial resistant organisms as AROs, and the Canadian Nosocomial Infection Surveillance Program as CNISP. Next slide, please. So we have three key objectives for this presentation. We hope that following this presentation, attendees will be able to, one, describe the HAIs and AROs under surveillance in Canadian acute care hospitals participating in CNISP. Number two is to describe the epidemiological trends of HAIs and AROs in Canada based on data from CNISP participating hospitals. And number three is to describe the key highlights and changes in Canada's AMR landscape based on data CNIS has collected from CNIS participating hospitals since 2012. Next slide, please. A few data notes to keep in mind during our presentation. These surveillance findings are based on data collected to date, and they may change as additional data becomes available. These results, they may not be generalizable to all Canadian acute care facilities. As mentioned, CNIS captures roughly 30% of acute care beds in Canada. But in recent years, we've expanded to include hospitals in 10 provinces and 1 territory, and rural and community hospitals. So this has helped us improve our generalizability. Further, for data stratified by region, when we discuss the Western region, we're really referring to data from BC, Alberta, Saskatchewan, and Manitoba. When we discuss the Central region, we're referring to data from Ontario and Quebec. And when we refer to the Eastern region, we're referring to data compiled from New Brunswick, Nova Scotia, PEI, and Newfoundland. Next slide, please. Great. So part 1 of our presentation will focus on 4 pathogens. So the first is C. difficile infection, or CDI for short. The second is methicillin-resistant Staphylococcus aureus bloodstream infection, or MRSA-BSI for short. The third is vancomycin-resistant enterococci BSI, so VRE-BSI. And the fourth is carbapenemase-producing Enterobacterales infection, which we'll refer to as CPE infection from here on out. Next slide, please. Great. So this is a timeline of CNS surveillance activities, and it shows, again, the HAIs and AROs under surveillance in Canadian acute care hospitals participating in Canada. But we're showing this again to really highlight when surveillance of these 4 pathogens started. So MRSA-BSI is our longest running surveillance project, and that started out in 1995, the same year CNS was created. Soon after, we started VRE-BSI surveillance in 1999. In 2007, we started surveillance of CDI, and in 2010, we started surveillance of CPE. Next slide, please. So here we present a slide, and it's based on data from CNS participating hospitals. We present the epidemiological trends for CPE infection, VRE-BSI, MRSA-BSI, and healthcare-associated CDI. So between 2012 and 2021, we observed the largest percentage decrease in incidence infection rates for healthcare-associated CDI, which is represented by the light pink line. In contrast, the rates of VRE-BSI and MRSA-BSI, they've increased since 2012. So VRE-BSI is represented by the purple line and MRSA-BSI by the dark pink line. The rise in VRE-BSI rates, it coincided with the emergence of a new sequence type 1478, which spread quickly within and between hospitals in Canada between 2013 and 2018. The rise in MRSA-BSI rates in Canada, they're largely, the rise is largely attributed to the increase in MRSA-BSIs acquired in the community setting. For CPE infection in Canada, so now we're looking at that light orange line there at the bottom of the graph. CPE infection rates have remained low over time relative to other pathogens whose rates are, of course, higher, as you can see. Now, when we look over to the right side of the slide, we present data on percent mortality. Please note this is all-cause mortality. So percent mortality for VRE-BSI is higher than for MRSA-BSI. When we look at healthcare-associated CDI, we see that percent mortality has remained below 10% across all years presented here. And because the number of cases year to year is low, we report an overall percent mortality for CPE infection, and that percent mortality is 17%. Next slide, please. Great. So next, based on data from CNS participating hospitals, we'll report on the key surveillance highlights for CPE infection, VRE-BSI, healthcare-associated CDI, and MRSA-BSI. And these surveillance highlights will focus on data from 2016 to 2020. So for CPE infection, KPC, NDM, and OXA48 carbapenemases, they're the most common. And we do see a regional distribution of carbapenemases in Canada. So NDM carbapenemase is most common in Western Canada, and KPC, it's most common in Central Canada. For VRE-BSI, the distribution of VRE-BSI sequence types has changed over time. So since 2018, we've seen a decrease in sequence type 1478, and that's coincided with an increase in sequence type 17. Further, when we look at antibiotic susceptibility data, the majority of isolates tested between this time period, they were susceptible to tigecycline, linezolid, and daptomycin. Next slide, please. For surveillance highlights related to healthcare-associated CDI, moxifloxacin is a fluoroquinolone, and among CNIS hospitals, we have observed a decrease in the use of fluoroquinolones over time. And it's interesting to see that moxifloxacin resistance decreased from 17.2% to 6.2% between 2016 and 2020. Coinciding with the decreased use of this antimicrobial. So I think this perhaps speaks to the efforts of antimicrobial stewardship. When we look at vancomycin and metronidazole, these are antibiotics that are relevant to CDI treatment. So it's great to see no resistance to vancomycin among isolates tested and to see only a single case of resistance to metronidazole. Further, the decline in of ribotype 027, it's associated with NAP1, and the decline in this ribotype, it may have contributed to the decline in healthcare-associated CDI rates we observed among CNIS hospitals, as this ribotype has been associated with increased virulence and fluoroquinolone resistance. Moving on to MRSA BSI, the epidemic type CMRSA 10 has surpassed CMRSA 2 as the most common epidemic type. And in 2020, CMRSA 10 was the predominant epidemic type, accounting for half of all isolates. CMRSA 10 is more common among community-associated cases. So this shift to CMRSA 10 is consistent with our MRSA BSI rate data that showed an increase in MRSA BSI rates, largely driven by an increase in community-associated cases. Finally, in the period between 2016 and 2020, no isolates were resistant to linezolid, tigecycline, and vancomycin. Next slide, please. So next, I'll hand off the presentation to my colleague Anata, who will take us through part 2. Thank you.
Thank you very much, Jessica, and thank you, John and team, for organizing this day. We're very happy to be here and share some of this data. So in part 2 of this presentation, we'll be discussing device and surgical procedure related infections. And these 4 infections here are central line associated bloodstream infections, and these are in ICU settings. And next, we have hip and knee surgical site infections, so infections following a hip or knee arthroplasty. And the latter 2 are CSF shunt or cerebrospinal fluid shunt infections and pediatric cardiac surgery surgical site infections. Next slide, please. So again, here's a brief look at the timeline we've seen throughout these presentations. As you can see, surveillance of surgical site and procedure-related infections date as far back in CNIS as 2000 for CSF shunt SSIs. And more recently, in what we're discussing here, we have surveillance for hip and knee surgical site infections since 2011. Next slide, please. So jumping right into central line associated bloodstream infections, or CLABCs, CNIS collects data for CLABCs from 4 different ICUs. And among the adult ICUs, we have adult mixed ICUs and adult cardiovascular surgery ICUs. And in our pediatric population, we have neonatal and pediatric ICUs. So taking a look at the figure in the bottom left here, we have rates of CLABCs from 2012 to 2021. And these rates are per 1,000 patient or line days, excuse me. Taking a look at the adult mixed ICU rate, which is the second line from the bottom here, we see a really concerning increase in CLABCs from 2012 to 2021, corresponding to a 140% increase. So 0.87 to 2.11 CLABCs per 1,000 line days. And in more recent years, since 2016, we've seen these increases driven by the central and western regions. And comparing these results to other jurisdictions, such as the US and Australia, on average, the CLABC rates are very similar to these jurisdictions as well. And we have seen increase in CLABC rates in US as well. Looking into reasons for this increase is quite complex due to the number of factors involved, including the collection of this data as well as the clinical factors involved as well. However, some work that is being done in order to elucidate some of these reasons are surveys in our network related to CLABSI bundles. And what CLABSI bundles are standardized protocols used at a hospital setting in order to reduce the chance of a CLABSI infection occurring. So by collecting these practice data, we hope to further contextualize some of these rate increases that we see for adult mixed ICUs. Conversely, looking at a more happier note here, we have our NICU CLABSI rates, which is the line right at the top here, that have reduced in rates 51% from 2012 to 2021, going from 3.27 to 1.61 CLABSIs per 1,000 line days. So this is very encouraging to see, and similar jurisdictions such as the US have also seen this decrease in neonatal ICU CLABSI rates. And last, the adult cardiovascular surgery ICU and PICU rates have fluctuated over time, and you see that in the bottom line as well as the line second from the top, and have really fluctuated and have no increasing or decreasing significant trend. Looking to the right side of this figure, we have, again, all-cause mortality at 30 days post infection identification. And taking a look at our different ICUs here, we see in adult mixed ICUs over time, 2012 to 2021, all-cause mortality has really been above 30% for those that have a CLABSI. This is quite concerning and a very high all-cause mortality. However, do keep in mind that patients in ICU settings tend to have higher numbers of comorbidities, as well as other reasons for being in the ICU. But certainly having a central line associated bloodstream infection does not help. Looking at our pediatric population, such as in the neonatal ICU, here we have much lower rates compared to our adult populations. However, over time, going from 2012 to 2021, there was an elevation in all-cause mortality in the NICU in 2017, and now has stabilized at around 12 to 14%. So there is some work going into understanding why all-cause mortality is elevated in this population since 2017, looking at some survival curve analyses to determine some significant risk factors. Otherwise, in PICU, all-cause mortality has fluctuated over time and remains around 10%. Next slide, please. Now we'll take a look at surgical site infections. And here again, we have 4 surgical site infections under surveillance: hip and knee SSIs, as well as cerebrospinal fluid shunt SSIs and peds cardiac SSIs. Please do keep in mind that participation by our sites in these different types of surveillance does vary, and surveillance programs such as peds cardiac surgery SSI is a much smaller participating group compared to hip or knee SSI, just due to the types of hospitals that perform this type of surgery, as well as resources involved. Taking a look at our rates of SSIs over time, 2012 to 2021, and these are rates per 100 procedures. We see the line in dark purple at the top are our rates of peds cardiac surgery SSIs, and these have fluctuated over time. However, you could also see in 2018, there is a significant outlier value of a rate of 7.5 SSIs per 100 procedures. And through investigation, this has been attributed to 2 hospitals, and further investigation is being done to understand why this is such an outlier year. Otherwise, rates of peds cardiac SSIs have fluctuated over time. Looking at CSF shunt SSIs, which is the second line from the top here, we have fluctuating rates as well, ranging from 1.4 to 4.0 infections per 100 procedures. And lower down here, we take a look at our hip and knee SSIs. The knee SSI, which is the last line at the bottom here, although it's a bit hard to see with this scale involving other SSIs, we have seen a 65% decrease in knee SSIs over time from 2012 to 2021, going from 0.65 to 0.23 SSIs per 100 procedures. So this decrease in the SSI rates has also been seen in other jurisdictions such as Australia and Europe. Conversely, though, hip SSI rates have fluctuated over this time period and range from 0.5 to 0.9 infections per 100 procedures. Taking a look at percent mortality, all cause at 30 days, we see for data that we've collected since 2018 for hip and knee SSIs, there's been 5 cases of death among patients with an SSI following a hip arthroplasty, whereas we've recorded 0 for knee SSIs. Peds cardiac SSIs data from 2012 to 2021. We've collected data on 4 deaths, which represents 1.6% of SSIs collected for Peds cardiac. And as you can see, 1 of those deaths were deemed cause of death, 1 was indirect, and 2 were unrelated. And for CSF shunt SSIs, we do not collect outcome data. Next slide, please. Last, I'd like to take a look at some of the most commonly identified organisms among our device and surgical procedure related infections. And this is from 2012 to 2021. As you can see, the vast majority of organisms identified are gram-positive. And among all our device and surgical procedure infections, we have coagulase negative staphylococci as the most commonly identified infection. Following that, we have Staphylococcus, and the majority of these Staphylococcus species are S. aureus, and as well as Streptococcus and other species such as Enterococcus and Klebsiella. And with that, I'll conclude part 2 of this presentation and hand it off to my colleague for the third part of this CNIS presentation. Thank you.
Great. Hi, John. Is it okay if we just kind of keep skipping through these, hopefully?
Of course. No, it's flowing beautifully.
Good. So hi, everyone. I'm Robin Mitchell, again, one of the epidemiologists with CNIS, and Joelle Cayenne is also on the line, and she has been working diligently on these data for some time now with me as well. And so is what the next topic is everyone's least or favorite topic. And so we're going to be looking at some COVID-19 trends that we have collected through the CNIS network. And when we came up with this title, I think John required it kind of earlier this year. And we knew we were going to start at wave 1, but we just didn't know where it would end. And it has not yet ended. So we're still flowing through the waves. And so just a bit of background for this surveillance. As you know, CNIS conducts surveillance for healthcare associated infections, and we included viral respiratory infections. We reintegrated that in 2019, just in time, fortunately, for COVID. So beginning of March in 2020, CNIS began collecting weekly aggregate data on severe outcomes among pediatric and adult patients who are hospitalized with lab confirmed COVID. And so we collect data every week from 155 acute care hospitals in 10 provinces across the country. And so the data that we're going to be presenting today is showing national trends of these severe outcomes among adult and pediatric population patients who are hospitalized with COVID. And then we're also going to take just an initial look at some preliminary analysis that we have been doing, looking at the impact of COVID on all of the rates that we have presented. And so this first figure shows the incidence of patients of all ages who are hospitalized with lab confirmed COVID. And so that's the blue line, that's the hospitalizations. And then those who are admitted to ICU in the purple, and then all cause in hospital mortality rates is in the pink. And so these data go back to March of 2020, and the rate is per 1,000 patient admissions. And so these rates, as I mentioned, are based on 155 acute care hospitals in 10 provinces. And so you can see all of the magnitude of all of the waves over time. And I guess just to confirm, the definition that we use for hospitalized with lab confirmed COVID is a patient is admitted and they have to have had a lab, like a PCR positive test, either 14 days prior to admission or during their admission. And so this captures people who were admitted because of their COVID infection, as well as patients who are those incidentals. So they're admitted for another reason, but happen to test COVID positive on admission or during their admission. And so the most recent data that we have are based on patients who were admitted up to October 8th. And so that's what you see kind of here at the very end of our epi curve. And so we did in September see a recent increase in hospitalizations, but in the last 2 weeks, we've seen kind of a plateau. And so definitely some regional variation happening there. But that's currently the trends that we're seeing. And then you can see along the bottom that thankfully ICU admission rates and mortality rates have really remained low and stable since earlier this year. Now, these figures are looking at the proportion of severe outcomes among these patients who are hospitalized with COVID. And we've stratified the data by waves. You can see the wave categories here along the x-axis. And so we have 4 indicators. And the first is looking at, on the top left there in the purple, of those who were hospitalized with COVID, what proportion are admitted to ICU? And we see a pretty clear trend here that we see lower proportions in waves 5 through 7. So those are those Omicron waves in 2022 compared to the previous waves 1 to 4. And then the figure on the right, top right, we see of those patients who are admitted to ICU, what's the proportion that require mechanical ventilation? And again, you see a similar trend that the 2022 waves or Omicron waves, the proportion of this outcome is significantly lower than previous waves. And then looking at ECMO data on the bottom left, so this is the proportion of those who were admitted to ICU. What's the proportion that required ECMO? And so we have stopped collecting those data in wave 7 recently, but you can see that the proportion of patients receiving ECMO is quite low. Definitely in wave 1, you see a higher proportion as everything was very new and patient management, there was a lot of uncertainties there. So a little bit more ECMO use in wave 1 compared to other waves. And then looking at the bottom right, this is of those patients who are hospitalized, what's the proportion who died? And this is all-cause mortality. And again, you see lower proportions in waves 5 through 7 there. And so there's many factors that contribute to this kind of decreasing trend in recent waves that we've seen. So we have, as you all know, higher vaccination coverage, a lot more natural immunity in these later waves, the emergence of less virulent variants, as well as I mentioned, kind of improvements in treatment and patient management. So all those factors have contributed to this decrease in severe outcomes that we're seeing. And so the next slide, in May of this year, we began stratifying our weekly data by patients who are hospitalized due to COVID. So that's those who arrive at hospital, or they're admitted to hospital because of the severity of their COVID infection. And then we stratified those by those whose admission is unrelated to COVID, so those incidental admission. And the goal was really to get a better sense of severity, because we know that when Omicron arrived, we were seeing a lot of kind of incidental admissions. So lots of people being testing positive on admission. And so that was kind of the impetus to look at some of this data. And so is what we see, the first row here in the peach is these are patients, their hospitalization, ICU admission, and death rates among those who were admitted due to COVID. And then on the bottom row are the rates for those that whose admission is unrelated to COVID. And these rates are based on a subset of those 155 hospitals. So there's just 56 hospitals that are able to stratify the data. And so the current trend is showing for hospitalization rates, there's a little bit of fluctuation, but in general, over the past few weeks, we've seen a relatively consistent trend for hospitalization rates for both those admitted due to COVID and those whose admission is unrelated to COVID. Noting though that the rate of incidental admissions is slightly higher than those admitted due to COVID. And then finally, among patients who are admitted due to COVID, we see that the rates of those being admitted to ICU and dying is quite low and stable. So that's good to see. And then we also stratify our data by where the patient likely acquired their infection. And so we began collecting these data back in September of 2020. And what we see here is that the majority of patients who were hospitalized without confirmed COVID acquired their infection in the community. So that's this orange section here. And then we also look at the proportion that acquired their COVID-19 infection in another acute care facility or a long-term care home. And so you can really see kind of in the early days of the pandemic, the impact of acquisition and long-term care there in that pink. And then finally, looking at the dark purple, this is the proportion of patients who acquired COVID in the reporting facility, so in the CNIS facility. And we've definitely seen some fluctuations over time in this indicator, but it's a bit harder to see in this graph because we wanted to show a long-term trend, but we've definitely noticed a shift in July of this year of an increase in an acquisition of COVID in hospital, and that has remained elevated. And there's a few hypotheses regarding this. Obviously, the increased transmissibility of circulating variants. As we all know, we've seen the removal of public health measures, which then leads to an increase in community transmission, more infected healthcare workers coming into hospitals with either asymptomatic or with milder symptoms. And we've had reports of decreased testing among healthcare workers, likely due to these milder symptoms. Some hospitals have explained this by saying, we've dismantled our COVID units, so now we have COVID negative and positive patients spread throughout the hospital. As well, as everyone is very aware, we're seeing lots of staff shortages and overcapacity in hospital, which just generally leads to transmission in hospitals. And then changes to visitor restriction policies. So we're seeing more visitors coming into hospitals and reports of decreased adherence to mask wearing among these visitors. So I think these are all reasons that I'm sure you're all very familiar with. And then we have also been looking at some vaccination status data. So these figures show the cumulative incident rates of patients who are hospitalized with COVID. So again, these are our similar indicators. Hospitalized with COVID on the left, admitted to ICU in the middle, and then patients who died with COVID on the right. And so we've stratified these data by vaccination status. And so, like I said, these data are cumulative. So it encompasses the time frame from December of last year until May of this year. And so we stratified these rates by vaccination status. So you can see in the teal, this is the rate of hospitalizations among those who are unvaccinated. In the navy is the rate of the outcome by those who are fully vaccinated, so they have received 2 doses. And then in the red is the rate of those who are fully vaccinated with an additional dose. And as you can see, the rates for all of these 3 outcomes are significantly higher among unvaccinated patients compared to vaccinated patients. So just really highlighting the benefit of COVID vaccination in reducing these outcomes. And so, as I mentioned, we've also, the team has also been looking at the impact of COVID on the incidence of our healthcare associated infections and ARO. So this is some preliminary analysis that we've done. We've conducted some interrupted time series analysis using a quasi-Poisson and step and slope change model. And the inclusion of these covariates has differed by the different pathogen, but at minimum, each model has been adjusted for seasonality, region, and hospital cluster, and others have included bed size and teaching hospital status kind of as appropriate and as it fits the model. We've calculated monthly rates from January of 2015 to February of 2020, so that's our pre-COVID period. And then we also calculated rates from March of 2020 to December of 2022. So that's our COVID period. So we have 84 monthly time points included in the model. And then we've restricted the analysis to hospitals that participated in all surveillance years. And so looking at CDI first, we see that healthcare associated and community associated CDI rates increased during the COVID-19 pandemic. And again, these analyses are preliminary, but looking at healthcare associated CDI on the left, we can see that at the onset of COVID, we observed like a little initial increase in HACDI. And then we saw a declining trend, but that declining trend is much slower than it was pre-COVID. So the slope or the rate of decrease is not quite as steep as pre-COVID. And then when we look at community-associated rates, again, we observed an initial increase in community-associated rates during this COVID period, excuse me, and then those rates remained elevated over time. Looking at VRE bacteremia rates and CP infection rates, we see that there was no change in these rates during the COVID-19 pandemic. So for both pathogens, you can see that we observed an immediate decline or a step change at the onset of the pandemic. So our pandemic period is this gray shaded area here. So there was that immediate decline. But as you can see, the change in the slope of the line in the pandemic period, it's not significantly different than the slope of the line in the pre-pandemic period. So there was no change in the rate of the rise of these infection rates. So essentially, COVID did not have a sustained effect on the incidence of these 2 infections. And then, excuse me, looking at MRSA rates, we see that there was no change in healthcare-associated MRSA BSI rates, but we did see a decrease in community-associated BSI rates. And so on the left, we have healthcare-associated rates, and we of MRSA bacteremia. And so we did observe an initial decrease of these rates at the onset of the pandemic, but then similarly that slope in the change between the slope and the line during COVID compared to pre-COVID, there's not a lot of difference there. And then when we look at community-associated rates, we did observe an initial slight decrease during the COVID period, and then we just saw that the rate has just continued to decline during the pandemic. And finally, looking at some national Clade C rates, we did not see nationally a change in Clade C rates in adult and mixed ICUs during COVID. So as you can see here, national rates of Clade C in adult mixed ICUs, they've been increasing prior to COVID. So in 2014, and the increasing trend in the pandemic did not significantly change compared to pre-pandemic. And so for these analysis, kind of some next steps is we're going to be including some subsequent data points, so including some 2022 data, accounting potentially for some various factors, and then also reducing the time period to account for the existing trends. As I mentioned, for Clade C here, we were already seeing kind of an increase. So it'll be interesting to look at more recent data. So looking at 2018 data rather than going back to 2015. And so that's a bit of a recap of all of the data that we have collected thus far. We'd like to acknowledge all of the staff at the hospitals who have been working very hard to submit these data, especially during COVID, the team here at FAC and the National Microbiology Lab. And then as well, we also have some links here to our InfoBase page, which we reviewed, and then those two surveillance reports in the CCDR. And if anyone has any questions or would like more information or would like to participate in the point prevalence or the simplified data set, our email address is there. And so I'll hand it back to you, John. Thank you.
Thank you very much, Robin, and thank you for the whole CNIS group. So a couple of observations for the data. And some of these are maybe tough questions, but, and correct me if I'm wrong, you noticed that the outcomes for VRE bloodstream infections were worse than for MRSA. Do you have any explanation for that? Because MRSA is a far more virulent organism. Could it be related that persons who are having VRE bloodstream infections are more medically compromised?
Jessica, I don't know if you want to make a point, but I'll just say that I think it can be a bit challenging too, because we're looking at all-cause mortality as well. So it's not attributable mortality to one of those two organisms. But Jessica is the lead for VRE, so I'll let her jump in as well.
Yeah, and just to add to that, I think the patient populations might be a little bit different too. For example, with VRE BSI, we know that a large proportion of VRE BSI cases in our data set, they're related to, they're in like hem-onc patients or, complex patients that have, complex medical issues. So I think that might also be related to the higher mortality.
Perfect. Well, thank you very much for putting together what you've done over 30 or 20 some odd years in 45 minutes. So some great questions from the audience. Let's see. Oh, a question about how do we find the antibiogram off the site, like a primary care in Winnipeg, or rural areas? If I'm not mistaken, I don't think this is a CNIS initiative. That would be more of a regional health authority or shared health initiative in Manitoba. So if you can just clarify for the first question on the screen.
Yeah, so we do, CNIS does conduct, we do collect some antibiogram data, but that's just for a specified number of CNIS hospitals. So it wouldn't reflect Winnipeg or specifically. I think that would be something that you would have to get from your local site.
So then there's a great question. Do you think MRSA will ever follow the same route as VRE in terms of the required isolation precautions? Unfortunately, no. I don't know what other centers experience across the country, but certainly locally, we found that the VRE initiative was a monumental undertaking that consumed vast resources, and unfortunately, it didn't really change the outcome in terms of VRE transmission. As a result, what we've got now is a significant VRE transmission, significant VRE bloodstream infections, and some strains of VRE that are essentially untreatable. I suspect the same is happening in the rest of the country. So given the virulence of methicillin-resistant Staphylococcus aureus, we don't really foresee a change at this time. I'm not sure what the prevalent thought is across the country, but I suspect it's similar.
Yeah, I think we would probably agree with you on that too, John. And as well as something we didn't mention is that CNIS is also collecting data on infection control practices over time. And I think there's also a lot of diversity and variability across the country. I know that, yes, we've had many discussions about that, but that's some other data that we are collecting. But I agree with you, or we agree with you on the MRSA VRE situation.
Excellent. Another great question, and it reads, if not mistaken, the CNIS presentation noted that there was only one documented case of resistance to metronidazole for hospital-acquired Clostridium difficile infection between 2016 and 2020, which is interesting. The Canadian guidelines suggest vancomycin first line. What is the rationale for vancomycin first line in Canada, given the data? Well, I think this is actually an incredibly complicated question, which goes back to an analysis of the clinical trial data. So at the end of the day, there are issues of tolerability with metronidazole. Metronidazole can still be used first line should the circumstance require, specifically cost of the medication. So I don't know if, Robin, you've got anything else to offer?
I don't think so. Kelly, I don't know if you have any thoughts on that either. She leads our CDI.
Yeah, I agree with you, John. It's evidence-based decision that was put out, and there's increasing evidence that metronidazole is not as effective as vancomycin for more severe cases. So yeah, I think that could be the reason why.
So the question for the CNIS group, what lies ahead for CNIS? And the question actually dovetails nicely with the discussion of Ronan Seagrave and Brian Postal about where the money comes from, who's paying for what, and the perpetual struggle that CNIS has for funding, given the valuable material that CNIS provides us in terms of just the cross-Canada checkup. Any thoughts about where CNIS is going next?
Well, currently the Public Health Agency funds CNIS, and so to my knowledge that will continue. I don't know if you next steps will just be, we're basically just continuing surveillance. As Kelly mentioned, we're looking to broaden and capture more Canadian acute care facilities, whether it's through our simplified data set or the point prevalence, and then as well kind of branching out into long-term care. I don't know if that answers that question.
Oh, that's perfect. Thank you.
Okay.
Well, if there aren't any more questions, I'll thank our presenters from the Canadian Nosocomial Infection Surveillance Program, and we look forward to seeing you again over the next few years. Thank you very much.
Thanks, John.
And for those who are still attending, we'll have a brief lunch break from 12:15 to 12:45 Winnipeg time. Please make sure that you've registered. Please make sure that you upload your questions to Slido. And remember, Jared Bullard will be speaking from 12:45 to 1300, and his presentation will be about COVID vaccination in children. And Lane Torograd will be speaking about germaphobia from 14:15 to 14:30. We'll see you back at 12:45 Winnipeg time. Thank you. Well, welcome back, everyone. It's 12:45. Everyone's back from lunch. Just a few housekeeping reminders. Please register with the Continuing Professional Development website. Record your attendance with Slido using hashtag BUG, all in capital, BUG 2022. And if you need a certificate, you must do this. So just a reminder about a change in the program. You were meant to be hearing about germaphobia right now, but unfortunately, Dr. Bullard had a commitment earlier and couldn't speak at his designated time. So Dr. Bullard will be speaking to us about pediatric COVID vaccination, where we are 1 year later. Dr. Bullard.
All right. Well, thank you very much, Dr. Embel. I'm very happy that you asked me again. I always enjoy coming to BugDay. It's one of the highlights of the year, and I'm happy I could be accommodated to make it to my daughter's award ceremony. So, of course, we are going to be talking about COVID-19 vaccines as it relates to children, and in particular in conflicts of interest. Usually I have nothing to say, but this particular year I am part of the Moderna trial, looking specifically at younger children under the age of 4. I also will be using trade names for simplicity, because if I'm to sit there and give the full names or code names, it can be potentially confusing. So the objectives are pretty straightforward. What I want to do more than anything is talk to you about how children are affected and what they do with this particular virus. And we're also going to talk about the vaccine as it relates to variants of concern, because obviously we observed that a lot of people who were fully vaccinated still were getting infected. And I'd say one of the most important things too is related to safety. So most people who are getting their children vaccinated want to ensure that everything is going well. And so I will talk about some of the longer term follow-up data that we have around the safety of the vaccines. Whenever you have a vaccine program that's being considered, you have a bunch of important questions you need to ask. And for children, it's no different. So in this scenario, we're wondering about SARS coronavirus 2 and COVID, and what does it really do to them clinically? What is the impact of children on community transmission of SARS coronavirus 2? Because you heard a lot of different things over the past couple of years about, can they transmit this? Do they get infected? And we know that clearly they do get infected. Whether or not they transmit it as effectively as adults is a question that needs to be addressed more fully. And then, of course, are there any significant harms to the administration of the vaccination in children? So we'll start with the clinical impact. And to do that, you kind of have to have an appreciation of what we've observed. And so if you were in Brent Ruson's talk, you kind of already saw a lot of this. So if you think back to wave 1, there really wasn't a lot of disease activity. But as we suddenly got into wave 2 and wave 3, representing the D614G variant and then also the alpha variant, we saw a little bit more activity in children. And specifically, we started to see the multi-inflammatory syndrome in children, which resulted in a lot of kids coming into hospital and being quite sick. As we got further along into the summer last year, Delta started to come. And then, of course, we had this massive spike of Omicron. And you can see basically BA1 caused most of the cases, followed by BA2. And then now we're into the BA4, BA5 realm. So I always like to look at the different provinces, see how we all did. As well, had a very different approach to the way to deal with the pandemic. And we're not too far off of our neighbors. When we look at Saskatchewan and Ontario, we had the big spikes associated in wave 2, wave 3, and then of course the Omicron wave in particular. So this is the data that shows us how many cases total of children, and everybody was basically infected. And one of the big changes specifically related to the Omicron wave was when we saw children under the age of 10 start to make up a lot more cases. They were significantly less than those 12 to 19 for a long time. And then when you think about those who are producing most of the cases, well, it's the most mobile elements for society, especially those millennial 20-year-olds running around doing what they do. But when it came to hospitalization, we saw kind of a similar trend in that the children that were a little bit younger were starting to come into hospital more frequently than we would have expected. And that's the nature of Omicron to some degree too, and I will talk about that a little bit later. As well, when we're talking about those requiring critical care, the numbers weren't especially high, but they definitely were higher than we expected. And I would say, again, that's related to Omicron and its unique presentation in children. And finally, of course, this is deaths. So most of the deaths were occurring in 80-year-olds and above, which makes sense. That's the highest combination of comorbidities. When we're talking about children, there weren't that many. But to say that there were no deaths is completely inaccurate. There, of course, were a number of children who died as a result of COVID and the complications and other comorbidities as well. So if you were to summarize that, you can see that there's a significant number of children who are ultimately infected as diagnosed by our standard diagnostic testing. About 1% of those ended up going in the hospital, about 1 in 1,000 were in the ICU, and about 1 in 10,000 ended up dying from or having COVID. So one of the important things to understand too is, well, how prevalent was this particular disease in the province? And so again, you saw Dr. Rusin providing this data earlier. And what you can see is that as we started to roll out vaccinations, the total immunity represented on the top graph with purple started to increase quite a bit. And then natural infection represented by the green also increased. What you might also notice is that those who are younger, 1 to 9, took off quite a bit compared to the other groups, when the others started to trend downward. And that's more of a reflection, I'd say, of the vaccination really wasn't available for those particular groups. Why is that important? Well, it's important to give you a sense of how much disease was actually in the community. And here is March of 2022. And you can see that we're really close to almost 100%. We actually have data, and I don't know why I couldn't find it, but I couldn't, where we have maybe 150%. So that's implying that children typically not only have been infected once, they've been infected more than once at this point. So if we were to apply that to Manitoba, we have the standard diagnostic test, which is RT-PCR, and we had about 30,000 kids. Our numbers aren't that far off, really, compared to the national numbers in terms of those requiring hospitalization, ICU, and we're talking about miscees, it's about 0.05%. And we did have some deaths here in the province as well, related to COVID in children. Now, if we're to consider the number of children who ultimately were likely to have been infected, you can see that it's adjusting for about 90% of infected kids, which is a conservative estimate, if anything. And so suddenly you have this drop by a factor of about 10. And so this is actually telling us some important information about kids and COVID. First, they do tend to have a higher proportion of asymptomatic disease. So even though officially we're saying 20 to 50%, if we look at the seroprevalence data, it's probably closer to 90% or so. A lot of them do have very mild disease. If you've had children who've had COVID, you've probably seen that most of them seemingly rebound in less than 24 hours. Fever, cough, and headache were the most common for the variants before Omicron. And what we saw in the children's hospital a lot more after Omicron was typical symptoms that we would see from other respiratory viruses. So RSV and influenza and parainfluenza causing things like croup and bronchiolitis and pneumonia. And so these were the kids that typically were coming into hospital, which I think is why you saw more cases. And that makes sense because when you have younger kids, they have smaller airway diameter, and as a result, any inflammation from any cause is going to cause a little bit more problem and prompting medical attention. So the interesting thing too, of course, is long COVID. And so we know that in adults, it may be as high as 20 to 30%, whereas in kids, you don't really see it to that same degree. And we have a network of different pediatricians in rheumatology, neurology, adolescent medicine across the country and in the province looking for these kids. And so it's supposed to be around 1 or 2%, but I don't think we've had any referred to the infectious disease clinic thus far. So it's also important to know the impact of children on the ability to transmit this. So if we're going to vaccinate them, will there be a benefit to the community as a whole in preventing further forward transmission? And so typically when we're looking at the data, what we see is households are highest risk by far. So they really typically have a high secondary attack rate. Depending on the variant, Omicron is as high as 40 or 50% of people in the same household will have an infection. So typically when they get it, it is from the older members of the family, whether that be parents, grandparents, or potentially older siblings. When it is a kid who's transmitting, so they're the primary case in the house, typically there's going to be maybe 1 or 2 other cases. And usually the kids that transmitted better are the preschool children. And so you're kind of wondering, well, why would that be? Well, preschool children require a lot more attention than your older teenagers who hide in the basement looking at their phone all night. Not that that's happening right now or anything. So typically with that more involvement, they are way more likely to spread it to their family members just by virtue of contact. So the single greatest risk to children in a household is having an unvaccinated family member. So that's a little bit old to say. It actually probably is more accurate to say the greatest risk is someone who has no pre-existing immunity to COVID, because we have a substantial amount of people now that also have immunity related to having had the infection plus vaccination or a hybrid of the two. I love this paper because it came out with Omicron, because a lot of the time when you're talking about data, they were saying, well, what about this variant? What about that variant? And so this is a study that came out of Ottawa, so it's Canadian on top of it. And it's looking at household transmission of coronavirus in unvaccinated, asymptomatic, and symptomatic members. And what they did was by seroprevalence. So this is a little bit more sensitive in terms of knowing like the total number of people infected. And there were a couple of interesting observations. If you had more than one person infected in the household, it was more likely that you were going to see secondary cases. Adults were transmitting to children far more likely than children transmitting to children or adults, about twice as much, which is interesting. If you had someone who was admitted to hospital, there was a higher risk that you would transmit this within the house, which again makes sense. The more virus you have, the sicker you're more likely to be. And if you're in a house and have to go to hospital, you're going to have a lot of virus. And so you're way more likely to transmit that. What was interesting from this particular paper too was saying that if you isolate the index case or you all wear indoor masks in a household, it actually wasn't associated with the decreased risk of transmission overall. And schools is the other area where we're really worried about the risk of transmission. And typically what we saw in schools across the scope of the pandemic was that it would be a mirror of whatever was going on in the community. And usually around 4 to 5% of outbreaks be related to schools specifically. One of the metrics that we were really interested in was, well, what about teachers? So we know that if you have other respiratory viruses, kids are transmitting that very, very efficiently and effectively. But we didn't really find that the seroprevalence in in teachers and health and educators was significantly different than others in the community. And the main risk factors are really those who had a case in their house, which made sense, as well as a student with COVID and travel. And so this admittedly was before Omicron, but that particular group has done the same study and it's going to be published relatively soon, and it has the same sort of conclusions. So what is the impact of variants of concern on community transmission related to this virus? Well, I bet you're really excited that you get to see a ribbon presentation, but there's really, the main take-home message are the number of red dots that you see. You can see with Delta, it only has about 8, whereas you're approaching 30 with Omicron. And so this is the spike protein specifically. So what does that mean? Well, one, it probably attaches a little bit differently than prior variants, but more importantly, prior immunity, specifically antibodies, may not bind to a protein that has as many changes in it. And this is just a representation of that. If you look from 12 to 6, you see all those warm fuzzy colors. Those are all the various subvariants of Omicron that have been basically coming along since then. What you can see here, and I really wish I would have included the Delta being taken over by Omicron, is that as we have in the province a different subvariant come along, it gradually displaces the other subvariant. Now, this takes place typically over about 4 to 8 weeks, sometimes a little bit longer, whereas with Delta, it took maybe a week or two, where it was completely supplanted by Omicron, and just based on the combination of features that I mentioned earlier. Sometimes you get a really, really great paper that comes along and shows you all about what you want to know about the effect of immunity on infection, hospitalization, and death. And so this really great paper came out not too long ago, showing that, as you've heard repeatedly, that your risk of hospitalization and death is greatly reduced when you are fully vaccinated. We also know that with prior infection, you're going to see that as well. And in particular, the risk of reinfection, if you've had a prior infection, is actually a little bit less. If you were to take that with hybrid immunity, meaning that you're both vaccinated and you've had infection with COVID, it's even higher. So are there any significant harms? When we look at 6 months to 5 years, we just approved that. And so there's a couple of options. There's both the Moderna product and the Pfizer product as well. Both of them have a slightly lower dose, and you can see the interval that we use there. Now, whenever you have approval, you have the initial studies, which only have a couple thousand. And so we have the follow-up studies, which have millions instead. And you can see from the US that they have over 1 million children who have been vaccinated particularly. And systemic reactions were really quite frequent, in particular for those under the age of 2. And a lot of the symptoms that we were seeing were very typical of vaccinations in general. There was crying, sleepiness, and irritability. And one of the main issues that came up in terms of a common event was administration errors related to a different dose. What's really important though, there was no myocarditis reported in this particular age group. We also, of course, approved the 5 to 11 back in November. And you'll see here that the dose is slightly increased in both those products. And it's important to say that when you have these products in children, the amount of antibody that you produce is actually really good, even though you have the lower dose. And in addition, you have less frequent side effects overall. One of the important things that got asked a lot was related to what if my kid turns 12 for the second dose, before they have the second dose. And so there, you can give them the higher dose. And so this is a picture of my son, Donovan, who was part of the campaign. He was very excited to get a shot from Joss Reimer. He was excited because she was in charge of the whole thing. When we look at the safety data from the States, we have almost 9 million kids who ultimately received the vaccination across November to December. And reported adverse events were actually less than about 1 per 1,000, and most of them were quite non-serious. The most common adverse event was, again, administration errors. So the dose was lower than what everybody had been used to for a long time. And they actually found that because of this lower dose, even though you had local and systemic reactions, they were less frequent than adolescents. And myocarditis was seen really in only a handful. I think they had 11 or 12 total in this particular group. Then finally, we had the 12 to 17-year-olds who were the first to receive this. It was a little bit easier because the dosing really wasn't much different. And so my daughter Taya was part of the promotional for this as well. She was very excited to be involved. I said this particular generation has a great willingness to help out their communities, so it's appreciated. And again, we have a large amount of data basically showing that it is quite safe, with 9 million adolescents vaccinated in the US. The adverse reaction rate is about 1 per 1,000, with slightly higher non-serious conditions, or slightly higher serious conditions. And in particular, this was myocarditis, and in particular even more, males, but fortunately, most of the cases of myocarditis most often manifested as chest pain, slight increase in troponins, and it was all transient, meaning that they got better and there were no deaths associated with it either. So overall, the vaccine was extraordinarily safe. We do have some data from Canada as well, and you can see here that when we look at the adverse effects of the vaccine, they were comparable really when we're looking at the ages that I was speaking about earlier. There are some special considerations. So we know that if a child's immune response is going to be compromised in some way, you typically have to give them more doses and more close together. If a child has had COVID in their primary series, typically we would say wait about 2 months. And probably the most common question that I get asked relates to what about a booster if they've had COVID? And so typically that's 3 to 6 months. But remember, this robust immunity that they have related to COVID is probably going to protect them, particularly if they got Omicron. When you're in doubt, always feel free to ask your healthcare providers. So there's a lot of us in pediatrics and pediatric infectious diseases who can answer your important questions. And finally, this is really just an interesting breakdown of the number of kids and groups that have been vaccinated here in the province. I predicted that we probably wouldn't be able to vaccinate the younger children very well, and you can see here that only 6.3% of them have got vaccinated, which is significantly less. I was thinking it would be around 20 or 30%. I knew, again, that the 5 to 11 probably wouldn't be as high as the rest of the groups, and they were right around the 50% mark. But you'll see here the 12 to 17-year-olds actually did very, very well. They were right around 80%. And I think that that's an interesting observation in that a lot of them did it partly for community benefit, but also for return to normal. I don't know that we gave them that return to normal after vaccination, so I'm curious to see what the impact of that is. So that was me going very, very quickly through a lot of information, but fortunately it's on recorded, or it's recorded. So with that, this is the self-assessment questions. You can see what the answer is there. That's pretty straightforward. And of course, I'm happy to answer any questions at the question and answer period. Thank you.
Thank you very much. I'd now like to introduce Stephen DeGroot, who will speak to us about leading with courage through crisis. And this was really borne out during the past 2 years or 2.5 years. Stephen DeGroot is the co-founder and president of Brevia, a proud Manitoba company focused on strengthening leadership and organizational capacity at all levels in health. Stephen is also the author of a book entitled Responsive Leadership. Stephen, the floor is yours.
Hey, thank you, Dr. Hempel. Thank you, everybody. Thank you so much for asking me to be here and trusting me with this on BugDay, trusting me with this presentation. Am I audible? Can you hear me okay, Dr. Embel?
Perfectly.
To double check. Okay, perfect. And as a proud Manitoban, as you mentioned, it's been an honor to support and strengthen healthcare practitioners, healthcare professional leaders, public safety leaders across Manitoba to get through this. And it's a pleasure to be here with so many great presenters. And I plan on a very ambitious yet simplified presentation. So what we're going to do is simplify human behavior, that's all. Simplify the role of leader through challenge and perpetual disruption, which sounds a lot like Manitoba, and offer 3 strategies for leading effectively, and then provide the most practical approach for demonstrating courage in crisis, a strategy that takes only seconds, right? Because there's a lot of talk about that. So what we're gonna do is talk about the core essentials, what all humans need before, during, and beyond crisis. And leading under normal circumstances can be really difficult. Leading through perpetual change and in a crisis can be very, very difficult and challenging indeed. Many of us have done it over the last 2.5 years. How leaders can help their people by leading with courage. So I want you to just quickly, I know we've only got a few minutes here, to connect to your greatest leadership experience ever. I just want you to go to a time when you experienced great supervisor, a great director, a great manager, a great head of your department, right? I just want you to connect with what they were doing, because I want the research here to be you. I want you to use yourself to know exactly what I'm talking about, because I want to move into what human beings need. And this is taken from my research on something called the core algorithm, is that, just to simplify it, human beings need to thrive just under normal circumstances, and especially in difficult ones, they need connection. They need to feel connected. They need to have relationships that are based on trust and mutual reciprocity. Connection is about relationships with other people that we depend on. It's about a strong sense of belonging and a strong sense of connection to the community or another person. That's the first thing we need. Clarity is the next thing we need. Clarity is about predictability. Clarity is about, I understand who I am, who you are, what your role is, what my role is, what I can expect from you, what I can expect from myself. And when we have clarity and connection, we have connection and clarity, we have a personal sense of agency, which is what I mean by control. Control is a sense of confidence. It's that ability to feel like I can influence relationships, or more importantly, the people or the things in my environment. The reason why I asked you to think about your great leadership experience ever, because when you go back to that, we'll get to it in just a minute, you can think about things that kept you connected. Certain behaviors and qualities created a strong connection. There were definitely things, you hear things like shared goals, right? Shared goals, we're working towards a purpose. We're all there for the same thing. I knew what to expect. We had clarity, and we had a sense of confidence and a strong sense of control. Why that's so important is not only that humans, we do exceptionally well when we're experiencing those 3 things. It's also the way our brain is developed and strengthened, right? To make it even more simple, it's like our amygdala needs that connection. We need that assurance. Our hippocampus, learning and working memory, needs clarity to give that prefrontal cortex control. So how does this tie into leadership and crisis? Well, most of us have just been through this, right? What a crisis does, what perpetual disruption does, is it undermines connection. When the pandemic hit, our relationships were rocked. The things that we valued were rocked. The things that we were connected to were rocked. Our clarity was compromised. Our routines were just obliterated, right? Our schedules, what was going to happen next, which also just destroyed many of us a sense of control or a sense of that personal agency. We experienced a lot of uncertainty. We experienced anxiety, and we experienced fear, which led to tons of dysregulation. What's dysregulation? Well, dysregulation shows up when we're having difficulty concentrating, when we're having difficulty staying calm. It's connoted by emotional sensitivity, reactivity. Most of this is a list for most of us during the pandemic, right? I don't know if you didn't experience any or all of these during the pandemic, I'd like to take what you're taking, right? A lot of performance issues, right? I use this because a lot of people, I said, when somebody asked me, Steve, what do you expect when the pandemic hits? I said, well, there's going to be lots of change, so expect lots of strange, lots of dysregulation. The problem with the dysregulation with employees in healthcare is that when we can't regulate, we can't reason. And when we can't reason, we can't relate. So we have difficulty focusing on the things that matter. We have difficulty coping. We have difficulty getting to the things that we need to provide the best quality care for the families, for the patients, and for the community. So what do people need in those moments? They need a really strong working hippocampus. But if it goes to sleep, we need a co-regulator. That's what we need. And this is where the leader's role comes in. Our people in those moments of crisis, in those moments of stress and disruption, need what their brains need. And the good news for leaders, for managers, for team leaders, for physician leads, for all of us is that we can operate as that external source and force of regulation. You've experienced this when somebody's put their hand on your shoulder and said, it's going to be okay. And you immediately felt okay, but that's because you had connection, right? Think about that for a second. If someone told you it's going to be okay and you didn't trust them, that doesn't really work, does it? It actually sets a dysregulation off in motion. Or you were clear on what was happening next. So what leaders can do, the three things that leaders can do is provide connection, clarity, and control. When we're connected with our people, when we provide them clarity, when we give them a sense of control, we'll talk about how you can do this. One of the great things about working with hundreds of leaders in Manitoba and across Canada through the pandemic is we've got to see the stuff that works, right? So let's connect it. Let's connect it to what humans need. The first thing, thousands of employees in health said the number one thing they needed from their leader was to stay calm. Calm preserves and reinforces connection. If we can't stay calm, we dysregulate and the connection is lost, the connection to ourselves, the connection to others, the connections to the work. So staying calm is a form of connection, clarity, clear expectations. Now, I know a lot of people say in Manitoba, especially, I don't have the answers. I don't know what's coming next, but clear expectations, roles and responsibilities to the extent possible to give them that sense of predictability and anticipation. Control, where do we get that? By building relationships based on trust. Right? If Dr. Ballard, who I got to know, I hold in high regard, asked me to jump and the connection's there, I don't need any clarity. I'll jump and we'll figure it out later. If the trust is there, I have a sense of control that we're going to be okay, right? So staying calm, giving people as much information and eliminating as many question marks as possible. Things like, hey, I don't know, you don't know, do it because I said so. All of these create a lack of clarity. Relationships built on trust are going to give us a sense of control and a sense of confidence. And you're going to see these three words again, because when leaders are there operating as a co-regulator, they offer a strong sense of connection. They offer a strong source of direction. And in the end, they offer protection, right? So we're going to go right from a high level overview of what people need into what leaders can do specifically through a crisis situation. The great news is most of you as leaders in the community, leaders in health are already doing, leaders in public safety, are already doing this. Keep doing these things that you know are working so that you can provide connection, direction, and in essence, protection. So how do we go right down? One of the biggest things in health, people were saying, I don't know, Steve, I'm freaking out. Is it okay to freak out? Is it okay to freak out in my mind? Yes, absolutely, but don't unravel, right? So let's talk about courage in crisis, because courage is one of those amorphous things. Those, people say, empowerment, self-determination, courage. What do these mean in a concrete, tangible manner? Well, we're going to do this right now. I'm going to give you 3 steps to demonstrate courage in crisis. And they're these things. 1, vulnerability. 2, optimism. 3, action. And what do I mean by that? Well, here's a statement that demonstrates vulnerability. It's okay. I'm worried too. Right? Show your humanness. This will strengthen and preserve the connection. One of the worst things that we can do is not let them see you sweat. Don't show any fear. I mean, that stuff was, I don't know if it was ever useful, but don't unravel, but show some vulnerability, but don't stay there too long. Move into optimism. Show your humanness and move into optimism. Something we've made it through the big challenges before, right? We have the Red River flood, Ebola, SARS, right? It hasn't been like this, but something, we've actually tackled things that were big at the time, that were unprecedented. Everything at one time is unprecedented, right? Once you demonstrate optimism, you move to action, right? The thing we need to get to is, right? Next, the thing we need to get to is, what's the next step? What is the tangible thing that we can give to the hippocampus, right? To keep it focused. So vulnerability, optimism, action. And that's the closest we've come so far through the pandemic, where staff and employees feel that when their leaders say, it's okay, I'm worried too. When they move to optimism, immediately say, we've done this before, we can do it again. And we move to the very next concrete step. And then what's next? People are able to regulate. They're able to connect. They're able to have the clarity that they need to focus on what matters most, to stop the dysregulating, to stop the swirling, right? The reason why these are so powerful is because they're attached to what humans need. Showing vulnerability. All I did said was, it's okay, I'm worried too. Yeah, because you actually accommodated a human ontological requirement for connection. I just focused on the positive. You provided clarity. Momentarily, you gave them to focus on something that was possible, but based in concrete evidence, which is what the hippocampus loves, right? And action. You gave them a sense of control in an environment or at a time when they needed control the most. And when we do this, we actually are able to give humans and the people on our teams exactly what they need, right? Connection, direction, and protection, right? Calm, clear expectations, and trust. And when we do that, we take care not only of the people on our teams, but we take care of the people that they're responsible for. Thank you, thank you, thank you. I look forward to answering questions and comments. I'm going to try to stay within the time limit. I know that's my time. I hope you found it helpful. Thank you very much. I'm going to pass it back over to the moderator.
Thank you very much. Don't go away. You'll be on again in 15 minutes. So our next speaker is Anil Nichani from the Public Health Agency of Canada. Anil is a scientist and has an expertise in wastewater surveillance. And Anil is going to explain to us what wastewater surveillance for COVID-19 is, how we used it, and how we can use it again in the future. So Anil, the floor is yours.
Thank you very much, Dr. Amble. Can you hear me?
Perfectly.
And can you see my screen as well? Okay, thank you very much for inviting me to this BugDay presentation. Really appreciate that. Today, I'm going to talk about establishing national wastewater surveillance program for SARS-CoV-2 that we did during the pandemic. So Public Health Agency of Canada has the responsibility to protect the health of Canadians by protecting, predicting, detecting, and responding to public health threats. So to work on these lines, we have been looking at new approaches for testing and surveillance during the pandemic that could further help public health decision making. So one of these approaches is developing and implementing national wastewater surveillance program for SARS-CoV-2 that we did in collaboration with a number of other federal, provincial, territorial, and municipal partners. So this is an innovative approach where detection of SARS-CoV-2 in wastewater would indicate the presence of infection levels in the community. And also we could track the emergence and spread of variants through wastewater metagenomic sequencing. And this kind of testing is very important, and it's a very useful tool when there are limitations on clinical testing, as we saw in the Omicron wave, where there were not enough facilities available for clinical testing. Wastewater was one of the tools that we could be using for seeing the emergence of pandemic, how it was approaching, whether the signal was going up or going down in various cities. Okay, I'm just trying to go to the next slide here. Yeah, so to address and establish this wastewater testing program, we used a kind of 5-pillar approach that I'm going to explain quickly here. Under pillar 1, we primarily established surveillance for various community settings that included urban settings, remote, and institutional settings. And we also established capacity for conducting wastewater metagenomic sequencing so that we could track the emergence and spread of variants. Under pillar 2, we established a leadership role and coordination role where we were sharing information with our provincial public health colleagues and also with other partners, and also developing quality assurance programs so that the results generated by various labs could be compared with each other. Under pillar 3, our main role was to create a number of working groups that involved a number of partners from federal, provincial, territorial categories, as well as academic partners from the universities, where we could discuss various approaches for wastewater testing in terms of surveillance, in terms of sequencing, modeling, or epidemiology. Under pillar 4, we have focused on applying public health research, method development, and our advisory role, and gradually expanding the capacity for testing throughout the country. We are also working on developing on-site testing solutions in collaboration with the National Research Council. And under Pillar 5, our main emphasis has been on developing an integrated surveillance and modeling approach where wastewater data could be used for generating short-term forecasts and helping public health to guide their response. So this shows the coverage of wastewater testing across the country. The red dots here, they show the locations from where we collect wastewater and then bring it back to National Microbiology Laboratory in Winnipeg for testing. And we also work with a number of other provincial networks. For example, in Ontario, the wastewater testing is primarily led by Ontario Ministry of Environment, Conservation and Parks. And they collect wastewater from almost 170 locations in Ontario that is tested in 12 academic labs in Ontario universities. So we collaborate very well with them. This covers almost 80% of Ontario population. Similarly, in Alberta, like there is testing done at the provincial lab in Edmonton, and they have a collaboration with the University of Calgary. And they're testing from almost 25 different sites across Alberta. That again covers 75 to 80% of Alberta population. In most of other provinces, the coverage is up to 50%, and there is a scope for further growth. What I want to emphasize here that wastewater testing gives us early warning. It is independent of clinical testing. It is efficient, it is field deployable, and it is expandable. So in the next few slides, I'm going to focus on these 5 main points. So first of all, how and where we collect wastewater samples. So most of the situations, we collect wastewater samples from a wastewater treatment plant in the city, or usually cities have lift stations to bring the water to the wastewater treatment plant. So at any of these 2 locations, we could install a auto sampler that will continuously keep on collecting a small amount of sample during the entire day, and then you can collect a 24-hour composite sample at the end of the 24 hours. That would give you a kind of representative sample for the whole day. In places where this is not possible, for example, in remote locations where there are no wastewater treatment plants, or if you want to go further upstream and say, for example, want to collect a sample from a long-term care facility or a correctional institution, for example, we use these Costco balls, which are shown in the picture here in orange color. And there is a gauze or kind of absorbing material that is put in these balls, and then it is hung through the manhole in the wastewater system. And then these balls are retrieved 24 hours later and then processed in the lab for testing. In situations where even this is not possible, we could just grab the sample using a bottle, say at the time of peak flow in that area. There are some companies, commercial companies, and they have recently developed a tool that we could use to collect wastewater from aeroplanes, from cruise ships, and things like that. When the wastewater is drained from these locations, there is this tool here that would collect a sample on the side, which could be brought to the lab and processed. So this slide shows a comparison of wastewater data from major cities in Canada with the clinical results. So the top bar here shows the number of clinical cases from late 2020 to kind of up to now in these cities. And at the bottom panel, we are comparing those with the wastewater signal in those cities. So as you see, like these graphs, there is a very good correlation. And we have seen that we see wastewater signal before the clinical cases started appearing or start going up. So usually there is a 4 to 10 days window when we can see the clinical, the wastewater signal going up before the clinical cases start going up there. This is a further comparison of the same data, and on the left side here, we're comparing the wastewater signal with hospitalization rates in Winnipeg, and on the right side here, it's comparing the wastewater data with the number of clinical cases in Ottawa. So as you see again here, there is a little bit of pre-warning before the number of hospitalizations start going up in these areas. And we have tested this in mathematical models and looked at the correlation, and correlations are very good. Just to kind of compare, like when we talk about clinical testing, we're talking about testing each and every individual. So chances are, like if you're not suffering heavily, like you may not go for testing, you just might decide to stay at home and not get tested. But whether you go for testing or not, like if you stay at home and if you're suffering from SARS-CoV-2, you would still be contributing to the wastewater. The cost per person is high for clinical testing, although sensitivity is very good, but often the test results are delayed by a day or two. Whereas for wastewater testing, with one sample, we can test the whole community. So the cost per sample is pretty low. And it's a kind of early warning for us, where it would give you 4 to 10 days early warning before the clinical cases would start appearing. However, we don't really know about the sensitivity, but because we don't have a gold standard to compare it. We developed all this testing methodology during the pandemic. So wastewater testing is not there to replace clinical testing. Clinical testing has its own value and is still going to remain there. But wastewater testing gives you an extra layer of information that could be used along with clinical testing. And on top of that, like all these data, clinical reports, hospitalization data, as well as wastewater data, we have tried to amalgamate all these three into models where we could use this information to generate short-term forecasts of the pandemic, to tell the public health folks if the number of cases are going up or they're going down. And also we have
3 minutes.
We have developed wastewater testing solutions for remote locations using the GeneXpert technology. We adapted that for wastewater testing, and we could see the comparison here, where the comparison was very good. And this helped us avoid the delays of transportation of samples. So in remote locations, we could plant a GeneXpert there and do testing on site, and that gives them results immediately. Also, we have used this for tracking the emergence of variants. So as you see, like towards the end of 21, we were primarily having Delta wave. So we could detect wastewater, Delta in wastewater as well, which then gradually was replaced by Omicron BA.1, followed by BA.2, and currently we mostly have BA.4 and BA.5. We also have a dashboard that is public facing, and it has data for wastewater testing from major cities in Canada. People could use this information to look at the trends in their community and use this information to see whether the number of cases in their community are going up or going down or staying the same, and accordingly use this information to make decisions at their own level, whether they want to wear masks, whether they want to keep social distancing and things like that, rather than being guided by public health to do these things. More recently, as the monkeypox appeared in Canada, we were able to leverage onto this network of wastewater surveillance and adapt wastewater testing for monkeypox. Currently, we are doing monkeypox testing from wastewater in 13 cities, and these Red color shows here the presence of monkeypox in wastewater in that city, and like on top it's kind of epi weeks starting from kind of around July to kind of current week here. And the blue color shows here the negative results, whereas the gray means the sample has not yet been tested. So as you see in some cities here and here, like there has been the presence of monkeypox for a substantial period of time. In some other places, there is sometimes we get a random positive result, but it goes down, so it's kind of on and off. Whereas in some cities, we are not seeing monkeypox at all. And these results, they align very well with the number of clinical cases they have seen for monkeypox in those areas. So this is kind of my final slide, which kind of talks about going forward, we continue to strengthen this network. And also, as the pandemic goes down, we are going to focus on a number of other priority pathogens for public health importance. The main priority would be enteric pathogens, for example, Salmonella, Campylobacter, noroviruses, things like that. And also, we're looking at methods for testing influenza, RSV, antimicrobial resistance, and other sexually transmitted diseases through wastewater surveillance. So there are some links here for more information on our program and wastewater testing in Canada. And thank you very much for your time, and happy to answer any questions if there are any. Thank you.
Thank you very much for the three speakers. So a great question. It appears that the wastewater surveillance is primarily in urban centers. Is there anything similar for rural and remote communities, such as northern First Nations communities?
Yeah, absolutely. So as I mentioned, we developed that GeneXpert technology that we have adapted for remote locations. So part of the challenge was that we were collecting samples in those remote locations, and bringing them to Winnipeg takes 4 to 5 days because of the transportation delays and all those things. And we were not really getting timely results to the public health, because like usually that's the 4 or 5 day warning we get for clinical cases to appear. So we were kind of losing that. Now we have established this GeneXpert technology, and we have done some pilots in Northwest Territories in key remote locations. And it worked very, very well. Like the results were comparable with clinical testing, and the information was very useful to public health. So we are now deploying that more and more into a lot of northern remote and isolated communities in Canada.
Thank you very much. For Stephen de Groot, one of the questions was, do you have any recommendations or suggestions for those of us not in leadership roles who feel like our needs are not being met by our leaders in those 3 core areas? So I guess the question is, how does a worker initiate these measures if they're not in a leadership role?
Yeah, well, that's a great question. You know, I think sometimes leaders, when they have lots going on, aren't always attuned to how our people are doing. So I think sometimes simply sharing how you're doing with your leader from a perspective of connection. Are you feeling connected to the work, to the team? Are you feeling clear on what's expected of you? If you're, and I know I just put an article out called "A Lack of Trust in Healthcare, a Danger Greater Than COVID." If you're not feeling as though you can trust your leader to have those conversations, which is unfortunate, is to ask them what they're hoping to accomplish with you. So you can let them know that you want to be a good team member, and you want to produce, and you want to do what you can to provide whatever it is, whatever department you're working in or whatever area of work, and ask them to be to provide more clarity of what's expected to you from you and what they're hoping for you. It's almost like, how can I be a good team leader, right? And let them give you the kind of that almost the roadmap, if you like. The other thing is, it's important to express to your leaders how you're doing. They want to know. There is no leader that wants to get up to not succeed and not do well for their people. So find some time, if you can, to share with your leader how you're doing in the areas of connection and direction specifically.
Thank you. For Jared Bullard, and you know, I think before I ask Jared any of the vaccine questions, we have to be careful with what we ask of Jared, because he has to follow the NACI guidelines. So we'll ask Jared some off the record questions. The first is, if a healthy 5-year-old child has not been vaccinated yet, would you suggest waiting until they are eligible for the bivalent vaccine at this point, or give them the original vaccine that they're currently eligible for? Which is a great question.
It's a fantastic question. I've been asked that by many different parents actually across a couple of months now. When it comes down to, most 5-year-olds and most children are going to have some degree of protection just by virtue of having been infected. Part of the data that I was showing was saying that the seroprevalence is so high in this group, and we know that it's robust protection. Now, ideally, I would love to see the bivalent vaccine come down to children, but we just approved the ancestral strain related vaccine products in July. So realistically, this could happen, and I think we need to streamline the process to make it so that this occurs on a basis the same time as adults. But there isn't necessarily a big rush to run out and get the COVID vaccine for a child who has already had COVID. That being said, I mean, if it's something that you're particularly worried about and you want your child to have reduced symptoms overall, even the older versions of the vaccine are beneficial in that regard.
Thank you very much. For Anil, going forward, what role do you see wastewater testing playing in the community just for basic epidemiology? Or is wastewater testing something that's flavor of the month with COVID, or is this something that's here to stay?
So I would say this is something here to stay. We are looking at, we're doing a scoping review right now to see like what are the infectious agents that we can detect through wastewater. So we have identified a few, like as I mentioned in my last slide, we adapted that very quickly for monkeypox as it appeared. We are currently working on developing methods for polio testing through wastewater, because as you see, there are cases reported in the New York State, and who knows like when we may get them in Canada as well. So we want to be prepared for that. We are also already working on developing methodology to test flu, RSV, enteric pathogens in wastewater, and then doing a scoping review to see what else we could bring to wastewater-based epidemiology.
Thank you. Dr. Buller, have there been any reports of cognitive decline or long COVID in children?
There have been numerous studies looking specifically at long COVID in children and comparing it to adults. And so typically what you're going to see in most cases of long COVID in children relates to almost like reactive airway disease or persistent cough, which isn't too different than most of the other respiratory viruses. And it's typically happening about 1% to 2% of kids, and usually resolves in the space of a couple of months or weeks. And that's very, very different than what you see with adults who have about a 20 to 30% long COVID, with a lot more of, like you're talking about, the cognitive symptoms and fuzziness, etc. But part of it too is really just keeping an eye open. And I think that's why we're trying to ensure that the pediatricians here in the province and across the whole country actually are in regular communication to say, are you seeing these kids who may in fact have long COVID? And we haven't seen very many here at all. I don't think we've had any referrals to the infectious disease service, and we would expect them to show up in some other places like neurology, rheumatology, and adolescent medicine, and we're not really seeing them there either. So I don't think that we're going to see as much long COVID based on kind of that observation over the past couple of years.
Thank you. And Stephen de Groot mentioned that he can elaborate upon the previous question about what can a non-leader do to try and survive in a time of crisis. Stephen.
Yeah, no, I just wanted to add one of the most overlooked things, and that is to focus on strengths. Most leaders have an intention impact gap, and sometimes it's small and sometimes it's large. And I think for those who aren't experiencing exactly what they need, there's moments where they are. So pay attention to the times where your leader is keeping people connected, giving you that level of connection and trust, staying calm, because often leaders don't know that they're doing things that are working. So you can be helpful by saying, hey, this was really helpful. Let them know when they've been able to provide the clarity that you need so that you can reinforce and strengthen their ability to give you what you need. Because I know sometimes that we look around and say, well, leaders aren't doing what they're supposed to do. They're not connecting and directing us, but sometimes they don't know what we need. So if you can focus on their strengths and reinforce what they're doing well, that will give them a better chance to elevate their ability to give you what they need in other times. So I just had to say that I'm a strengths-based poster person and my conscience would have not let me sleep. So thank you very much, Dr. Embel, for letting me jump in.
Thank you. Now, any last words, Dr. Bullard, about when children should be vaccinated? And again, there's several questions about, should we wait for the bivalent vaccine? Should we get the vaccine that's available? Can you reinforce the comments that you made earlier?
Right. So I think the key is really that I'm hoping to see the bivalent product come down to, for sure, 12, but I'd like to see it in younger, because it makes sense. If you have an Omicron-based spread in the community, to give them an older vaccine may not be as helpful in preventing infection, but it will still be beneficial in terms of clinical severity and hospitalization and those sorts of things. But I think what's really, really critical is that over the course of the pandemic, there's a number of children who have not been vaccinated with primary vaccinations. And so those are essential. We have to ensure the children get those. And in addition, I would also suggest getting the influenza vaccine for them, because we are suspicious that this will be a bad flu season. And so that will definitely help them, because they are definitely impacted by influenza.
So basically what you're saying is make sure that the vaccines are all caught up to date and ensure that influenza is also up to date. So thank you. And Neil, if the federal government gave you all the money you wanted for your projects, what would you do next with wastewater testing?
So I think currently what we are trying to do is expand the wastewater testing to remote locations as much as possible. So that is kind of our primary focus as of now. And again, like as I said earlier, we want to establish wastewater-based epidemiology for a number of infectious diseases and chronic diseases in Canada. So that's where we would invest that funding.
Well, thank you very much to our three speakers. Thank you for great presentations. We'll now transition over to the next block of sessions. I'd like to introduce Dr. Sergio Finella, who will speak about vaccine hesitancy, a topic about which he is very passionate. Sergio is a pediatric infectious disease physician. Not that he's a pediatric physician, he's actually an infectious disease physician who specializes in pediatrics. And he has an interest in antibiotic stewardship and medical education. Sergio is a member of the Canadian Pediatric Society Committee on Infectious Diseases and Immunization. And again, Sergio will speak to us about vaccine hesitancy and how to approach vaccine hesitancy and what it really is and why it's a challenge for parents and providers. Sergio.
Thanks very much, John. I will go ahead and start sharing my screen. Okay, that looks good. Okay, and I will apologize if you hear screaming baby in the background, that we have a four-month-old little girl at home. So, and the key when you're giving a talk is don't leave the soother right in front of your computer as you're about to start the talk. So I'm Sergio Finella. I'm a pediatric infectious disease physician. And the learning objectives for today are basically the same that's in the program. We're going to talk a little bit about the concept of vaccine hesitancy, and then we're going to touch on how it might manifest, how you might encounter it in a routine clinical day. And then we're going to talk on some strategies, communication strategies, as to how you might be able to address vaccine hesitancy. So in terms of disclosures, I'm a member of the CPS Committee on Infectious Diseases and Immunizations, as well as a member of the Manitoba Provincial Vaccine Advisory Committee. And I'm the local site principal investigator for a funded study through Moderna looking at SARS-CoV-2 immunization in children 6 months to 5 years of age. So instead of baby pictures, I'm going to go in the other end of the age spectrum and show you some grandparent pictures. These are my mom's parents. So Al and Mary Sochacki of Detroit, Michigan. They had 8 kids, including my mom. When I was a kid, we spent a lot of time at their place, pretty much almost every weekend. We were over there. We lived just on the other side of the border. And being a nerdy kid, they would always tell me stories about the history of Detroit. And one of the ones that stood out to me was about outbreaks of polio in and around the Detroit area in the late 1950s. Now, 1952, so 3 years before the availability of the Salk polio vaccine, over 52,000 people in the United States contracted polio, and there were over 3,100 deaths associated with polio. It was a frightening disease, to say the least. There would be regular peaks in the summertime with swimming pools, movie theaters, outdoor parks, all were regularly closed in an attempt to curb transmission of this disease. There was a national poll in the early 50s that found that polio was second only to the atomic bomb in terms of the thing that Americans feared the most. So 1954 began what would be the biggest test of a medical product in history up to that point. The National Foundation for Infantile Paralysis, also known as the March of Dimes, footed the bill for a trial that would involve over 1.2 million children at a cost of over $75 million US using today's dollar value. The March of Dimes was originally set up by FDR in conjunction with one of his former law practice partners. The historic results were announced on April 12, 1955, actually 10 years to the day from the death of FDR. And the results were a resounding success, over 90% effective preventing paralytic polio. And within the next few years, there was a very rapid rollout of the Salk vaccine. But despite the availability of the vaccine very early on, there were pockets of disease that popped up around the United States. The biggest of all actually happened in Detroit in 1958. The numbers were actually very similar to what was seen in pre-vaccine years. Now, in a population at the time of close to 3 million people, there were over 400 paralytic cases and 25 deaths associated with polio. You can see from the map that there were clusters in the downtown core areas, and these are largely non-white African-American communities. Rates of paralytic polio were more than 10 times what was seen in the white and Caucasian population and neighborhoods. Now, that fact was actually a change as compared to the pre-vaccine years. Now, there were many reasons identified for this at the time. Surveys identified indifference and lack of health awareness or facts regarding polio and polio immunization, and in some circumstances, fear regarding safety of the vaccine. As well, crowded living conditions and access to care due to segregation played a role. Detroit was one of the few northern cities that were destinations for African Americans leaving the South, seeking a better life elsewhere. Many of the cases during this outbreak were in families that had been in Detroit for less than a year. Now, once the governor declared a state of emergency, they rolled out over 2 million doses of vaccine that were made freely available, and the outbreak was brought to an end. So I think you could, having heard that, likely appreciate some similarities between polio in the 50s and the COVID pandemic. This is a side-by-side map. The color map on the right shows you a snapshot of some weekly COVID rates in the same Detroit metro area. So not only do we have disproportionate impact on certain racial and ethnic minority groups, but also the same idea of hesitancy towards a vaccine that was safe and effective and worked very well, especially against the worst forms of the disease. So what is vaccine hesitancy? Well, I think there are a couple of definitions that we could look at. Clearly, there would be some context that needs to be considered. So in general, we could say that it is doubt or being indecisive about what to do in regards to vaccination. Or there's a definition put out by the World Health Organization Specialty Advisory Group on immunizations, which defines it as a delay in acceptance or refusal of vaccination despite the availability of accessible vaccine services. So the idea central to both of these ideas, both of these definitions, are to express that there's a spectrum to how people decide about vaccination, that it is often not an all or nothing viewpoint, with true vaccine hesitant persons falling somewhere between the ends of the accepting spectrum. And it is also used to try to depolarize the idea of a purely pro versus anti-vaccine sentiment. So what factors influence decisions about vaccination? Well, it can be the person's context, their environment. I think many of these will clearly have overlapping influences, especially when we look at things like media, politics, the accessibility to healthcare and to vaccine services. Not having an understanding of the diseases you're trying to prevent or how you view your own health will impact your views on vaccines as well. Now, I think from the list of the vaccine-specific factors, the one that is often overlooked, and I think it actually came up in some of the Q&A comments from the last block, is how they are given, how it relates specifically to needle phobia. So while not being a new problem, hesitancy has increased in scope and scale, really being amplified in particular by social media. Now, this figure overlies two timelines. On the top, you got key events influencing vaccines, and on the bottom, you have key points in the history of social media. And now, anytime you have a new vaccine that's developed and released, there are always new questions that arise, and consequently, lots of searching on social media platforms, which are just rife with misinformation. There was an Italian study that showed in the 10 years after its launch in 2005, negative videos about MMR vaccine on YouTube outweighed the positive ones by a factor of 3. Or things could be very vaccine specific. An example of social media's impact to really drive anti-vaccine messaging was with human papillomavirus, HPV vaccine. It was first approved in 2008. And there are stress-related responses to HPV vaccine, and these are defined as things like fainting, dizziness, lightheadedness. And some of these were initially posted on Twitter in 2013 and led to such a social media-driven anti-vaccine movement that the government of Japan actually withdrew its active recommendation for HPV vaccine for over 9 years, only just being reinstated earlier this year. Now that messaging, that spread to other countries. And modeling has shown that in Japan alone, due to the decreased rates of HPV immunizations, there could be as many as 25,000 preventable cases of cervical cancer and 5,000 cervical cancer deaths. So all those contributing factors to hesitancy, we could group them into 3 main models. One would be confidence. So this is trust in your effectiveness and safety of vaccines, the system that delivers them, the motivation of the policymakers, et cetera. There's complacency. This is where there's a low perceived risk of vaccine preventable diseases, and vaccination isn't thought to be kind of a necessary preventative action. And then finally, convenience. So these are things like physical and geographical availability, affordability, if that applies, and then overall appeal of general immunization services. So how might hesitancy be encountered in your clinic or in your daily work? So how could you identify it? A first step, I think, would be to use a presumptive statement about vaccination being the default plan for when you see a client during an appointment. And this could be something like, today we're going to give Sergio his vaccines. And if you get the all clear, all affirmative, then great, you can carry on. However, flags for a vaccine hesitant caregiver can include the statements that you might see listed here on the screen. So how would you approach this? What would you do next? I think often our response may be one that is more directive or argumentative, such as, that's not correct, research supports vaccines. So that sort of style has the end result of really decreasing trust between the parent and the clinician, and vaccine uptake does not improve. You really need to invest the time in learning the reasons and motivation behind the hesitancy with the goal to move the patient or the client into the vaccine accepting camp. And that's where motivational interviewing comes in. This is a tool that's been around for a long time in other areas of medicine as a way to elicit behavioral change. It has been adapted to help address hesitancy, with studies showing it can significantly increase rates of uptake. The key points are that it's a collaborative way of interacting with patients where you explore their reasons for hesitancy with the end goal of changing attitudes and behavior. So for the last couple slides, let's talk about how to do this. So for a more effective conversation, you can focus it around 5 main questions. First, avoid yes/no questions. Keep them open-ended. What do you think? What are your concerns about vaccines? Second, based on what they tell you, it's your chance to use your words to acknowledge their concerns. These can be simple, where you just repeat back what they said. I understand that you are concerned about side effects. Or they can be more complex, where you repeat what you think they mean. You want to make the best choice for your child, but you are uneasy. Third, to affirm strengths, you could say something like, it's great that you're starting to consider vaccines. And for validation, something like, the health of your child is important to you. As you listen to details, you can drive into concerns as they are raised. Use the ask, provide, verify framework. You could ask, what do you already know about vaccination? Then provide some specific info based on what they've shared with you. Then you verify they have understood and what they will do with that info. Now, like any discussion, to close out, you want to summarize the interaction, such as the main point to remember is X, and then from there, determine your follow-up plan. If they are yes, great, vaccinate and give praise to enforce the positive decision. However, if it's a no, but they want more follow-up, you could say, well, let's revisit once you've had a chance to think more about it. When can you return? If they are an outright refusal, don't debate with them, but rather leave the door open to talk more. Don't dismiss them from your clinical practice, because then your odds of changing the behavior will be 0. Of course, if you want to adapt the conversation, taking into account your particular setting in terms of culture, social norms, level of education of the client, et cetera, certainly that should be done. So remember, one of the goals of this motivational learning approach is to increase trust. We heard about trust in one of the other sessions. Increase the trust between you as the provider and then the caregiver, the patient. A regular healthcare provider is the resource parents trust most as a reliable source of info around vaccine questions. There was a global survey from over 140 countries that as high as 90% of respondents saying they would trust their physician or a nurse. By taking the time to interact and listen, it really helps to show that you care, and that along with this, demonstrating that you have a high level of competence around vaccines helps you push into that circle of trust. So to conclude, we learned today that vaccine hesitancy is indecision and uncertainty around vaccination despite its availability. And it is something that is dynamic and can change over time as well as context. Factors that impact hesitancy can be grouped into broad categories that center around themes of confidence, complacency, and/or convenience. All hope is not lost, though. We can increase vaccine acceptance by using various evidence-based tools, one of which is by listening to the patient's perspective using motivational interviewing as a tool. So I would be remiss if I didn't include at least one baby picture. So there you have it. So thank you, and I will be around for the Q&A period. I will turn it back to John.
Thank you very much. Rachel DeWillow will now speak to us about an update on tuberculosis infection and preventative therapy. Now, it's interesting. This morning, the opening presentation was all about tuberculosis, but we seldom speak about tuberculosis in children. So Rachel's presentation will be ideal. So Rachel's a specialist, is a pediatrician with a specialty training in infectious diseases. In addition, Rachel has additional training in the diagnosis and treatment of tuberculosis in children. Rachel is the lead author on the pediatric chapter in the latest edition of the Canadian Tuberculosis Standards. Rachel, would you like us to go to Lane to talk about germaphobia, and then we can come back to you?
Well, yeah, and I'll figure out how to do this.
Okay, well, Lane, I hope you're available. I apologize for calling upon you sort of at the last minute. So as a matter of introduction, Lane is a clinical psychologist with the clinical psychology group for Shared Health and an assistant professor in the Department of Clinical Health Psychology at the Max Rady College of Medicine. Lane has spoken to us on several occasions about germophobia. And if the COVID pandemic didn't heighten our awareness of germs, and drive us to become germ phobic. Nothing would. So we thought it would be a timely refresher about germ phobia and how do we not become germ phobic, even though society has programmed us to be germ phobic. Lane, you're on.
Okay, hi everybody. Glad to be here, and thanks, John, for inviting me. I assume the slides are up there okay?
Perfectly.
Okay. So as John mentioned, I am a psychologist. At least I think you said that, John. And one who works in an anxiety treatment clinic, where one of the problems we try to help people deal with is excessive fear of germs and contamination. The key word here, of course, is excessive, and we'll focus on this quite a bit as we go along. I also want to acknowledge, though, that the world, of course, has changed a bit due to COVID, and so our idea of excessive has also been altered a little bit. Before we get going, though, given that I'm going to be kind of cautioning against going overboard on germ avoidance, I want to offer the following somewhat tongue-in-cheek disclaimer. Efforts to promote infection prevention and control are important, and this is especially important if you work in healthcare. So nothing I say should be taken to contradict the sage advice of other speakers or minimize the importance of following public health guidelines. Now, I'm going to do my best to try not to let COVID completely hijack this talk, since the fear of germs existed long before COVID came around and is going to continue to exist even as COVID lessens. So consistent with the title of the talk, let me start by defining a germ phobia. So to qualify as a phobia, the following have to be present: not surprisingly, marked fear or anxiety about germs, and avoidance or avoidance of situations where germs might be encountered. Now, the bottom two bullet points are important. The fear or anxiety has to be out of proportion to the actual danger. So if you're avoiding touching public door handles because you're worried about contracting HIV, that's out of proportion. If you're someone who is elderly and immunocompromised and you don't want to sit right next to someone who is COVID positive, that may well not be out of proportion. And lastly, the symptoms have to cause significant distress or life impairment. Now, in my line of work, most of the people who come to our clinic would have a diagnosis of a certain subtype of obsessive compulsive disorder. When people have this diagnosis, they have obsessions, intrusive thoughts about contamination that cause a lot of anxiety. And they also have compulsions, which are behaviors that the person feels a really strong need to do in order to get rid of the anxiety and to feel better. Things like excessive hand washing or excessive use of disinfectants. And those compulsions are defined as such if they take a lot of time, say greater than an hour a day, or if they're really done to excess or according to strict rules. Now, excess, could look like, say, a single hand wash taking 10 minutes, or say washing hands 100 times a day. And with all these things, we have to take context into account. If you work in healthcare, for example, washing your hands a much larger number of times a day may be quite normal. Sometimes strict rules are involved with the hand washing. A person may sort of divide their hands up mentally into sort of 60 different quadrants and feel that they have to wash each quadrant an even number of times. Or they might have some sort of counterintuitive rules, like not looking at their hands when they're lathering up. Because if they were to look at their hands and see a section that wasn't fully lathered up, they might have an intrusive thought that maybe they haven't soaped up properly, and they might have to repeat the hand wash. Now, for purposes of this discussion, I'm going to use the terms germ phobia and OCD relatively interchangeably. They're not really the same thing. OCD adds a sort of an element of excessive doubt that can come in there, as in the example of the person not wanting to look at their hands. But regardless of what we call it, it's a problem when the fear and anxiety are out of proportion to the actual danger, the behaviors that are designed to ensure safety are done to excess, and the problem causes a lot of distress or interference in the person's life. So what would be some common sources of OCD contamination fears? Well, an obvious one would be objects touched by other persons: door handles, elevator buttons, bus poles. And again, these are fears that people have had for a long time in the area of OCD, well before COVID, in relation to other kinds of contamination, but they've certainly been elevated for many folks because of COVID. Bodily secretions from other persons or from oneself, feces, urine, and as a result of that, many people have a lot of trouble using public washrooms. Garbage or garbage cans can be a major source of worry. Animal secretions like dog or goose poop. There's a lot of goose poop around these days. You may have seen that if you live in an area where there's a lot of geese. And so folks with this worry may have a lot of trouble walking through grassy fields, may not want to walk inside the house with shoes on because of the worry of spreading that contamination around. And raw meat is another. So what would some symptoms of contaminated related OCD be? What would this look like? Well, not surprisingly, you might see people going to great lengths to avoid touching objects that other people have touched. They might completely avoid public washrooms. They might not touch objects that have touched the ground. So again, if they worry a lot about, say, dog poo being tracked into a place and they drop a pen on the ground, they may not be able to pick up and use the pen. They might change clothes completely after a bowel movement, say worrying about microscopic flecks of feces being on their clothes and that might contaminate them. Washing hands for far too long or far too often. Again, keeping in mind the context, some people need to wash more by virtue of their occupation or other factors. And maybe taking extremely long showers or baths. Some people with OCD may need to shower or bathe for 2 hours or more at a time, which, as you can imagine, is extremely distressing and interferes a lot. So we want to keep in mind the definition of OCD there, that those kinds of behaviors only qualify for a diagnosis of OCD when they use up a lot of time, when they're excessive, and they produce a lot of distress and interference. You don't have OCD just because you use a paper towel to open the washroom door. A lot of us do that. And a lot of these other kind of normal things that many people do. In terms of treatment of OCD, the two main treatments that have been shown to have the best evidence for success are certain kinds of medications, especially selective serotonin reuptake inhibitors. A few examples are listed there. And an older generation medication called clomipramine. The other thing, or the other approach that has a lot of evidence is a form of cognitive behavior therapy. This is a psychological therapy called exposure with response prevention. Now, what does ERP look like? Well, it involves exposure, as the name implies, and that's really just a fancy way of saying practicing facing the things you fear, often by touching the sources or the things that feel as though they're sources of contamination. And at the same time, engaging in response prevention, which is refraining from doing the compulsive behaviors that people do excessively in order to feel better. Now, if you imagine that sounds really challenging for people to do, it is, and it takes a lot of courage for people to go through this process. We, in recognition of that, we try to help people along by having them face their fears gradually using what we call an anxiety hierarchy, which is kind of an anxiety ladder that you get people to climb as they're going through this process. So for this person who looks as though they're struggling with worries about, say, dog poo germs on the grass or that have been trafficked into their home, we might have them start with touching and then maybe even sitting on the floor in their clothes, say starting with a low traffic area of their home, which they're only rating here as a 30 out of 100 on a 0 to 100 anxiety scale. So they'd sit on the floor, rub their hands on the floor, then get up, maybe sit on their couch, go into the kitchen, touch the cupboard handles, touch the TV remote. And if they do that often enough, the anxiety will diminish, at which point we would then move on to the next step and the next step, doing the same thing at each stage until eventually they're able to sit in the grass in a dog park. When people do exposure with response prevention and go through a good program, usually that has these results. It reduces the anxiety associated with touching contaminated objects. It creates greater tolerance of uncertainty about living with normal day-to-day risks. And it results in changes in beliefs about dangerousness. The central one there is really an important one because you can never be absolutely certain about avoiding contracting the disease. But what you can do is to learn to live better with the amounts of uncertainty that go with living a life without excessive restrictions. So that's what we're trying to do in ERP. Now, some of you will be rightfully thinking, yeah, but the situation certainly has changed with the advent of COVID, and does that entail a modification in these procedures? Well, as a matter of fact, it does. Especially early on in the pandemic, there were articles coming out talking about how exposure with response prevention should be modified to follow public health guidelines. So we certainly try to do that when we're engaging in treatment. And that usually involves a greater focus on the response prevention side of things, that is restraining people from their excessive compulsions rather than deliberately focusing on touching contaminated surfaces. So as the bottom bullet says, we're now really focused on eliminating the excesses, there's that word again, in washing, cleaning, and avoiding. So in sort of putting this in the context of COVID, germaphobia, and OCD, we really need to acknowledge that there's a lot of very normal uncertainty and fear about the virus, as we heard earlier, I think, from Stephen. That's been true at various points in time during the pandemic. It's sort of gone up and down. So we need to acknowledge that. We need to also acknowledge that public health orders have been designed to sort of push us more in the direction of the kinds of behaviors that we might before have regarded as excessive. So how we define excessive has really had to change. We also need to note that pandemics are dynamic. So our definition of excessive really can go up and down depending on what the current rate of transmission is, whether there's a new variant that's been prowling around, and what the current public health orders are. Having said that, there are certainly some people who, in light of COVID, have really found themselves going to extreme lengths in order to try to avoid the risk of contamination. So what might we see if somebody's exhibiting an excessive fear of COVID? Well, we might see behaviors that are far in excess of current public health guidelines. People washing their hands too often or too long, avoiding touching surfaces others have touched. Sometimes people will avoid going outside the home, period, to avoid contracting the virus, even to open outdoor areas where there's nobody around. Leaving groceries or parcels in quarantine before we're bringing them to the home. Other things we might see, separate from public health guidelines, checking the internet for long periods of time. It's been said there's sort of an infodemic around COVID, lots of information, some of it misinformation, and people may spend hours online trying to get reassuring information and find out more about COVID, and it's driving their anxiety up. Some may check their own bodies for signs of infection far too much, taking their temperature repeatedly, checking their breathing repeatedly. And others engage in excessive seeking of reassurance from family and friends about the virus. Maybe asking about symptoms, do you think I'm okay? But asking this repeatedly again and again and again, despite having been given reassurance. So how do we know when something is a problem? Well, there's no hard and fast rules about this, but some things that one might want to consider in deciding whether one has a problem or someone one knows has a problem. Checking with public health guidelines can be very helpful, and this is the provincial website link. And asking oneself the question, am I going overboard when I compare my behavior to what's posted there? How distressing are the worries, or my worries about germs? Am I thinking about it all the time? Is it highly distressing? If so, much more likely that it's a problem that one might consider doing something about. Asking others one knows and trusts, what do they do in terms of trying to, wash or clean things or avoid sources of contamination or be out in public situations. And with all of this, of course, one has to take into account one's level of vulnerability and personal risk factors, age, immune status, those sorts of things. And physicians and health professionals can be a guide as well in deciding if something is a problem. So lastly, in closing, just to summarize a little bit about sources of help for whether we call it OCD or germaphobia. Some people are able to do a lot of work in improving problems with this kind of a difficulty by educating themselves about the problem. There's a lot of good self-help books out there. The first three there I've listed are OCD books. There's a phobia one at the end. Got to keep in mind with the OCD ones, these were written pre-pandemic, so some of their suggestions aren't modified in accordance with current healthcare guidelines. There are a lot of good self-help organizations that can provide a lot of information. A lot of online resources, resources that would have information, podcasts, a lot of self-help ideas. I've listed some here for OCD and some for COVID anxiety. I understand people have access to this, so I'm not going to go through them individually. Speaking to one's family physician could be a good place to go for some help if it's a more serious problem. They can provide advice about resources, possibly prescribe a medication if needed, and segueing to the last bullet point, maybe make a referral to a mental health professional if that should be required. And that is everything I had to say.
Well, thank you very much. Don't go away. We'll see if Rachel DeWillow is ready, and then we'll have you back for the question and answers. And I see a number of questions that have already appeared, so it should be a lively discussion. And Rachel, are you ready?
I will try again. All right, well, thank you very much for inviting me, and apologies for the technical difficulties, but we'll proceed with my talk. My name is Dr. Rachel DeWillow, and I'm an assistant professor in the Max Rady College of Medicine. And today, I will be talking about the updates on tuberculosis infection and preventative therapy. Next slide. And so the objectives of my talk today are to keep it fairly simple. It can get a lot more complicated, but the point is to help get a better understanding of this issue. First, I will talk a bit about the epidemiology of tuberculosis in Manitoba and Canada. I will define the concept of tuberculosis infection, and I will help you understand the rationale behind the latest Canadian recommendations for preventative therapy. Next slide. I have no conflicts of interest to declare. Next slide. The only disclosures I have to mention today are that I'm the lead author of one of the chapters in the Canadian TB standards that was published earlier this year. And I'm a tuberculosis consultant for two of the regions of the Nunavut tuberculosis program, as well as the WRHA tuberculosis program. Next slide. So again, just a brief primer on TB, and this is very brief so that everyone is on the same page as to what TB is and does. And so TB is classically one of the infections prior to everyone talking about in COVID. That was one of the few infections that was acquired through airborne spread. And so how do people get TB? Well, an infectious TB patient, and it has to be of the respiratory tract, coughs, sings, or speaks. And what happens when they do this is that they essentially propel the germ through the air. And anyone sharing the same airspace of them is susceptible to breathing it in, it entering their respiratory system and bloodstream. Next slide. So what does TB disease, or also known as active TB when you're reading information on TB, look like? Well, it's predominantly a problem of the respiratory system or lungs. And so just as, again, a very quick and dirty comparator, that we have a normal chest x-ray on the left. And if you look at the two big black things, for those that are less familiar with reading chest x-ray, those are the lungs in a healthy individual. And so what we see is a lot of dark, and dark means there's lots of air and healthy lung tissue. And if we look on the right, those two big black things that are nice and dark with the stripes of the ribs over top basically have what looks like cloudy snow-like appearance. And that cloudy snow-like appearance is basically TB that's infected the lung and causing damage. Next slide. And so TB is predominantly a respiratory disease. That's the predominant form it comes in, but basically has the ability to affect any part of the body, any organ system. And so one of the most severe forms of TB that people get sick from is CNS, or central nervous system tuberculosis. And so in the MRI of the brain on the left, you see small white circles throughout the brain. What that is multiple deposits of TB in the brain, and this is associated with high morbidity and mortality. One of the more common forms and less severe manifestations of TB are lymph node TB. And on the right there, you see an infected lymph node from tuberculosis. Next slide. So now that we understand TB, who gets TB in the globe? Well, basically, before we speak about the epidemiology, what that was also briefly mentioned today, is that TB is a very common disease globally, and probably around 10 million people had tuberculosis in 2018, and was the leading infectious disease cause of death, above that of HIV, prior to the COVID-19 pandemic. Next slide. And so if we look at what's happened with TB in Canada since we started tracking it, we can see in the 1920s to the 1940s, if we look at that blue line, we can see that the number of TB cases per 100,000 people in Canada was very high, at around 100 there, it peaks. And so that rivals that of low and middle income countries now. But with the advent of public health systems and better drugs, we have now dropped it dramatically, and it's about 5 per 100,000. Next slide. And so what kinds of TB do Canadians suffer from? Well, this is being tracked by all the public health systems in provinces and territories. And so predominantly, again, not surprisingly, most Canadians who are diagnosed with TB, if you look at the right of the top red circle, about 75% of them will have had a form of respiratory TB. Next slide. And so who in Canada is affected by TB? And this was also mentioned before, but again, you know, it's very important, as Dr. Rueda mentioned earlier this morning, to understand that not all Canadians are equally likely to be diagnosed with tuberculosis. And so in Canada, because we've kept track at who gets it, we know that the data shows that this is a disease of people that are born in other countries where TB is more common, and Indigenous Canadians. And so the take-home point of the top graph is that the purple bar that's way above the other ones, that's the Inuit population. And so it is well above that of anyone else that's affected by TB in Canada. And if we look at the graph below, we can see then that the next most common groups affected are First Nations persons living on reserve and those living off. That's the light blue bar, and then the red graphical bar. And then below that is TB of foreign-born people, and that's of the light purple bar. Next slide. And so if we break this down by province, again, as not surprisingly, as I showed in the previous slide, the most affected group of Canadians are those that live in Nunavut. And then the next one is the next population broken down by territory or province is those who live in Yukon. And then unfortunately, Manitoba is the province with the highest rate of TB in 2016 and 2017. Next slide. So what can we do about this in addition to treating people once they get sick? And so between being exposed to TB or sharing airspace with TB and getting sick, there's actually a point at which we can intervene in between and offer treatment. And this would be treatment for what we call tuberculosis infection. Next slide. And so again, as was also mentioned earlier this morning, we used to think that TB was a much more simplistic infection than we've actually come to know. And so after exposure, if someone breathes in the TB germ, they become infected. And we used to think that there was only these two states. Either you were sick with TB and had active disease, or you were not sick with TB, had the germ inside you, and were infected, which was also called latent. Next slide. But what we now know in between these two states outlined by the red circles is that there's likely much more nuance to what happens in between these two states. And this is an area of active research to try and figure out how do we diagnose these and treat these two states. But for today, I will just speak about the one that we know a bit better, which is infection. Next slide. And so what is tuberculosis infection? It's actually a really hard question to answer and not so simple. And so, like a lot of infections that we try and treat, how we usually know that there's an infection or prove that there's infection is by a gold standard test. And those gold standard tests are things that we do which grow germs in the laboratory. We actually can't do this with TB infection. So people have tried to come up with other ways to do this. And one of the more common ways that a lot of you may be familiar with is what's called the tuberculin skin test or the Mantoux test. And the picture on the right shows a large area of what we call induration or firmness in a positive skin test. And so what this is actually doing and what we actually define TB infection as is a state of persistent immune response to TB antigens without being sick or having measurable TB in the lab. And so basically what we're doing is we've made tests up to measure immune response. And so we have another test, which is a bit newer as well, that's available, which is a blood test called the interferon gamma release assay, which essentially does the same thing a little bit better than the tuberculin skin test. Next slide. And so how many people have TB infection and could benefit from treatment? Well, we actually don't know because no one keeps track of this. And so our best guess, and it's a pretty astounding figure, is that 1/4 of the global population is infected with tuberculosis, which if you think about it, is a pretty staggering amount of people. But again, we actually don't know this, and we use surrogate markers as a projection for this infection. Next slide. And so just before I speak about treatment, the last part of my talk, just as a brief comparator of what TB infection is versus active TB or TB disease. And I thought that this was a nice way to compare it because again, I found it hard conceptually when I was learning about it. So a person with TB infection is thought to have a small amount of TB germs in the body that are alive, but aren't doing anything, basically dormant. And so that person doesn't have any symptoms of TB, and they cannot spread this TB in this state to other people. Versus a person who is sick with TB has much more TB germs in the body and is sick. So things that we traditionally associate with TB of the lungs are a chronic cough, chest pain, coughing up blood, weight loss, and sweats. And definitely in this state, you can spread this to other people. And so someone with infection will have a normal chest x-ray and you'll not be able to grow any TB in the lab, versus someone who is sick with TB, depending on where it is, will have abnormal imaging and positive microbiology samples. Both people will benefit from treatment, and the treatment varies a little bit from that of TB disease for TB infection. Next slide. So prior to the update this year, the standard that was being talked about in Canada for treating TB infection, which they've shortened here to LTBI, is isoniazid for 9 months. As this historically was the best evidence for treatment of TB infection, and everything else was considered secondary. Next slide. And so isoniazid is great, but you have to be able to take it all. And so 9 months of a drug that tastes horrible and causes liver problems in people tends to have low rates of completion. And again, this was the standard of care for many decades. And so this has led to the further investigation of shorter, more tolerable prescriptions for TB infection. Next slide. And so only within the past decade have we actually gotten good studies on what else could work besides isoniazid. And one of the more recently published studies is that of rifampin. And this is actually done by some Canadian investigators. And so everything new always gets compared to the standard, which is isoniazid. And so what they did is they compared 4 months of taking rifampin to 9 months of isoniazid. And they did this in a randomized control trial, which is considered great science. And it was found to be non-inferior to isoniazid, safer, and people were more likely to complete it. Next slide. And so the newest kid on the block that people may or may not have seen is a cousin of rifampin, and with that it's been called rifapentine. And so the benefit of this drug in comparison to rifampin is that it has a longer half-life. What does that mean? It stays in the blood at high levels, which means you don't have to take it as often, and has just as good activity against the TB germ. Next slide. And so this is a huge, again, landmark study published in the New England Journal. And what they found was if you use this cousin of rifampin, rifapentine, with isoniazid, you could take it for 3 months and it was just as good as 9 months of isoniazid. And people were more likely to complete it. Next slide. And so how do we look at all these treatment regimens, and how do I decide and other people decide what to do for TB infection? Well, first, we look at duration of therapy, the number of doses, and a few other things. And so basically, any of the rifampin or R-named regimens and rifapentine are much shorter in terms of how many months you have to take them for. And if you look at the last column, the 3 months of INH and rifapentine, it is 12 doses versus many, many more doses in all the other prescriptions. And so again, isoniazid regimen, but again, people don't complete it. And it is quite hepatotoxic, which worsens with age, meaning people are at risk of liver injury. But again, the downside, and there are some downsides to the rifampin and rifapentine-based prescriptions, is that rifampin-type drugs tend to have a lot of drug-drug interactions. And again, they interact with blood pressure medications and diabetes medications. So one does have to be aware of that when prescribing that. And finally, and unfortunately, rifapentine is actually not yet Health Canada approved and is only available via special access in Canada. We are very fortunate that we've had some good advocates in our TB program who have gotten access to this excellent prescription. Next paragraph. And my final slide. So this has led to the update in the Canadian TB standards, which is a huge, I think, huge change in terms of what was being recommended about 10 years ago. And so isoniazid or 9 months is no longer considered to be the regimen of choice or prescription of choice. And we now recommend that rifapentine and isoniazid therapy taken for 3 months once a week, or rifampin, depending where you are and depending what access you have, taken on its own for 4 months, are the treatment of choice. And again, these are much less burdensome for patients and have much less side effects, and people are more likely to complete them and benefit from this treatment. Last slide. And so that brings me to the end of my talk, and I'm happy to answer any questions.
Thank you very much. So a number of questions in the chat. So for Lane, what are the triggers for germ phobia? I mean, one day it's business as usual. The next day you have a heightened awareness to your environment and germs. How does that happen?
Well, I think it can happen in a number of ways. And I'm not sure it always is just, sort of the next day you have a heightened awareness. I think for some people, they may encounter, a kind of a traumatic experience where they suddenly were exposed to a situation where they had sort of a real sudden surge of worry about, well, let's say COVID, and that then can linger and create an ongoing problem. For other people, it can be kind of a gradual buildup of stress and uncertainty around, well, let's use COVID because it's the most obvious recent example. And just bombardment with information. We're constantly getting information, especially for people who are online a lot, about dangerousness, and I think that can really get into people's heads, and over time can spiral into a germophobia for some individuals. Other people seem to be quite sort of immune to those things and quite resilient.
Thank you. So a number of great questions for Dr. DeWillow, and some related questions. What is the role of BCG for children at risk, and not part of the conventional vaccination stream? Should it not be part of the conventional vaccination stream?
Right. So yeah, that's an excellent question and comes up a lot. And so BCG vaccine, its primary use is that it prevents severe TB disease in young infants and children. It doesn't prevent TB infection necessarily, the state before TB disease, but it prevents severe forms, which would include CNS tuberculosis or miliary tuberculosis, which are associated with high levels of morbidity and mortality. So that's the purpose of the BCG vaccine. And so it actually is a routine vaccination in other countries where they have much higher rates of TB and people are more likely to encounter it and get sick with it. So for example, I see a lot of children from India and the Philippines in my practice, and it is common to get BCG vaccine at birth. Here in Canada, again, it's a more strategic approach, and only certain communities get it because, again, you have to balance side effects and risks related to vaccine with benefit to the entire population in terms of cost benefit as well. And so it's still widely used in Nunavut, where the rates, again, as I showed in my slides, are quite high of encountering someone with TB, as well as in several communities in northern Manitoba.
Great. Now, part B to the question, what do you do when there's family screening and children have received BCG previously, whether it's children of foreign-born people or children from remote communities in Canada? Now what? They invariably have a reactive MAN2 test.
Yeah, that's right. Again, because the MAN2 again reacts with BCG and also reacts with M tuberculosis complex as well. And so there's a couple of things to that question. I don't just use the TST result in that situation. And it's felt to be that the farther out you are from your BCG vaccination, so by the time you're 5 or 6 years out, it really shouldn't be influencing your TST result. Can I say that for 100% certainty? No. But again, they've done studies looking at this. And again, the farther out you are, the less likely it is to actually be playing a role. So again, when someone tells me that from a TB endemic country that they got a TST and they're 30 years old and they had their BCG when they're an infant, that a positive TST in that scenario is unlikely to be your BCG. Again, it's tricky when you get to children. And again, it's only one part of the decision to treat. So then I look at someone's exposure, and I look at their chest X-ray, and I decide from a risk-benefit perspective whether to treat them for infection. And again, a lot of the times in children, and now with some of these newer regimens that we have, there's much less side effects to them. And so again, if I'm preventing TB disease in children, but we're using a 4-month or a 3-month prescription versus ignoring it, I would always err on the side of caution and trust the TST. Again, might it be a false positive? Yes, but then I look at the risk of treating versus not treating.
Thank you. So great question for Sergio Finella. Dr. Sergio, my concern is low uptake in flu/COVID vaccine among healthcare staff. What can be done to alleviate vaccine hesitancy among this group? I know your presentation was turned towards pediatrics and families, but any tips? Great presentation too. Thanks so much. So what do we do to optimize vaccination amongst healthcare workers?
Yeah, that's a great question. I mean, I think the first thing is to remember that as healthcare workers, we're also part of the general population as well. And so when we look at the breakdown of those people who are, full vaccine acceptors versus people who are on the other end, vaccine refusers versus more in the middle, the vaccine hesitant, the percentages are going to roughly mirror what you see in the general population. So I think that's one important thing to keep in mind. And then thinking about those factors that we discussed in terms of what drives hesitancy, so the things like the confidence and convenience and things like that. So there are things that are already in place that I think could continue to be built upon. So making it as easy as possible for busy healthcare workers to get their influenza and COVID immunizations, obviously for flu vaccine, like we have roaming carts and stuff around the wards, but just breaking down the barriers and keeping it as easy as possible. Things like incentives, financial incentives or otherwise, when those have been looked at in the general population, so like for COVID example, some big states in the United States looked at big Powerball lottery systems. Those were not shown to result in any significant uptake in vaccine. So I don't think that would necessarily be of benefit in the healthcare worker setting. Of course, there are mandates, employment mandates that can be put in place. That's not universal across the board, whether you're talking about jurisdiction or particular products. I think my own personal view, what I think would really be a good idea to do would be, in some states, for example, or actually Ontario is a good example, for required vaccines for school attendance, if you choose to claim an exemption, those can be granted, but you have to meet with a public health professional, nurse, et cetera, and have an informed discussion about why you are going through with the request for that exemption. And in a certain percentage of cases, that can result in actually people moving into the vaccine acceptance, because those interviews are also driven through motivational interviewing. Perhaps there's a lack of awareness about some aspect of the disease or vaccine. So I think I would like to see that for healthcare worker vaccine immunization, say for things like influenza or hepatitis B, and also to make those as easily accessible for healthcare workers.
Thank you. There's another great question, and one that is embroiled in great controversy, that basically reads, how is it that we can require people to get vaccinated for hepatitis B, et cetera, for employment and healthcare, but the same is not expected for COVID or influenza? There isn't an easy answer for that one. And what I'll say to Laura Campbell, who asked the question, was stay tuned. There may be movement in that direction. I think the critical thing is, if there are vaccines that provide benefit, and when you look at the graphs that I think it was Jared Bullard showed about COVID disease in the immunized, or the benefit of the COVID vaccine, there was clear benefit. So we're moving in that direction. I don't have an answer for you now, and I don't think anybody has an answer for you, but there is movement in that direction. Any last comments, Dr. Finella, given the importance of vaccination as a primary preventative strategy for adults and children?
No, I mean, just to build on what you said, I mean, going back to as early as, medical school for us, we had to demonstrate immunity to a wide range of different infectious agents. Those things like that have been in place for many decades.
Well, a great session. Thank you for all the panelists, and we'll now have a 15-minute break. We're in the home stretch. We'll see you back at 3 o'clock. A few housekeeping things. Please make sure you've registered online. Please use the Slido app, and that's Slido, S-I-D-O, and the code to enter is hashtag BUG, B-U-G, all in capital, 2022. For those of you who require certificates for proof of completion of this continuing professional development event, you must register and you must verify your attendance using the Slido app. So we're now in the home stretch. I'd like to introduce Dr. Lauren McKenzie, who is a specialist in infectious diseases and who has a specific interest in infection in care and research in infection in those who have infection with the human immunodeficiency virus. Lauren is the associate director of the Manitoba Human Immunodeficiency Virus Program. Lauren's presentation is entitled Pre-Exposure Prophylaxis for HIV Prevention, What You Need to Know. The floor is yours.
Perfect. Thanks so much, Dr. Embel. I'm really excited to have the opportunity to share a little bit about pre-exposure prophylaxis for HIV prevention, because I think it's a topic that not everybody has heard about, and I think it's relevant to a really wide audience today. So the learning objectives that I'd like to cover today are to recognize individuals in Manitoba that may benefit from pre-exposure prophylaxis or PrEP, to understand how PrEP can be accessed for interested and eligible people at high and ongoing risk for HIV infection, and to understand the basics of clinical monitoring for individuals using PrEP. And we won't be able to go into all the details today, but I think we'll be able to cover some of the major points of clinical monitoring. So to start with, I wanted to give us a picture of where we're at for HIV diagnoses in Canada, and specifically in our home province of Manitoba. So this is the most recent federal data from 2020, looking at new diagnoses of HIV. And you can see here in Manitoba that we really have quite a high rate compared to the rest of the country for new HIV diagnoses. So we're sitting at about 7 per 100,000 population, which is almost double the national rate, and second only to Saskatchewan. The Manitoba HIV program will be releasing a report on December 1st, which is World AIDS Day, to update what our 2021 data is showing. And a big part of that data was actually from one of our earlier presenters, Dr. Rueda, who gave our grand rounds this morning. So our HIV program has put out some prevention guidelines that I wanted to highlight. They can be accessed from the Manitoba HIV program website, and the address is at the bottom right of my slides there. And the point I wanted to emphasize here is that HIV prevention is really multifactorial. It's not just one approach, it's kind of a toolkit of approaches that we can use. And some of these things include routine testing for HIV and other sexually transmitted and bloodborne infections, encouraging clients and patients about consistent and correct use of internal and external condoms, thinking about harm reduction for people who inject drugs, using post-exposure prophylaxis or PEP for people who have had HIV exposures. Of course, antiretroviral therapy for people who are living with HIV, and this concept is treatment as prevention. And then doing everything we can to prevent mother-to-child transmission of HIV. And finally, of course, the topic of the 15 minutes today is PrEP, or pre-exposure prophylaxis, so part of our toolkit in HIV prevention. So what exactly is PrEP? So PrEP is the use of specific anti-HIV medications that we refer to as antiretrovirals. And in PrEP, these are used in HIV-negative people who are at high and ongoing risk for acquiring HIV. Now, there's multiple forms of PrEP, but typically when we're talking about PrEP, we're referring to the combination of two specific antiretroviral medications. And those are tenofovir disoproxil fumarate, which you'll see abbreviated as TDF, and emtricitabine, which you'll see abbreviated as FTC. And together, this combination is in a 1-tablet pill, abbreviated as TDF-FTC. You may have also heard of it under its brand name of Truvada. And importantly, this medication has been around for a long time. We have a lot of experience in terms of safety and tolerability with this medication for people living with HIV. It's been around since 2004, and specifically for its indication as pre-exposure prophylaxis, it was approved by the FDA in July 2012. It was approved by Health Canada for PrEP in February of 2016, and thankfully, we now have a generic form that's been available since 2017. I want to highlight that PrEP is not the same as PEP. These two abbreviations can sound pretty similar. So PrEP, or pre-exposure prophylaxis, is specifically used for people before they've been exposed to HIV. Whereas PEP, or post-exposure prophylaxis, is for use after someone's been exposed to HIV. So how does PrEP work? Well, by taking PrEP, people are able to accumulate antiretroviral medication in their mucosal tissues prior to HIV exposure. And specifically, when we talk about tenofovir, or TDF, and emtricitabine, or FTC, these are both part of a class of medications called nucleoside reverse transcriptase inhibitors. And essentially how these work is they are able to block HIV replication using competitive inhibition. Now, in Manitoba, TDF-FTC PrEP is a 1-tablet, once-a-day medication that people are now eligible for coverage for under pharmacare, and that's been active since October 22nd, 2021. So almost exactly a year. And it has coverage under pharmacare under EDS Part 2, meaning that people need to be shown to be eligible for PrEP. So first I wanted to mention about the effectiveness of PrEP. So does it actually work? Well, we have a lot of data supporting that PrEP is very effective if you take it. So the effectiveness of PrEP is very much linked to adherence. So I like this graph because it shows us these little colorful dots here are representative of just some of the randomized controlled trials and cohort studies that have been done looking at the effectiveness of PrEP. And on the y-axis here, you can see effectiveness going up to 100%. And on the x-axis, you can see a percentage of participants in these trials that had samples with detectable drug levels, meaning we knew for sure they were definitely taking their PrEP. And you can see this nice linear relationship approaching 100%. So meaning that for populations that are definitely taking their PrEP, it's a really effective medication. So for gay and bisexual men who have sex with men, we have data supporting that PrEP is close to 100% effective. And in heterosexual people, we have data showing that it's around 95% effective at preventing HIV acquisition. So PrEP is highly effective at reducing the risk of HIV when it's used consistently and correctly. Now, who's eligible for PrEP in Manitoba? So currently we have these kind of 3 major criteria. So people have to either be enrolled in pharmacare or have active EIA coverage and be HIV negative and meet criteria in one of 3 groups at high and ongoing risk for HIV. And these 3 groups are MSM, men who have sex with men, trans women and gender diverse people, people who inject drugs, and heterosexual people may all be eligible for PrEP. So going a little bit more into the details of eligibility for PrEP, the guidelines that I'll tell you about have some more details, but essentially this is the general eligibility for PrEP in Manitoba. So looking at our first group, men who have sex with men, transgender women, and gender diverse people. So if someone in that group has had condomless anal sex within the last 6 months and any of the following, they could be eligible for PrEP. So syphilis or a bacterial sexually transmitted infection in the past 12 months, previous use of non-occupational HIV post-exposure prophylaxis, that PEP that I mentioned earlier, more than once, if they're in an ongoing sexual relationship with an HIV positive partner with a risk of transmissible HIV, or there's a risk index called the HERE MSM risk score that is linked in our guidelines. It can help care providers determine if someone might be at a higher risk for acquiring HIV and could benefit from PrEP. For people who inject drugs, if they have a history of ongoing sharing of injection drug use paraphernalia with a person with a non-negligible risk of HIV infection, they may be eligible. And again, for this population, there's also a risk tool called the ARCH-IDU Risk Index that can be used to help clinicians determine whether someone might be at a higher risk for acquiring HIV. And for heterosexual people, they could be eligible for PrEP if they have ongoing exposure to HIV positive partners involving condomless vaginal or anal sex, where the HIV positive partner has a risk of having transmissible HIV. So in terms of the general overview of a PrEP care flow, the first step, of course, is to confirm eligibility for PrEP. And then the provider goes on to provide a baseline evaluation. And some of what that will include is a baseline HIV test that we do at CADM, so not a point of care test, but a CADM HIV test. Screening for STBBIs, including syphilis, gonorrhea, chlamydia, and hepatitis C, and screening for hepatitis A and B, and offering vaccination if someone's not immune, and some basic baseline lab work, including a creatinine, urinalysis, CBC, and a pregnancy test if relevant. And then if someone is eligible and ready to start PrEP, that typically happens within 2 weeks because we want to make sure they definitely have a negative HIV test before they start. We follow up with the individual about 1 month after starting to check in, see how they're doing with adherence, which, as I mentioned, is so important for the effectiveness of PrEP. To get another baseline HIV test, check the creatinine, and then people move on to regular 3-month follow-ups. And what's so important at these follow-ups is regular screening for STBBIs, because we know that people who have active sexually transmitted infections are at a higher risk for transmitting HIV. So it's so important to screen for these when people are using PrEP to decrease the risk of HIV transmission. And then people get regular creatinine screening, pregnancy screening if relevant, and annual screening for hepatitis B and C if relevant. And what's so important with this regular HIV testing at each visit is because antiretroviral drug resistance can develop if a person initiates or continues PrEP when they're already HIV positive. So regular HIV screening is a really important component of PrEP follow-up. So who can prescribe PrEP in Manitoba? Well, almost anyone. There is a few criteria for prescribers of HIV PrEP. So first, they need to register with the Manitoba HIV PrEP provider registration form. It's a really simple 1-page form that I'll show you. And then linked on that same form is a link to the eligibility criteria for Manitoba HIV PrEP, which providers need to indicate that they've reviewed, as well as a link to the Manitoba HIV program, HIV prevention guidelines, also linked on the registration form that providers need to indicate that they've reviewed, and that's it. So this is what the registration form looks like. It's really simple. Here's the checkbox indicating that a provider has reviewed the prevention guidelines and the eligibility criteria. Another checkbox indicating that they'll be following the patient as outlined in the guidelines. And then there's some boxes for contact information. And that's essentially it. It's a really low barrier registration form. So where can you find the registration form? Well, this is a snapshot of our Manitoba HIV program website. And you can see there's a little box for healthcare providers. So if you click on that, you'll come up with this host of pre-exposure prophylaxis resources. And at the bottom there, highlighted in green, is a link to the registration form. And if you've decided that you're interested in offering PrEP in your clinic, You can advertise your HIV prevention services, kind of promote them so that people looking for PrEP know of different clinics where they might be able to access it. So on our same HIV program website, we do have a services map where interested people could look for a PrEP provider. So that's the address to our services map. And if you wanted to add your clinic, there's a link where you can register your clinic with your information there. We also have another map linked on our website, and that's the Street Connections map, which shows people where they can access a variety of STI testing and HIV prevention services. And you can link your clinic information there to let people know that they can access PrEP as well. So if you wanted to be added to the Street Connections map, you could email hshr@outreach@wrha.md.ca, and people could find you via our website on the Street Connections website. I also wanted to emphasize that there's a variety of PrEP support and resources. So in addition to our Manitoba HIV program PrEP page that I referenced earlier, we also have an email address that you could access if you have general questions or inquiries about PrEP. And we also have some help available via e-consult. So we have clinicians and pharmacists at 9 Circles that you can access via e-consult to support people who are providing PrEP. And I wanted to take this opportunity to highlight some additional resources for those who were interested that are particularly relevant given one of our speakers earlier today, Dr. Tan, who spoke to us about monkeypox, is the lead author for the Canadian PrEP guidelines, which this is a picture of here. They're really accessible, I think, easy to understand guidelines, so I do highly recommend those. And then particularly timely, if you're a subscriber to our CMAJ journal, Dr. Tan was also part of an article that was the cover article for CMAJ outlining some additional thoughts on PrEP that I think is a really great accessible article as well. So I'd encourage you to check those out. So in conclusion, the number of HIV cases in our province has been dramatically increasing. And because of this, I think it's critical that we bring extra attention to HIV prevention efforts. PrEP is only one of the HIV prevention tools that we do have available, but it's a tool that's currently quite underutilized. So my hope today is that I've given you some useful information on PrEP so that you can maybe be more empowered to think about PrEP when you see patients or clients who might be eligible for PrEP. Can discuss it with them as an HIV prevention option, or even think about becoming an HIV PrEP prescriber yourself. And that's all I have for you today. Thank you so much.
Thank you. So don't go away. We'll be back to you in the question and answer session. So David Patrick from the University of British Columbia is joining us to present the pandemic acid test, what we've learned about how to improve the health research system. And as a matter of background, David is an infectious disease specialist at the University of British Columbia, and he is the director of research and the medical epidemiology lead for the antimicrobial resistance program at the British Columbia Centers for Disease Control, and of course a professor at the University of British Columbia School of Population and Public Health. Thank you, David.
Well, hello, Manitoba. It's good to see you. I have my screens down behind me for the benefit of any climate change deniers out there. We're more than 20 degrees and sunny well into the second half of October, so something is probably happening. I appreciated Lauren's talk. I think the community engagement that has happened with HIV PrEP and with syphilis control is actually helping monkeypox control in Canada. And that's the untold story. It's not just the pharmacotherapy, it's the community engagement that's happened there. The talk I would have really liked to give today is one you should ask Megan Azad to give instead. And I would call that Asthma and Antibiotics Part 2. The Revenge of Breastfeeding. So look that up because there's a fascinating follow-up on that story we talked about a couple of years ago. This talk instead is focusing on sort of our meta experience with research in BC and in Canada. And it'd be really interesting to compare notes with you about your own, about how the healthcare system was ready or not ready to deal with urgent pandemic research. is clicking ahead. So how it all began, we all remember that we began to hear about things around New Year's Eve. For me, it's always, I hear from Danuta Skowronski, my colleague. She's always giving me a few days notice on what anybody else is saying on the planet. You had an emergency committee at WHO saying it wasn't yet a public health emergency, but that changed very quickly because we were confirming our first cases on January 25th. We had another one in BC not long after that. And of course, we had the fully named, coronavirus thing in early 2020. So that was the beginning. And we've all lived through 2.5 years of this pandemic now. And basically, we've also seen over the course of 2022, the gradual lifting of public health measures at the same time as we've seen a fairly improved uptake of immunization in the population, trying to keep pace with a change in variants that were escaping immunization to a certain degree, but not necessarily escaping a reduction in morbidity. So we've been through all that together. And it's interesting then to sort of look back. This was like towards the end of 2021. What was the cumulative COVID-19 death rate per million population in different countries in the world? And you could see how dramatically different it was from between New Zealand and places like the United States and Brazil. And what was weird about that was that if you put this beside how people were ranked for global health security prior to the pandemic in terms of their resources, their preparedness, all that kind of thing, the US and the UK looked like they were ready to go, but they didn't perform as well as some other countries in the world. And you take that to Scandinavia, and we've got these two countries side by side, Norway and Sweden. And basically, we see good standards of living in both these countries, usually sensible public policy, high investment in both the healthcare sector and in public health prevention, and relatively low population density. But you know the story that when we take a look at the rate of morbidity over population, the COVID-related deaths was 12 times higher in Sweden than it was in Norway, at least up to a point in the pandemic. And we know that was due to policy decisions. And so we know that those were relatively important. So that begs the question, what accounts really for these differences in health impact of COVID-19 in different countries? And we might well ask in North America, in different provinces and in different states. And so if you really think about it, there's a lot of things that are at play. One might be geography. It was a lot easier for a place like New Zealand to be isolated than a city like Winnipeg to be isolated when you're sitting smack dab at the hub of a continent. Demographically speaking, some demographics played very much into the burden of illness. You remember the real hard hit that Lombardy got in Italy. There you had a lot of older retired people. So you had people who were more vulnerable to begin with, but they were living in relatively crowded extended family settings as well. So it was a good setup for transmission. And demographics will play out in different ways around the world, both in terms of who remains vulnerable and in terms of how countries appeared to deal with mortality. Resources are important. We know that in Canada, we were challenged early on because we had sort of a lower vent rate per capita than some other countries in the rich world. But our governments did a pretty good job of procurement, and I think our policies managed to help the hospitals just cope. But clearly, that's just one example. The availability of resources makes a big difference on overall health impact. Culture was huge. And so obviously we've seen cultures around the globe that have been much more prepared to extend public health measures for a long time. We have the extreme case today of the People's Republic of China spending huge amounts of money and inconveniencing tens of millions of people to try and continue a COVID zero policy. And on the other end, we've seen many places where we sort of let it rip. And that is determined by political culture and by pre-existing ethnocultural and national cultures. Preparedness is important. I mean, I think Manitoba probably had a pandemic preparedness plan. We had one here, but as soon as an actual pandemic comes in, you've got to be prepared to improvise pretty quickly. But a degree of preparedness was important because it meant that we were ready to set up emergency operations centers. We had pathways to garner additional resources and that sort of thing. And where that was lacking, responses sometimes struggle. Politics is huge. I mean, just look across our country at the differences in response by political culture in different provinces. We had a very different set of responses compared to our neighbors just over the Rockies in the West here. And we saw lots of difference by province. But that paled by comparison with what we saw under a mega United States administration that was quite prepared to ignore some of the facts because it was inconvenient. And the same sort of thing played out in Brazil. But then what about research? I mean, we're all involved in academic healthcare and public health initiatives. So what differences did research make? And it's important to talk about that and whether it was optimized. So what role did research play in the pandemic response? Well, let's think about it. I mean, there were some people very favorably impressed. The crucible of COVID-19, what the pandemic is teaching us about health research systems. It turns out that when the going gets tough, researchers get productive, collaborative, and impact focused. And I know a lot of my colleagues there were heavily involved in just that kind of deep collaborative focus. Research in the time of a pandemic, research has never moved faster, some people would say. But on the other side of the ledger, we've got people saying we had a deluge of poor quality research and it's sabotaging effective evidence-based response. And that's not so much just about research, but about science communication and how it can be warped by social media algorithms in particular. And also, I think this was the key one for me, this Mulligan statement, that there's a striking imbalance between the scientific advice available and the capacity to make sense of it. And when we think about it, we do a lot as researchers to come up with answers, but how is that synthesized? How is it delivered to policymakers, and how is it taken up? And we almost have to make sure that there are knowledge synthesis brokers working very closely with senior people in our ministries and provincial health officers' offices so that they can actually channel right into the deep roots in academia that are able to do primary knowledge generation and knowledge synthesis. So lessons for the future. There's a paper that has been published now by the Royal Society of Canada, and it drew some of these conclusions about the global research response. Coordination of research is most effective alongside very clear priority setting. So that means agreed upon priorities by funders, researchers, and policymakers. That it's alongside data and other approvals so that there's a quick movement of data and approvals, and that it's well evaluated. The unprecedented funding, hundreds of millions and more by far, was shoveled into this, but even in Canada, if you take a look at it, it was uneven. There was some duplication and waste. We had some overlap between what CIHR was doing, what the immunity initiatives were doing, and what regional funders were doing. The other thing is that, and I'm interested in hearing about how it went at your hospitals, but the idea that research and healthcare should be integrated in peacetime so that it's relatively easy to stand up new studies during a pandemic is really important. And we've had different cultures in health authorities. Some have said, hey, research is somebody else's job. That belongs at the university. We're just involved in delivering service, and we're not necessarily going to do anything to sort of roll out the red carpet to move research along. And yet, the absence of innovative research and fresh answers definitely is a determinant of poor healthcare under stressed circumstances. The use of evidence in policy depended on structures and cultures. So quite apart from how the system worked to develop evidence, the structures and culture we've mentioned, the political cultures, for example, certainly affected the way in which that was used. And then pulling back from just how did the things work for COVID, how did the health research system get hit? I mean, we're an infectious disease group talking here, so this was a bonanza for us for the most part. There was a lot of extra research funding, but at the same time, there were hundreds of millions pulled away from other things. And we have many hundreds of early and mid-career researchers in other health areas and other areas who were basically sitting dormant for a couple of years. So it's real damage to the health research system. And as I mentioned before, the idea that hydroxychloroquine stories can rise to the top when the evidence isn't all that good really means that we have to think about social media algorithms as a determinant of health, and that goes beyond health into the way in which politics is playing out around the world today too. A couple of key lessons that we've had in British Columbia itself. We've had some good provincial coordination, lots of collegial efforts between people who would have never worked together before. We leveraged existing infrastructure, lots of successful grant applications, and in areas where there was pre-existing strength, there was some international leadership shown. Patients were engaged and things made a difference. But let me tell you a couple of stories about what didn't go well. We had one PI who had, it was a PI for a pan-Canadian study, about 15 sites. That ethics harmonization in BC worked like a house on fire. Ethics review happened really quickly. But then we got down to organizational reviews by our various regional health authorities, of which we have 5 plus a First Nations health authority. And that held up a 12-month grant by 4 months. Not functioning as a research system, functioning as very much 6 separate health service delivery fiefdoms that didn't give a hoot about research. So room for improvement there. We had similar problems with getting data amalgamated, and this was even when we were pulling together cohorts to take a look at the COVID immunized and the COVID experienced and their subsequent experience of healthcare and other critical stuff to pull this together. We had the usual folks in the health authorities whose job is often to protect privacy more than it is to achieve the value in data, not really ready to move very quickly. So room for improvement on pulling data together. And it's important to say that wasn't the global experience. The UK can't teach us too much about the actual response, but they can about conducting research in a hurry. This is Rowan Atkinson, of course, as Chief of Staff of the National Health Service. But basically, you know the story with recovery. They built that trial before they needed it, so it was ready to go when they did. They had research embedded across dozens of hospital sites around the country, 1 ethics review, integrated funding with the NIHR, and from trigger to start, the recovery trial was off in 10 days. And you know that gave us our first useful clinical information about dexamethasone, was the first to falsify hydroxychloroquine and a number of other things. And those were implemented into care. That's the way health research should work in Canada and around the world. We were able to sort of develop various different approaches to priority in these different framework documents with the Strategic Research Advisory Committee that I co-chaired. But connecting that to funding is still something that we really need to do. If you want to sort of have a strategic direction for research, there has to be a direct connection to funding to give the policies teeth. And of course, we had some successes getting our regional funders like Genome BC and Michael Smith Foundation to work together on the same RFPs. But that only happened a little bit after. And we still had trouble coordinating with CIHR around priorities. So some coordination, room for improvement there. And finally, I think I've spoken about the importance of integrating research into care and making sure that our healthcare system is also a health research system. The need is very clear, the evidence is growing, and that's very important for us. So just to sort of finish up, as I'm keeping an eye on the time here, we definitely do want to make sure that our knowledge synthesis and translation directly goes to healthcare workers and that sort of thing. But we've got a few things we're following up in BC. Now we're working closely with the ministry and the CEOs of the health authority to make sure that the philosophy of research is care is adopted by health authorities and that we streamline research in those environments. We also want to get the universities to work more closely with the health authorities to help provide better research capacity, not just at our urban teaching hospitals, but at any sizable facility, so that we can function as an entire system. And then nationally, a number of you will have been on these conversations. We're talking about functioning nationally as a more unified country that can put together multi-center trials for pandemics and other things. So with that, I'll just say that there's an awful lot to be learned. I'm interested in hearing about what your experiences are, and I should cede the mic because we have another talk this session from what I understand.
Thank you very much. Stay tuned. And the final presentation is Supervised Injection Spaces, Why Manitoba Needs Some, presented by Pierre Plord. And Pierre is no stranger to BugDay. Pierre is a medical officer of health with the Winnipeg Regional Health Authority, and Pierre is a professor in the Department of Community Health Sciences and the Department of Medical Microbiology and Infectious Diseases with the Max Rady College of Medicine. Pierre.
Great, thank you very much, Dr. Embel. So we're ending the day on supervised consumption spaces, a safe, non-controversial topic. Why Manitoba needs some, and we actually have our previous speaker from Vancouver probably scratching his head and wondering, why doesn't Manitoba have supervised consumption spaces? We have several in BC. And I'll tell you that story because my story does start in British Columbia. But just to begin with, I will declare that I have no significant conflicts of interest to declare. So about 5 years ago, we were alerted by the BC coroner to the fentanyl fueled rapid rise in overdose deaths that was occurring out in British Columbia. But this crisis, which had its origins in British Columbia, did not remain confined to that province. It has subsequently, as many of you know, spread eastward. And this is recent data from the Public Health Agency of Canada, showing nicely in the pre-pandemic period that in subsequent years, 2016, after the BC coroner's alert, 2017 and 2018, that fentanyl-fueled opioid toxicity, so it doesn't say on here that it's fentanyl, but these are mostly fentanyl-fueled opioid toxicity overdose deaths, became an escalating problem in British Columbia and Alberta, but it appeared to be relatively stable and less of a problem in Manitoba through those pre-pandemic years, and actually leading some to suggest, because Manitoba did not seem to have the same kind of an opioid overdose crisis as was being seen in British Columbia and even Alberta, we really didn't need supervised consumption services, at least at the time. But subsequently, through the pandemic, we have seen a significant rise in opioid-related and fentanyl-fueled overdose deaths throughout the prairie provinces now, moving eastward, as you can see in Manitoba, to rapid increases in 2020 and 2021. And there appears to be, I don't know what to make of this, a decreasing west to east gradient. As you go from west to east, the rate of overdose opioid toxicity death seems to go down, suggesting that the origins of fentanyl, and we know this anecdotally, that the illicit market of fentanyl likely has originated in British Columbia and is making its way eastward and has yet to have a significant impact in Eastern Canada, for example. Now, it's not just an issue of overdose deaths due to opioids, but similarly, stimulant-related overdose deaths, mostly probably due to crystal meth, have dramatically increased during the COVID-19 pandemic, also appearing to show a west to east gradient, possibly suggesting again sources of crystal meth coming from the Pacific side of Canada. But as you can see with stimulant-related overdose deaths rapidly rising in Manitoba, in fact, approaching opioid-related death rates. So all this has led to some media attention, and this publication in the Winnipeg Free Press, quoting from the Medical Chief Examiner's Office, reporting 200 overdose deaths in 2019, followed by a doubling, almost 372 deaths in 2020 and 407 deaths in 2021, which is essentially a doubling of deaths due to overdoses in Manitoba compared to before the pandemic. And we are seeing rates in 2022 that are going to likely surpass 2021. And this mother of someone who died of a drug overdose, Arlene Lastcobe, has essentially said that with deaths increasing each year, it's long past the time for laying out plans. It's time for action. It's everybody's responsibility to do more. She says, these are preventable deaths and we have to do better. And I agree with her. And beyond overdose deaths, we are also seeing an alarming preventable tragedy unfolding in Manitoba that started at the beginning of the pandemic, sometime in 2020 through 2021, and has really escalated in 2022. And that is essentially an outbreak throughout this province of HIV infections, which is being fueled mostly by injection substance use. 70% of newly diagnosed people who have HIV in Manitoba in 2022 were reported to be individuals who inject substances, mostly younger women aged 20 to 49, and many of whom, upwards to 70%, according to the Manitoba HIV program, self-identify as Indigenous. And so I don't have time to get into the details of harm reduction. Harm reduction is by no means a new concept. It's a perspective that focuses on reducing adverse health, social, and economic consequences of psychoactive drug use through non-judgmental policies, programs, and practices. And its principles are well articulated in the WRHA position statement on harm reduction, which was published back in 2016, and I have a link to it here. That statement includes what I've listed here, several harm reduction approaches, including safer drug consumption spaces, as critical as key approaches with respect to reducing harms associated with substance use, so clearly articulated by the WRHA. Now, supervised consumption is one of many key harm reduction approaches and interventions that work synergistically. So it's not just a matter of let's put up a supervised consumption space and that's the end of it. To be successful, a supervised consumption service should never be a standalone service, but it needs to be surrounded by wraparound services, some of which are listed here under policies, programs, and practices, including safer use supplies, needles and syringes, safe drug supplies, naloxone distribution, drug checking services, opioid replacement therapy, access to housing, mental health supports, rehabilitation services, and culturally safe primary care. So again, I'm focusing on supervised consumption spaces, but they are not and should not be a standalone operation, which means significant resources need to be put into developing appropriate and effective supervised consumption services. Again, I'm not going to review, in the interest of time, the extensive body of evidence. This is an Alberta supervised consumption website, SafeWorks Harm Reduction Program, and it lists supervised consumption services as being evidence-based. And I want to clearly and unequivocally express the overwhelming data on the effectiveness of such harm reduction services like supervised consumption services. The jury is not out deliberating. The jury has finished and rendered its verdict. For the last 2 decades, we've seen that supervised consumption services are solidly supported by evidence of effectiveness in various respects preventing HIV and hepatitis C infections, preventing, pretty well eliminating overdose deaths, preventing costly use of ambulance services and emergency rooms for overdoses, enhancing public safety, reducing crime in neighborhoods that are immediately surrounding supervised consumption facilities, and reducing debris and discarded needles in those neighborhoods as well. So this evidence is likely the reason why every Western province in Canada, excepting Manitoba, delivers supervised consumption services. So one has to ask the question, why is Manitoba the last to offer supervised consumption services? And I'm glad to see that some politicians have begun to ask the same question. In this case, Sherry Rollins, a Winnipeg City Councillor, has begun to ask this question and is speaking up, noticing the absence of some critical, appropriate harm reduction services in Manitoba. Winnipeg's mayor has even weighed in and has himself expressed that he would like to see less ideological scrutiny, to quote him in this article, on these issues, and more openness to the science around the evidence that definitely demonstrates the life-saving and cost-saving outcomes of supervised consumption services. And now we have, last April, a provincial MLA, Bernadette Smith, who's added her voice to the discussion. And in response to Bernadette Smith, the Provincial Minister of Mental Health and Community Wellness, Sarah Guillemard, has expressed, as quoted in this article, her openness to considering safe consumption sites. But that was back in April. So I'm looking forward to timely, concrete action and proceeding with supervised consumption services in our provinces. And more recently, we have a mayoral election coming up in a couple of weeks. Even our municipal election has entertained the topic of supervised consumption services. And you can go on the website of all the mayoral candidates and find out which ones support supervised consumptions and which ones are silent on it. It's quite clear. In this article, a Bear Clan volunteer who has witnessed the reality of dangerous drug injection practices on the streets of Winnipeg says he is looking forward to voting for a mayoral candidate who understands the science, isn't looking for any more evidence, and has empathy and the courage to follow through with creating supervised consumption services in Winnipeg. So I hope that supervised consumption will continue to be discussed in future provincial and municipal election campaigns. So where does that leave us? The Canadian Medical Association has identified in its COVID-19 pandemic recovery plan for Canada, expanding access to supervised consumption services as one of its highest priorities. The Manitoba Harm Reduction Network has made it quite clear that supervised consumption services are one of its highest priorities to help Manitobans with problematic substance use. And so I'd like to conclude with a very stark observation that I've alluded to earlier. We remain the sole province in all of Western and Central Canada, from Quebec westwards, with no supervised consumption services, not even one. I find that this very unsettling, this reality, given the demographics of drug harms in this province that has been shown in my previous slides. And we will see more of this on World AIDS Day this year on December 1st, when Manitoba HIV program will present data showing significant disparities in the harms from HIV currently in this province towards Indigenous populations, that I feel the denial of access to important harm reduction services like supervised consumption, proven to prevent HIV and hepatitis C infections and overdose deaths, can be considered as another form of colonial violence against Indigenous persons. So this does leave me asking the question, what is holding Manitoba back? And the WRHA's harm reduction position statement clearly supports the need for supervised consumption services. Public Health Agency of Canada strongly endorses such services, and there are over 36 such services already operating in Central and Western Canada, with several more on the way, as you can see under current applicants to the Government of Canada. So we really don't need more data. that supervised consumption services saves lives and saves costs to our healthcare system. So I hope I made it clear why Manitoba needs supervised substance consumption spaces. And I want to leave you with a quote. I'm going to quote myself actually. 15 years ago, on November 5th, 2007, I published an op-ed, an editorial that I wrote was published in the Winnipeg Free Press titled "Lifeline Between Prevention and Treatment." I actually didn't, it's the editor who came up with this title, and I thought this was brilliant. And what applied 15 years ago still applies today. And I'll just quote what I said in this editorial, that supervised consumption spaces simply provide a humane gesture from one human being to another when enforcement, prevention, and treatment have not worked. And supervised consumption spaces provide a bridge toward treatment. So again, thank you for your attention, and I look forward to questions.
Fantastic. Well, thank you very much for the three speakers. So I'll begin with a load of questions for Lauren McKenzie. Clearly, there was a lot of interest in pre-exposure prophylaxis. So, and I don't know if this is a question you can answer, but what is the cost of pre-exposure prophylaxis if not covered by the government?
Absolutely. So PrEP per month costs about $250 a month. And so right now, while PrEP is covered under pharmacare, people first have to meet their deductible. So that is a potential barrier for PrEP there, although it is covered for people who are on EIA, but otherwise $250 a month roughly is the answer.
And does the PrEP have to be taken every day, or is it taken in anticipation of?
Yeah, that's a great question. So there's actually a prominent trial called the BugDay trial that looked at PrEP on demand. And so I won't get into the details here, but there is some evidence to support PrEP on demand. However, for Manitoba coverage of PrEP, it's not covered as on-demand PrEP, it's covered as daily PrEP. So that's one tab once per day. And essentially people take the PrEP for as long as they're considered to be at high and ongoing risk for HIV acquisition. And so that's one of the reasons why it's so important to have regular follow-up with people who are on PrEP, because it's something that needs to be evaluated at each visit.
Thank you. So for David, the times of crisis, such as Second World War, the COVID pandemic, moved technology and moved thinking rapidly. The question for you is, what do we need to do in a time of calm to move forward with an integrated health research system?
I've thought about that a lot, and so it depends on whose perspective you're looking at. But say you're a researcher wanting to get the most out of Manitoba, I'd say you want to make sure you've got this seamless relationship with the health authorities, some embedded research coordination personnel that are ready to work with your usual suspects as PIs, and that you're well networked in a Canadian network as currently being supported by the CIHR. So that's preparedness for clinical research. I would say the big need, given all the decisions that needed to be made about funding and policy and public measures, is that we need to sort of think carefully about our evidence synthesis apparatus and how that's plugged into decision making. And I know that sounds kind of dull, but we don't have too many places that have evidence synthesis experts supported by librarians ready to work with your content experts, and then a common brokering system to work with your PHO and politicians. And you only have to do that once, and we can actually share that kind of resource across the country as well, because it's a global literature we're working off of. It's rarely just a Winnipeg or a Vancouver specific set of circumstances. So I think I would say readiness to do clinical trials in a hurry, clear away the obstacles for ethics and funding and stuff, and really think about how our peacetime evidence synthesis, the same people who could be working on climate change mitigation and other things that are AMR, other things that are moving at a slower pace, they have the same skills to at least support the content experts in good knowledge synthesis.
Thank you. No, so Pierre, two almost identical questions. And basically, it's a foregone conclusion from your comments from 15 years ago that safe consumption sites are necessary. What is the additional step to move this forward? I think the concept is accepted. So how do we move it from a concept to a reality? Or what do you think we need to do? Or is that too politically charged a question?
Oh, it will always remain a very politically charged question. There's a lot of ideology around harm reduction, and if you believe in it, you know, you're passionate about it. But if it rubs against you, or if you have issues with it, you're equally passionate against it. So that's not going to go away. But as is suggested by one of the questions here, supervised consumption facilities in other jurisdictions, including the original ones in BC, did not have strong political support. That slowly grew over time. And it required an awful lot of work and an awful lot of private partnerships that eventually became private-public partnerships. And so there's only one single supervised injection facility in Saskatchewan. It likely operates with little to no provincial government support, but likely has some federal government support. But in the past, we had little to no federal government support and more provincial support potentially. So that will ebb and flow over time. And when people ask me, what can we do? I basically reflect the question back to them. I can't be alone advocating for this. I need everybody, all of us need to be communicating with our MLAs, and during election time, making this an election issue, as is a little bit right now in the municipal election. We have a provincial election coming up within the next year or two, and we just have to get this onto the agenda and make candidates declare where they stand on this, and make this more of a public discussion, so that people who are running for election will see that they need to give harm reduction serious consideration to on their platforms.
Thank you. One last question for Lauren McKenzie. There's a great deal of homelessness. How can we integrate PrEP into the homeless population, or is that just wishful thinking?
I don't think it's wishful thinking, but it certainly is a huge challenge. Other jurisdictions have looked at tools, including medication lockers, so that people have a safe space to keep their medications if they don't have access to, a home or someplace safe that they can store things. But certainly, I think that is one of the barriers to implementing PrEP in people who definitely could benefit from it. There's a whole host of other social determinants of health that are impacting their risk for HIV that are very difficult for the health system to tackle. But some things that have been tried include medication lockers, so people have a safe space to keep their medications.
Thank you. With that, we will end unless there are any other additional questions.
I just had one thing to share with Pierre.
Please.
Currently at UBC campus attending BC Health Officers Council of Public Health meeting. And we were just looking at alcohol statistics with the pandemic, and consumption's up 10 or 15% with the pandemic. So it's interesting to see other substances and the use of substances in general as a means of coping or as a sign of stress or what have you.
Yep, not a surprise at all. Thank you for that.
Well, with that, we'll end, and we'll see you again next year. Thank you all very much.
Thank you, Dr. Embel.